I've been given the task to talk on the introduction of artificial intelligence and its current world scenario. So, on this topic, basically, I have prepared a few slides, ending with a small 2 minutes video. So, I like to share my slides with all of you and then start my presentation. Is my slide visible? Can anyone respond? Is my slide visible?
Yeah, your slide is visible, sir.
Thank you so much. So the slide, as it is, I'll be talking on the introduction to artificial intelligence. Is my slide changing? I am on the second slide. Can someone respond? Hello? Is my slide changing?
The slide is changing, sir. You are correct.
Slide is changing.
Yeah, so I just wanted to reconfirm because although we have marched ahead a lot on this online presentation and technology, but sometimes there are glitches. So it's better to confirm before actually proceeding. So as far as the introduction is concerned, in very simple terms, artificial intelligence is the science and engineering of creating intelligent machines. Okay, we all know this. And what we are trying to do as far as this technology is concerned, we are trying to mimic or duplicate some of the functions of human beings. Okay, that has been the actually objective right from the days we started creating machines. That machines actually try to duplicate or do some of the functions which human beings do and try to make life simpler. So it is not something new, artificial intelligence. We are just moving ahead with a little more technology to make machines a little more smarter so that some of the functions that we were still doing, we will delegate it to the machines. Okay. So in my next slide, the central principles behind artificial intelligence. So what are the basic technologies or the principles, not exactly technologies, okay, which are used to make machines intelligent. And I have listed here some of them, some of the important ones. There are, of course, several others which can be listed here, but the important ones are we are trying to give actually ability to the machines to reason. And basically, reasoning has not been there too much till now in computers and electronic devices and machines. So, what we are trying to do is create reasoning capability in the machine so that they can actually make some decisions based on that and maybe suggest some further course of actions to human beings. Now, this reasoning is based on some of the knowledge which the machine should have, and this knowledge is based on data acquisition. Okay, the machines are made capable to acquire data or they are fed with data, and the data actually is organized in such a way that it becomes knowledge. There is slight difference between data and knowledge, okay, in computer science. So properly organized data so that it can be used, okay, to make some inferences or for reasoning is basically what is knowledge. So converting acquisition of data and conversion of data into knowledge is another technology that is going in artificial intelligence. The third one is basically planning to make some inferences or for reasoning is basically what is knowledge. So converting acquisition of data and conversion of data into knowledge is another technology that is going in artificial intelligence. The third one is basically planning to make some inferences or for reasoning is basically what is knowledge. So converting acquisition of data and conversion of data into knowledge is another technology that is going in artificial intelligence. The third one is basically planning to make some inferences or for reasoning is basically what is knowledge. So converting acquisition of data and conversion of data into knowledge is another technology that is going in artificial intelligence. The third one is basically planning to make some inferences or for reasoning is basically what is knowledge. So converting acquisition of data and conversion of data into knowledge is another technology that is going in artificial intelligence. Third one is basically planning to make some inferences or for reasoning is knowledge. So there is a problem in the presentation. It is repeating my is another technology that is going in artificial intelligence. Third one is basically planning to make some inferences or for reasoning is knowledge. So there is a problem in the presentation. It is repeating my own. Is another technology that is going in artificial intelligence. Third one is basically
I
planning
think we have problem with the audio. Can somebody see that volume?
knowledge.
Sorry to interrupt,
There
sir.
is a problem in the presentation. It is repeating my own. Is another technology that is going in artificial intelligence. Third one is basically
I
planning
think we have problem with the audio. Can somebody see that volume?
knowledge.
Sorry to interrupt,
There
sir.
is a problem in the presentation. It is repeating my own. Is another technology that is going in artificial intelligence. Third one is basically
I think we have problem with the audio. Can somebody see that volume? Sorry to interrupt,
there
sir.
is a problem in the presentation. It is repeating my own.
I think we have problem with the audio. Can somebody see that volume? Sorry to interrupt, sir.
There is a problem in the presentation. It is repeating my own. Okay, I'm sorry, there was some technology problem. Am I audible? Hello, can someone respond? Am I audible?
Yes, sir. We are audible.
Okay, am I on the second slide? Reasoning, knowledge, planning, learning. Okay, I'm sorry, there was some technology problem. Am I audible? Hello, can someone respond? Am I audible?
Yes, sir. We are able to hear. Yes, sir. There is some quality issue.
Okay,
It is
am
not
I
very
on
clear,
the
sir.
second
I don't know
slide?
whether
Reasoning,
problem is
knowledge,
here
planning,
or from
learning.
your end,
Okay,
sir.
I'm sorry, there was some technology problem. Am I audible? No, I'm audible, but repeating the same thing.
We are able
Slide
to
of
hear.
reasoning,
Yes,
knowledge,
sir. There is some quality issue.
Okay,
It is
am
not
I
very
on
clear,
the
sir.
second
I don't know
slide?
whether
Reasoning,
problem is
knowledge,
here
planning,
or from
learning.
your end,
Okay,
sir.
I'm sorry, there was some technology problem. Am I audible? No, I'm audible, but repeating the same thing.
We are able to hear. Yes, sir. There is some
You have to stop recording.
clear, sir.
Second
I don't know
slide,
whether
reasoning,
problem is
knowledge,
here
planning,
or from
learning.
your end, sir.
Okay, I'm sorry, there was some
Sir, what we do is temporarily we can stop, sir,
audible?
once. We are not at all audible.
No, I'm
Sir, am I audible?
repeating the same thing.
We are able to hear. Yes, sir. There is some.
You have to stop recording.
Clear, sir.
Second
I don't know
slide,
whether
reasoning,
problem is
knowledge,
here
planning,
or from
learning.
your end, sir.
Hello?
Sir, what we do is temporarily we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, repeating the same thing.
We are able to hear. Yes, sir.
Yeah, I will do that. Stop recording. Second
I don't know
slide,
whether
reasoning,
problem is
knowledge,
here
planning,
or from
learning.
your end, sir.
Hello?
Sir, what we do is temporarily we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, The same thing.
Yes, sir.
Yeah, I will do that. It's recording. Second slide, listening, knowledge, planning, learning. Hello?
Sir, what we do temporarily, we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, the same thing. Yeah, I will do that. It's recording. Second slide, listening, knowledge, planning, learning. Hello?
Sir, what we do temporarily, we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, the same thing. Yeah, I will do that. It's recording. Second slide, listening, knowledge, planning, learning. Hello?
Sir, what we do temporarily, we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, the same thing. Yeah, I will do that. It's recording. Second slide, listening, knowledge, planning, learning. Hello?
Sir, what we do temporarily, we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, the same thing. Yeah, I will do that. It's recording. Second slide, listening, knowledge, planning, learning. Hello?
Sir, what we do temporarily, we can stop, sir, once. We are not at all audible. Sir, am I audible?
No, the same thing. Yeah, I will do that.
शेयर करो
शेयर अभी मत करो पहले बढ़ा नहीं पहले सेट करो प्रॉब्लम हेलो ये थोड़ा सा लैंग्वेज
वो लोग शेयर करो
अभी मत करो पहले बढ़ा नहीं पहले सेट करो प्रॉब्लम
Sir, you are visible. Please share your slides.
ओके हेलो ये थोड़ा सा लैंग्वेज
वो लोग शेयर करो
अभी मत करो ओके हेलो ये थोड़ा सा लैंग्वेज
वो लोग शेयर करो
अभी मत करो ओके हेलो ये थोड़ा सा लैंग्वेज Okay, am I audible and my slides are visible? Hello? Hello?
Slide is visible, sir.
Okay, should I continue?
Please continue, sir.
Okay, so I was talking about and my slides are visible.
Yes, sir.
No, I think we have not sorted the problem. It is again repeating my old voice. Okay, should I continue? Okay, so I was talking about no, I think we have not sorted. No, my old
You can continue, sir.
old voice. It's happening. Whatever I am speaking, it is repeating the old thing.
Sir, at your end, there may be another Zoom
Okay.
open
So I
or
was
some
talking
mobiles
about
open. You have to close all other devices at your place.
no, I think we have not sorted. No. My old
You can continue, sir.
old voice. It's happening. Whatever I am speaking, it is repeating the old thing.
Sir, at your end, there may be another Zoom
Okay.
open
So I
or
was
some
talking
mobiles
about
open. You have to close all other devices at your place.
कुछ नहीं है
I think we have not sorted. No. My old
You can continue, sir.
old voice. It's happening. Whatever I am speaking, it is repeating the old thing.
Sir, at your end, there may be another Zoom
Okay.
open
हमारे यहाँ कुछ भी खुला हुआ नहीं है
at your place.
कुछ नहीं है
पढ़ रहा हूँ लेकिन वो पीछे वाली रिपीट हो रही है happening whatever I am speaking it is repeating the old thing किसी का कहीं से रिपीट हो रहा है, समझा हुआ नहीं है, तो सबको म्यूट Okay, so I'm sorry for the inconvenience caused. I had talked about reasoning, knowledge, and planning. I hope I am audible.
Yes, sir, you are audible, sir.
Okay, now the problem is sorted out. I think
Please continue, sir. Your
the
slides are
inconvenience
visible.
caused. I had talked about reasoning, knowledge, and planning. I hope I am audible.
Yes, sir, you are audible, sir.
Okay, now the problem is sorted out. I think
Please continue, sir. Your
the
slides are
inconvenience
visible.
caused. I had talked about reasoning, knowledge, and planning. I hope I am audible.
Yes, sir. Yes, sir.
Okay, so
Slides are visible. You are audible. Please continue, sir.
okay, now the problem of learning, and there are two types of learning that happens in artificial intelligence. One is supervised learning, and the other one is unsupervised learning. And in artificial intelligence, basically,
Yes, sir. Yes, sir.
unsupervised learning is okay. So major role where we don't need to actually learning machines. So machines actually learn on their own. Next is communication. A lot of them is unsupervised learning. Actually have sensors, and they for actually data learning. Okay, so communication is required, and normally the data goes to the machines using the communication technologies and devices. Finally, we have the perception of the machines and the actions, that is the ability to move certain objects or to take certain actions. And let me tell you that perception wise, machines are actually having better capability than human beings. And that's why in healthcare, AI is playing a very major role. I will also like to mention at this point of time that although we are trying to make machines intelligent, we are far away from making machines as intelligent as human beings. So there is a lot of misconception that machines will become as intelligent as humans. Actually, cognitive level, the cognitive capability of machines is still not at all anywhere near to the cognitive capability of human beings. So it's a long way to go to make machines as intelligent as human beings. Now, AI enabled devices or machines basically are of two types. Either what we do, we make existing electronics devices intelligent by adding artificial intelligence algorithms to the devices, or we actually create totally new devices for specific tasks. Like we hear about several types of robots used in healthcare, robots used in surgery, robots used in industries, and so on. Many types of specialized robots are created which have some type of intelligence for the specific task for which it has been created. Now I'll get to the first type of machines. For example, we all use our mobile phones. And in mobile phones are actually becoming more and more intelligent day by day because AI algorithms are being added to how they function. For example, predictive writing is one of them. Okay, for example, when we actually type WhatsApp messages or SMS, we often find that the machine actually uh, gives us suggestions that we are trying to type this thing, and we don't need to type. The words sometimes appear on their own. So basically, the machine learns the way actually we communicate or the way we write messages. And believe me, this predictive writing, suppose we are I am writing some type of message and my wife is writing a similar type of message. Depending on her usage and my usage, the machine will predict different words because it actually learns how to adopt to your style, that is the individual's style. Same is true with voice recognition based dictation systems. We all are now getting used to, rather than typing, we are speaking to our mobile phones. And many times we speak, it creates the text, and then we slightly edit the text before sending. So it's also usage pattern analysis. Okay, how do we actually use our mobile? What type of applications we use more frequently? Based on that, it will reorganize the application icons automatically on the mobile phones. So what it does, it keeps learning automatically the behavior of the human being who is using that machine. And same is true with voice response system. We have Siri, we have Alexa. We are actually hearing about many type of machines which actually talk to us and give us suggestions in voice. So these are some of the AI-based enhancements in intelligence in our mobile phones, which I just thought all of us are using, and we will be easily able to connect. The next one is shopping behavior. Okay, analysis to better engage with customers. For example, when we actually do online shopping using Amazon.in or Amazon.com, we find that when we actually try to buy certain goods based on our earlier purchase pattern and behavior, the system suggests us that please buy, you may like to buy this one, you may like to buy that one. Okay, for example, here is an example of a user actually searching a book on a particular topic, and it is suggesting, the system is suggesting that those who have purchased this type of book have also looked into purchasing similar books of this type. So it makes our life easier by making the right suggestions for a better choice. Similarly, you will find that when we buy, say, clothes or shoes using online shopping, it will suggest us the type of actually purse we have, okay, the buying capacity. Because, for example, dress materials or shoes actually may range from anywhere from 500 rupees to 50,000 rupees. But based on our behavior analysis of earlier buying patterns, it knows, the system actually recognizes of what range this person will be interested in. So it will not actually suggest us a person who normally buys 1,000, 2,000, 3,000 rupees stuff, something which will cost 40,000, 50,000. So it will suggest items in the range, in the behavior of that person. So this type of behavior analysis machines are today designed to do automatically, and we can see this in online shopping. I'm giving examples of things which we are doing in our daily life where AI is actually making our life simpler. The same thing is happening. There are a lot of recommender systems today designed based on AI technology, which recommend to the users when they are using electronic devices. For example, Netflix, it actually recommends the type of entertainment videos the user normally likes to see based on his or her earlier viewing patterns. So it analyzes the pattern of what the user wants, whether the user actually is interested in sports or thriller or love stories and so on, whether the user is interested in foreign movies or which language movies or Indian movies and so on. Okay, so these are some of the things which AI is actually driving in our day-to-day life. The next is we are all hearing about actually traffic condition analysis by our cars and machines which are fitted with AI algorithms, and the recommendation comes based on the navigation analysis of the machine fitted in the car of how should what route should we take, where is more traffic, where is less traffic, which will be simpler to actually reach the destination and so on. Healthcare, we are going to actually hear a lot today, but because the entire conference is revolving around healthcare, so I will not be talking much about it. I think we'll be listening this for the whole day. But there are a lot of things which are making a difference based on AI application in healthcare. Social media, again, we actually machines are trying to, whether it is LinkedIn, whether it is Facebook, actually it analyzes based on our browsing pattern, based on our connection pattern, and it keeps suggesting possibly you will like to connect to this person, possibly you like to connect to that person, and from actually nowhere it suggests some very good contacts and connections. Okay, same way likes and dislikes, based on that, it keeps learning what is the behavioral pattern of the individual and accordingly suggest. It will automatically send birthday messages, marriage anniversary messages. Based on the photographs uploaded, it creates videos, okay, and so on. So there are many things which are adding to the intelligence of the machine and making personalized decisions. I already talked about driverless cars and AI assisted driving. Because we lost some time, I will not be getting into the details of explanation of what is happening, but a lot of work is going on making cars more intelligent, and possibly the day is not far when we will have driverless cars. I already talked about specialized machines. Those, the current examples which I gave were existing machines being made intelligent by adding AI algorithms to them. Now, here is a list of specialized machines which actually use AI to create a specific type of robots. For example, we find robots in hospitals. Okay, during the corona time, pandemic time, we found that there were specialized robots installed at the entrance of the hospitals which will actually interact with the patients. So basically, we were trying to see that contact free help can be offered to patients. Same is true with many other type of industries like hotel industry, offices, in factories, farming. We can see an example of farming. Okay, it will pluck a fruit or pluck a particular type of vegetable exactly when it should be plucked. In human being, because of the perception problem, okay, we sometimes pluck fruits and vegetables before actually or after it should be plugged. So perception level of machines is very high as compared to human beings, and that is making a difference of application of AI in many domains. In gaming also, machines are actually helping the sportsmen in becoming smarter and intelligent, because machines have the capability to actually analyze very different type of moves and different types of scenarios which normally human beings are not able to actually perceive, and they are not able to understand that this type of thing may also happen in my sports. So in all types of sports, whether it is football, cricket, chess, machines are now being used to train the sportsmen. Now finally, actually why the whole world is running after AI, okay, it's because the business, okay, finally everything boils down to economics. And we see that 54% increase is happening in the AI market, and enterprises are actually employing AI based technologies more than 200% year on year. Now, what is the future of AI? Basically, the future of AI is very bright because natural power of human brain to accumulate, remember and analyze data is limited. And the brain also is volatile. We forget things. Machines don't forget things. And what is happening, what has actually triggered AI is we are getting more and more powerful computers, more and more actually capacity storage, and all this is becoming more and more cheaper. Okay, and that is basically fueling, because for AI we need lot of data, because based on data the machine actually makes decisions. So a lot of data storage is required, and fast processing of data is required if we want to make intelligent decisions. Now all this is on computer science area. In computer science area, all these are progressing very rapidly, and that because of that, AI is actually getting more and more prominent in most of the domains. We see this type of news very frequently, okay, in newspapers. Now, I will end with actually showing you a small video how actually there is a big competition going on between the major actually technology players. So I have just actually, I will try to run a video, okay, which will show how Google actually is trying to use AI in healthcare.
Last year at Google I/O, we announced Google AI. It's a collection of our teams and efforts to bring the benefits of AI to everyone. And we want this to work globally, so we are opening AI centers around the world. AI is going to impact many fields. And I want to give you a couple of examples today. Healthcare is one of the most important fields AI is going to transform. Last year, we announced our work on diabetic retinopathy, which is a leading cause of blindness, and we use deep learning to help doctors diagnose it earlier. And we've been running field trials since then at Aravind and Sankara hospitals in India, and the field trials are going really well. We are bringing expert diagnosis to places where trained doctors are scarce. It turned out, using the same retinal scans, there were things which humans quite didn't know to look for, but our AI systems offered more insights. Your same eye scan turns out holds information with which we can predict the 5-year risk of you having an adverse cardiovascular event, heart attack or strokes. So to me, the interesting thing is that, more than what doctors could find in these eye scans, the machine learning systems offered newer insights. This could be the basis for a new non-invasive way to detect cardiovascular risk. And we just published the research, and we are going to be working to bring this to field trials with our partners. Another area where AI can help is to actually help doctors predict medical events. Turns out doctors have a lot of difficult decisions to make, and for them, getting advance notice, say 24 to 48 hours before a patient is likely to get very sick, has a tremendous difference in the outcome. And so we have put our machine learning systems to work. We've been working with our partners using de-identified medical records. And it turns out if you go and analyze over 100,000 data points per patient, more than any single doctor could analyze, we can actually quantitatively predict the chance of readmission 24 to 48 hours before, earlier than traditional methods. It gives doctors more time to act. We are publishing our paper on this later today, and we are looking forward to partnering with hospitals and medical institutions.
So with this, I will once again like to thank the organizers for giving me this opportunity, and I'll stop here. Thank you very much. Thank you very much. Over to the organizers. I am done, sir.
Hello.
Yes.
Hello. Yes.
Yes. If there are any questions,
Yes, please.
if we are learning late, maybe I leave it to the
Yeah,
session.
I'm ready here. So we are waiting for organizers to come.
Okay.
I'm ready. Hello.
Hello. Hello. Is it Dr. Mahendra Bhandari?
Yeah, speaking.
Good morning, sir. It might be a good evening for you over there.
Almost going to be good morning.
Okay. Okay, sir. So we will welcome you to this artificial intelligence CME in healthcare system. So please, would like to hear your presentation.
Thank you very much. Thank you, Dr. Sinha, and you made a very good base for me. At the outset, I must thank Dr. Nitin Nagarkar, Dr. Alok Chandra, and other organizers to have invited me on this symposium of great significance. I also see two of my very dear friends, Dr. D.K. Gupta and Dr. Saroj Chudamani Gopal, and I thank them and really appreciate, very happy to see them here. Can you see my slides?
Yes, sir.
Okay. The first contest I'll have is there is nothing artificial in this because it's an intelligence created by human beings, you know. You may talk of Jeopardy or anything, but you don't talk of 100 intelligent people and very powerful machines behind the whole thing. So this is the choice of human being, and I see no conflict between machines and men, because they are complementary and ultimately they are the purpose of the objective for us. They are to improve the patient care. I would like to make few disclosures. Our project, part of it is being funded by under National Science Foundation, and Ready Minds Inc. is the startup which is totally dedicated to surgical healthcare, and I work as advisor, and most of the work has been done by their funding. When we are talking to the surgeons about surgical applications of robotics, the first thing is we have to really introspect and see how surgical decisions are making. They are very complex, they are very high stake, time constrained, and surgeon virtually has no predictability. I would say astrologers are more correct than surgeons. Because surgeons have a lot of tools to explain if their prediction is not right. And everything we decide impacts the patient outcome. Some of the data I'll show you subsequently. Most of our decisions and reasoning, as Professor Sinha said, is very much unlike machines. They are hypothetical, they are deductive reasoning, they are surgical experience and surgeon bias, which lead to preventable harm to the patients. Why are we talking of technological complementation? Every time when we were students, mostly we were talking about excellent surgeons and good surgical craftsmen. Why are we talking of technology today? And here is the reason that recently I attended a workshop on all the robotic companies trying to construct the robot of the future. And they said that preventable surgical errors are the third leading cause of death in United States after heart and cancer. We are very good that we don't, in India, we don't have a data to show that. It's anybody's guess. 400,000 patients die per year due to avoidable complications. What is more startling is 36% of surgeries do not go as per the plan. And 1 in 10 would have a durable complication. Patient will have to live a compromised life. To set the safe OR workflow, you need 60 to 70 people in order to have a safe workflow. And most interesting component of this whole slide is the lowest quartile surgeons, which you can say that how many of them would be experienced surgeons. Surgeons in making would have 3 times more complications than a surgeon who is experienced. Now, here I would like to talk of relativity of experience. A surgeon I met the other day had done 8,000 robotic radical prostatectomies, wherein 5 million radical prostatectomies are done across the globe. So when you try to see that when we can bring in this entire experience through this technology for the benefit of patients, this 10,000 cases experienced surgeon who is supposed to be one of the most eminent surgeons in US is also likely to behave as a minuscule. He has a lot to learn. When you talk of surgical events, only 25% are because of technical errors, 75% are human errors. And there are so many causes, but the best part is by complementing with the machines. And Professor Sinha mentioned about the cars, and you can see Tesla has produced the data to say that these cars are 200 to 400 times more accurate than this, and the human drivers, the best human drivers. So where is surgery leading to? This is a question we need to ponder. Now, technical satisfaction is the days for that are gone. That we used to do good surgery, and we say that I am satisfied with everything is to be linked to patient outcome. Every action has to be centered towards patient outcomes. We have had the era of reference guidance surgery with CTs, reconstructions, 3D models, printed models. All of them are reference points for surgery. Now we are talking of immersive surgical guidance intraoperative to the surgeon. Democratizing surgery. The biggest objective and a lot of companies are working on is that today our rural people in India would never ever be referred to or like to go anywhere. How can we empower the surgeons there? Uh, General surgeons who are not trained or nurses to really do a safe surgery under the mentorship or guidance. So, democratizing surgery means excellence is not only the prerogative of people in the cosmopolis and big cities, it should do, and technology has a promise to do so. Remote monitoring, I'll show one of the examples, and learning curves. Learning curves, it is going to play a very major role in teaching of surgery because it is a lot of, I shouldn't say, but surgery is being taught with accidents. We really train them and then we evaluate, but by then the damage is also done. Surgical companies has muddied the water of learning curves. Like I'll give example of robotic radical prostatectomy on Da Vinci robot. Company claims that 10 cases if you do your learning curve, you have crossed the learning curve. But the data published by Mount Sinai Hospital, Tiwari and group has shown that there are 300 cases needed for benchmarking nerve sparing surgery, which will give benchmark results on erectile dysfunction. So we have to accept that 300 patients are going to suffer in the hands of mediocre people. I think it's a pretty serious matter and we should do. I have a right, because I am a surgeon myself, to criticize my own fraternity. Surgeons are really confident people because they don't care about complications. Their skill sets are so many, so much that they say, don't worry, we'll fix it up. You injure a vessel, we repair it. You injure a IVC, we take care of it. Make sure that the patient leaves the hospital or the operating room safe. But no surgeon would like to be that. Every surgeon would like to be predictive, as Professor Sinha mentioned. And predictability is another concern which we hope machines will save. I would like to not to repeat what Dr. Sinha has said, but from the point of view of making it clear to the medical fraternity, those who are participating, artificial intelligence is a multidisciplinary field of science whose goal is to create intelligent machines. And then there are three buckets under that. So machine learning, deep learning, and there is a lot of crossover when we'll talk of the application. You already know about the natural language processing and language translation. You know about the wherein it's that intersection of machine learning and deep learning. Speech recognition softwares are in popular. And I won't waste time on this area because this is all Dr. Sinha talked about. And all I will talk is for medical concern, there are two areas, which is the computer vision and deep learning models are the ones which we are using, at least that has definitions which I may be using. Algorithm is an unambiguous specification of how to solve a particular problem. I think most of you know model. Supervised learning and unsupervised learning already Dr. Sinha talked about, and I would say that supervised learning is the only learning currently possible, but in unsupervised learning, there are forays because I'll tell you the labor pains of labeling data and cleaning the data are huge. So everybody is looking for algorithms which will perform on their own. Humans can communicate with each other at only 10 bits per second, whereas robots could communicate through net at the speed of 100 million times faster. So most of the robotic companies are trying to take advantage of that and communicating like Tesla has a network of 2.2 million cars. Each one of them is a computer warehouse and they act as a data warehouse. And similarly, there is a possibility that we will be able to exploit exchanging data between robots means exchanging different surgeons' data and using it for the purposes which would really improve the outcomes. Now, here I would like to say the technology which is available today, technology under research, and technology along with the overall boat of ethical issues which are applicable to cars and other areas. But the technology is there, but there is a hesitation to develop that. And current robot nutshell falls into this group, Da Vinci, which is hardly a robot. It's a misnomer. It's a master slave system. It doesn't do anything. Everything is to be done by the surgeon. The next level, what you call robotic level 2, is where there is a decision support systems involved, and that is Dr. Alok Chandra's department of orthopedic Mako robot is much more intelligent than the dumb Da Vinci robot, because Mako, with 3D reconstructions, we can feed the data and it will accurately do the varus level you need. It will give you the size of the prosthesis. It will tell you millimeter to millimeter how much cartilage needs to be removed. It is an intelligent robot. And similarly, there is a dental robot by the name of Yomi, and that also does the same thing. But now I think we are looking for more decision support tools which can assist surgeon in trying to take the decisions.
Interesting question.
Why I can't change my slide?
So your slides are visible.
No, I am not able to move my slide. Something has happened. Let me stop share and I'll share again. Okay, sorry. Okay. There is another major question. Can you see my slide?
No, sir. No, sir.
No? Sorry. Okay. Can you see now?
Yes. Yes, sir. It's visible.
Yeah, this is a meta-analysis which shows again radiological studies. And if you see that this is the deep learning models which perform definitely better in terms of sensitivity and specificity in comparison to the healthcare professionals. And this was the data created by for the several radiologists, board certified radiologists. The speed of, you would have seen during COVID time, the speed of what you call the data, the reading radiograph was much high. I already talked about these printing models, which are used for rehearsing surgery, but they are reference points. You know, they don't become a real patient. So that is the distance which is traveled, difficult to treat. Efforts are being made. Pre-operative information and intraoperative actions, there is a big gap between that. And that's what already I talked, that reference is outside. You have to apply between the x-rays or whatever is the investigation, and immersive is what is the future. Now, when you compare open surgery era did not have any data except for some preoperative information. Since then, the graph is going towards the minimally invasive surgery. It has increased the complexity for the surgeon because every technique has a learning curve in itself, and you can't use much of general surgical principles to use that. But yes, every technique replicates a good open surgery. And it has given as an offshoot a lot of data available to us, which we really are exploiting in terms of producing models and making surgery more predictable. This is a work we have done a PhD work at Wayne State University, and where you see that unlike cars keep track of everything of the field on the side, on lateral through the lidars, the sensors, ultrasonic sensors, and cameras. But surgeon doesn't have such a thing. Now you see the surgeon is very careful and he's trying to dissect the area very gently, but he's focused on that target, what he's trying to do. He is not aware of what is going to create a problem for him. And he's just focused very gently, he's doing, but he has no idea about the amount of forces being applied by other instrument or tractions. And that's what is, I mean, unpredictability of surgery, that suddenly something from somewhere would come. Again, no big deal. He'll control, no damage would be done. If the vessel is significant, he'll be able to anastomose. But the point I want to say, we wanted to predict before surgeon sees the blood. And so we created a VSLAM algorithm, and that's the project funded. Means instantaneously, real time, we can go back because we wanted to give three information at that time. What is the source of bleeding? What is the magnitude of the bleeding? Whether it's arterial or venous bleeding. Then we did surgeon interviews and they added another dimension to it until we can give a context of the bleeding, where the bleeding is coming from. And that's where our subsequent research worked. This went off well. We used entropy. Dr. Mustafa used entropy to say, and we found in our first 10 primary study, preclinical trial study, that it is about 30 to 60 milliseconds before a real blood is seen by the surgeon. The entropy of the instruments can be noticed, and that is, if it is true in large studies, that's a pretty good time for a robotic tool to really control the surgeon's bleeding point. Another area I won't touch, we got into predictive modeling, and in 2019, we published a paper in British Journal of Urology giving our theoretical concept of building predictive models. Since then, our journey, we learned a lot on predictive models. We were looking for data. There was no data like big data in healthcare, because most of the healthcare data is for relational databases. We are not still used to big models, and I'll show a sample of it. So we got publicly available data, Mimic 3 data, and it's an ICU data, very good database, which had a data of 8,664 patients in 35,000 ICU patients. And we had almost 3.5 million trainable parameters and 15 million if we include all events. The models performed very well. 96% we could predict the within a week mortality in ICU. We were very excited about it. Now, where do you go next? It got accepted for publication, but that was not the objective. We thought we'll make it a clinical resource tool. I mean to say the clinical practice tool. And then we maintain a database of robotic partial nephrectomies. 25 centers contribute this data. So we thought this is the best model to build, where we can really deploy the model back and we can predict which patient is going to have a complication after this. Again, we faltered because we did not know. This is what I'm telling. Until you are in this area, you would not learn on the job, because there is a very little information on healthcare predictive modeling. And you will see 99% of them do not go beyond publication. So we did this, and model performed very well. You will see that AUC of 87% is very good, and with 95% confidence intervals. We did random forest, we did neural network, we compared with the logistic regression. Model performed well. And then we got another 300 patients to train the model again as a test data set. And we found that model collapsed. We went and studied the whole thing with our model building experts and found that one of the major centers which was contributing data had stopped supplying the data, and that's why model did not perform well. So lessons we learned is, until we know what kind of data is needed, these models are data hungry. You need, our focus is on volume. Yes, volume you need variety of data, you need velocity of the data. That's why ICU data is better, because always there is a 15-minute record of blood pressure, or urine output hourly, or pulse, blood pressure are monitored, and you can directly get through machines. So velocity of data is very important to predict timed events, because we can say this endotracheal tube would be removed on 7th day or so. If you can predict on 9th day, the hospital managers can plan their whole thing. But it's a long way to go. Then you need variability of data, veracity of data. This is the most important thing. Let me tell you, veracity, or the kind of data you have, is the foundation of models. Your models would perform only well if your data is trustworthy, and the value of data. It's not garb in and garb out, that you have, when I'm talking of big data, you put everything into it. At the same time, we don't take selected variables as we do in logistic regressions, because we want to pull out the hidden insights. We want data to reveal something which otherwise we would not know. So then still there is a very careful selection of the value of the data. Now I'll show you that this is our work on, uh, um, again, we have access to publicly available databases which everybody can use. And this was a challenge we participated in. And it was 300 CT scans of tumors, and we built this model, and you can see that this is inference and this is the ground truth. We did not win this challenge, but the model performed well because there were algorithms better than us. But we learned a lot and to progress our work. In 2020, we published an invited review on conceiving what would be the future robot. And our conclusion is, though there is a lot of hype about talking on automatic robots and all, it's very unlikely to come. And the bottleneck is not because technology is not there. Bottleneck is that we don't have surgeons and physicians participating in this game, because I'll show you why we are very important component of building these models. Most of the places in US have PhDs, and clinical departments are not included except for Ivy League people, because they understand the value of it. Most of these people are given access, and PhDs build the models and present. I attend MICI meeting, which is the largest meeting, and in about 2,000 delegates, I have not found one clinician. Only one guest faculty came and gave a lecture on the model. So I'm again and again cajoling you that clinicians and younger people must come into this. So we participated in MICI 2018 challenge, wherein we had to identify 18, our model, we had to build a model to identify 18 structure. This was porcine model, and this label data was given to us. We built the model. We progressed a little. We didn't win this competition, but we were shortlisted in 13 teams, and we went to Grenada. You see that this is the video of the real procedure of partial nephrectomy, and this is the model recognizing it. So now we have abstract in all three important meetings this year on annotating and building supervised deep learning models in laparoscopic live donor nephrectomy. Why we chose live donor nephrectomy? I think most of you know that my discipline is urology, so I am working on urological problems only. And why we picked up live donor nephrectomy? Because we thought that we'll make a base model, ground truth model with normal anatomy, and then it would be very easy to augment it for different pathologies by getting disease-specific data. The first challenge we put was that we had allies and partners collaborating with us. But how do we get the data? Because they have the data, but they have no time. They are busy clinicians to upload the data. So we had to create a purpose-built, what you call, um, app for this. And this is an app which is protected. It is compliant with HIPAA as well as GDPR. And it satisfies all IRBs and ethical committees where it says that data should not be transported out of their country. We can build these models in your country, and the biggest part of this is that you control your assets, and those assets can only be given at any point in time for model building with you. Next step is we are adding a radiological data labeling tool to this. And more important, we are adding is a distributed ledger system where there are no permission, rule-based blockchain. You can control, all participants would be able to control their data with them. And there is an inner chamber where if you collaborate with somebody, you can build data with your own models. At the same time, you can build data in collaboration. The end-to-end workflow is, I don't, in fact, I'll request Dr. Nagarkar to do a course because it is too unreasonable to cover up the whole subject, but I'll try to rush through and give you introduction. That end-to-end workflow is important, and in this paper we have emphasized that at every stage, if you want to build the model, it has to be a collaborative work. And then we have 3 annotators at 3 different remote sites labeling the data. And then there is a consensus building process in the data. And this is every time the model building expert or engineer is to participate in the data. And this is our labeling tool. I won't like to waste much time. All I would say is, now this is what I mean by discrepancy. This is how you label. This is renal vein. This is a very good labeling. This is the correct labeling of this vein done by one annotator. Another annotator applied his mind and did labeling of the lower part of the thing. And third annotator had covered the tool also. Mind you, that models recognize one texture and color. So then we had to consensus and we say only if the object is clearly seen, class is clearly seen, you label it. Otherwise, don't label it. Don't label the tools and all. Now you see the impact of IOUs on renal vein. IO is the intersection over union area between the real video and the ground truth and the model. And what you see is that IOU is 80% if the annotators agree. And if they have mislabeled the class, you see one annotator has labeled artery instead of vein. IOU falls. And similarly for IOU falls if the annotators don't agree. And this agreement will come only if you have a consensus. This is how our model performs. On your left side is the real video, and 3 classes we did: spleen, renal vein, and renal artery. You see that this is spleen here. This is the renal vein, and these are 2 branches of the renal artery seen here. Model performs exceedingly well. But however, model needs to be further augmented with different classes like ureter, gonadal veins. And similarly, the model needs to be augmented with more data to make a real generic model before we really go into. I wouldn't like to say it's a very good precision versus threshold. We did the precision plotting against to study the area under curve. We use several techniques to really semi-automate the image selection and augmentation of the data. And we found that the model had longer training, augmentation has improved the model. Now, I will lastly say that we have been simultaneously working on several projects. Once the models are built, then you have to register these models virtually. These are virtual models, and you have to immerse them with the real-time anatomy of the patient. And then the third thing would be tracking. With the breathing, the model moves, and with every surgical action, model changes its volume. And that is one of the most difficult tasks. This is the cutting edge, wherein so many groups and startups are working to track the model. It is simple for brain and spine because there are uh, points where these are hard points and we can have reference points, but it is not easy. So first stage is that again we participated in a challenge in Mikai at Shenzhen, and you see that this is the kidney surface, and herein we had to build a model for what you call depth perception. This is the kidney surface, and you see that how accurately you can see, but naked eye you won't be able to see that. And this challenge we won at Mikai. We were the first team, and we do that. This is what I meant by registration of the model and registration of model of the liver. This is the virtual model which goes over the real model. Now this model would be static, that model is mobile, and we are trying to find out so many things, including the infrared bioglue or something to make a real mixed reality, which so far is eluding us. This is what happens, that if you try to put a virtual reality, it doesn't help you because it doesn't move in synchrony with the real model. Now, this is our new tool. We are trying to prepare a user interface and trying different things. And one of them is the latest Google, so we use Google Glass, and then we are using the head mount display of the Google, Microsoft HoloLens. And you see that these are models built by the CTs of the patient, and we are able to play with them. We can split them open, take the kidney out, take the adrenal out. Ultimately, our plan is that we have built a computer vision model. Now we'll personalize that model with the CT of the patient's model, and then we will register, track, and do long way to go, but that is the track of the whole thing. Surgeons collect very scanty data, and there are ways and means. There are lots of sensors available, and we have to think in terms of how do we collect more data. Now, last thing I like to show you, if you ask me a question that when is automatic robot coming, I don't think it is likely to come from Silicon Valleys. It is likely to be the small startups will come up with smart robotic tools. One example I'll give you, 1.7 million high-risk abdominal surgeries are done. And again, leak accounts for 13,000 deaths. Real-time detection of leaks, and is a very simple concept with the pH and bacteria level marker. Sensor response time is 100 milliseconds. It's a very small startup, and you see that small clip, what it does, and that's what, according to me, is the future of uh, automated surgery. I'm sorry I overshot the time, but it's the last slide. With the first drop of the leak, mind you, sensor has sensed the change in pH. At the same time, doctor gets a message on his iPad. He gets the entire data, intraoperative and postoperative data. So I think that's what is the future which I foresee. I would be very happy to answer questions, and this is my email. And I once again thank you for inviting me and giving this opportunity to talk to you today. Thank you very much. Back to the organizers.
Thank you, sir. It was a really extensive and knowledgeable uh, regarding knowing the application of artificial intelligence in the field of surgery. A few years back, for partial nephrectomy, it was to be done by the surgeon, but now you can see that it can be done in much better way with the robotic machines also. But this requires a large number of data and analysis to have a more precision, better accuracy. And with this, I thank you. And we can get whichever the queries are there can be taken up in the chat box and can be answered at the end of the session. Thank you again.
Thank you.
Thank you, Professor Bhandari, for your wonderful presentation. Till now, we had heard Professor Sinha and Professor Bhandari talking on overall introduction to artificial intelligence and its status worldwide, which covered a wide variety of topics, followed by applications of artificial intelligence in the field of surgery. Up to this point, what we could see is the artificial intelligence has made a sort of transition phase between actual working of our brain and our neuroscience systems. The way we learn, the machines are sort of taking up these things in a smooth fashion and in a much different ways. Secondly, one thing which I could gather from the first two presentations is very important is the data which we are feeding to the artificial intelligence. So it is almost totally dependent on how good the data is and how truthful the data is, because as we say in machines, garbage in and garbage out. So it's very important the way the data is handled and the data is presented. With this, I have the privilege to invite Professor Dhaneria, the Dean of our institute, AIIMS Raipur, to deliver his lecture on artificial intelligence in pharmacology. Welcome, sir. A very interesting topic, I understand, with all your drug targeting, gene therapy, repurposing drugs, so much of scope in your field. Welcome, sir. Please go ahead with your.
Honorable Professor Nitin M. Nagarkar, Director of the Institute, Honorable Chairpersons and distinguished delegates. At the outset, I express sincere gratitude to the Chairman, Medical Education Unit of our Institute for giving me this opportunity to share the views on role of artificial intelligence in pharmacology. Artificial intelligence is a computer science field where the computer is trained to perform the tasks that normally require human intelligence. So artificial intelligence refers to the simulation of human intelligence in machines that are programmed to think like human and mimic their action. Artificial intelligence as a system's ability to correctly interpret external data, to learn from such data, and to use those learnings to achieve the specific goals and tasks through flexible adaptation. So in artificial intelligence, intelligence demonstrated by machines, unlike the natural intelligence displayed by human and animals, which involves consciousness and emotionality. The weak artificial intelligence tend to be simple and they usually involve the simple tasks. So weak intelligence, artificial intelligence tend to be simple and single task oriented, while the strong artificial intelligence carries on tasks that are more complex and human-like. So how the artificial intelligence works? So these are the principal elements: machine learning, deep learning, neural networks, natural language processing, computer vision, and cognitive computing. So there are huge data. These data are corrected and processed. They are analyzed, conclusions are drawn, algorithm is prepared, and then before the algorithm, a question is put and algorithm tries to give the solution. So in machine learning, it is basically the analysis of structured data to reach the possible conclusion. Unstructured and free text form are detected by natural learning processing. In deep learning, actually it processes inputs through layers in order to classify, infer, and predict the outcome. And the neural networks, actually it works on the similar principle of similar principles on the human neurons. Now, when we talk of role of artificial intelligence in the pharmacology, the first thing which come in our mind is the role played in drug discovery. So we have the computer-aided designing of the drugs in the beginning. A chemical molecule has been designed and then it is tested. So there is one. Second, when we carry out the studies in animal, that is in the preclinical phase, this preclinical phase data will help us in planning the clinical trials in human being. On the basis of the preclinical studies, we can predict the outcome of phase 1 and phase 2 trial. In real world, the data are so huge. And when we conduct the clinical trial, there is a possibility of the huge confounding variables affecting the outcome. So artificial intelligence will deal with the problem of huge confounding variables. It will speed up the process of clinical trial and therefore expenditure may be reduced. So success rate of clinical trial will be increased with the help of artificial intelligence. Because if we look to the development of a new drug, it will take around 10 to 12 or even 16 years. And expenditure is certainly more than $1 billion in the development of a new drug. So artificial intelligence has a significant role in drug development. It will speed up the drug development process and also reduce the expenditure. Artificial intelligence can use sophisticated algorithm to extract useful information from the huge amount of healthcare data. It may suggest us about the appropriate diagnostic procedure. It helps in establishing the relationship between the preventive and treatment strategies and the patient outcome. It will help us in developing the treatment protocol. We have the data of patient, we have the data about the illness, and it may suggest the various treatment options from which we can select the most appropriate one. It will help us in rationalizing the drug therapy. The key of rational drug therapy is to use a right drug in right patient at right time in right dose by right route, and it will also help us in right documentation. A drug may influence the response of another drug, so it may help us in predicting the drug interactions. We can identify the high-risk patient from developing the complications who are more predisposed to the, we can say, the adverse drug reaction during the drug therapy. It will help us in assessing the adherence and compliance, which is more important when we are treating the patient from chronic illnesses, because in chronic illnesses, the patient adherence is extremely important. Otherwise, there may be a therapeutic failure. It will help us in identifying the medication error and hospital readmission. readmission. So medication error may be prescribing error, transcription error, dispensing error, administration error. So it will help us in preventing the medication error. It will help in actualizing the precision dosing. In particular, organ dysfunction or organ failure, what should be the dose of a particular medicine? We have the model, AI-driven model, where the patients who are requiring the hemodialysis repeatedly, they are developing the anemia, and how to treat that anemia, we have the AI-driven model for that. Then also another role is to guide how and where to obtain the most cost-effective healthcare, which is quite important in context of developing country, and will also advise us on the lifestyle modification, because there are a number of clinical illnesses we can very well manage with lifestyle modification, and if that fails, only then we switch to the drug therapy. Pharmacovigilance is another area where the artificial intelligence has helped a lot. At present, under the pharmacovigilance program of India, we are monitoring the adverse drug reactions. So now it is not only the drug, now we have the program for vaccines, we have the program from blood and other elements, that is the hemovigilance, and also for devices, the materiovigilance. So our institute is one of the ADR monitoring center in this program. And there are two types of forms are available. One for the healthcare professional, means one who prescribes the drug, one who administered the drug, and one who dispenses the drug. But we have another form, one who consumes the drug is there, and that form has been translated in around 15 languages. So, like other center, our institute is also one of the AIIMS ADR Monitoring Center. We submit our report to the National Coordinating Center, that is Indian Pharmacopoeia Commission, where the data are processed, and then these are sent to Uppsala ADR Monitoring Center, that is in Sweden. That is a World ADR Monitoring Center. This WHO center, it operates, there are different systems are there, that is VigiFlow, VigiBase, and Vigilize. VGAxis is publicly accessible. From these huge data, we can identify the signal. Signal means one of the information about the adverse event with the drug, which is not known previously. So we identify the signal, and then we plan the careful study to confirm that signal. So artificial intelligence in pharmacovigilance has reduced the cost, time, and workforce, and also improved the quality and accuracy of the system. My colleague, Dr. Manju Agrawal, will be speaking in late afternoon on this topic also. Now, role of clinical pharmacologist. It has been questioned that with the introduction of artificial intelligence, is there any role of clinical pharmacologist in 21st century or not? So a clinical pharmacologist is a medically qualified practitioner who teaches, does research, frames policies, and gives information and advice about the actions and proper use of medicines in human, and also implements the knowledge in clinical practice. So still, we have to adopt a balanced view. So AI enabled the 21st century clinical pharmacologists to build better hammers to improve the therapeutics for the benefit of patients and society, and keep swinging. Now, what can be the utility of artificial intelligence, or we can say the advantages? Reduction in human error. Computer do not make error if properly programmed. Takes risks instead of human. AI robot are unlikely to make mistakes. Available 24/7, helping in repetitive job, because human may feel boring in repetitive job. We can use for digital assistance, faster decision, daily application, new invention. We have the AI-driven technology where we can predict very early the breast malignancy. But it has got certain limitations because every brighter side has a darker version in it also. Tainted data and bias. No one size fits all solution. We cannot use in generalizability. Requires supervision. Limited computation resources, high cost of creation. So high cost both in the, we can say in terms of the hardware and also in energy. Unable to adapt to deviation in circumstances because human can have the empathy and compassion, but computer cannot. Lacking out of box thinking because computer will work as per the direction and programming, not out of that, while human can do it. Cannot think for itself. There is no consensus on safety, ethics, and privacy. It may make human lazy. There is a problem of unemployment, no emotions, and lack of creativity. These are the limitations in artificial intelligence. So, to conclude, machine can perform only those tasks which they are designed or programmed to do. Anything out of that, they tend to crash or give irrelevant outputs, which could be a major backdrop. Machine cannot develop a bond with a human, which is an essential attribute when it comes to team management. So when it comes to originality and creative thinking, a machine simply cannot compete with human brain. And therefore, we still need both human and machine. Thank you very much for kind attention. Thank you.
Thank you, sir, for your excellent presentation. I think as we discussed in the end that with the question and answers coming from the people, we will have the discussions at the end. I take this opportunity to request you to kindly accept a slight token of appreciation from the Institute. Thank you, sir. Thank you, sir.
Warm good morning to everyone. And I think we had a great 3 deliberations in the morning, which were exciting sessions. Now, I call upon Professor Dr. Alok Chandra Agarwal, who has been backbone of this conference. And he has been the Associate Dean and Chairperson of Medical Education. And as rightly pointed out by Dean Sir, so is it human intelligence or a machine intelligence? So in the decades to come, so we are going to see more machines popping up, so which is going to be a realistic, similar to human intelligence. But always the machines will have some limitations. So to address this issue, I welcome Professor Alok Chandra Agarwal. So thank you, sir. Welcome.
Respected chairpersons, Director M. Dr. Nitin Agarkar, sir, and all the people who are online watching this. My lecture has been made quite simple by the last slide of Professor Dhaneria, who told you basically what are the limitations coming in healthcare. So why this paper? This paper is because the Central Ministry of India, the Niti Aayog, has taken healthcare as one of the thrust areas for starting artificial intelligence. They mention that artificial intelligence is poised to disrupt our world. New things are going to come. A change is going to come. With intelligent machines enabling high-level cognitive processes like thinking, perceiving.
Sir, sorry to interrupt. Your slides are not shared. Yes, sir. You can go ahead.
So I was telling you people that artificial intelligence is going to now disrupt the world, and newer machines are going to come, which people may be afraid that they are being substituted by the machines. With intelligent machines enabling high-level cognitive processes like thinking, perceiving, learning, problem solving, and decision making, coupled with the advances in data collection and aggregation, analytics, computer processing power, artificial intelligence presents opportunities to complement and supplement human intelligence and enrich the way people live and work. More and more machines are going to come, but then not all can be achieved. There will be some limitations. The first thing comes like cost effectiveness. Just now, Dr. Bhandari told you that in orthopedics, we'll be coming with robotic arms. The cost is 15 crores. Only 4 robots at present in India. So it is a very huge setup you have to bring about. Of course, it will give you the precision, which may never come by human hands. But then at what speed, what cost, what time? So these are the limitations. Same way, there will be technical limitations. It may give the precision, but it may not do the whole surgery on your own, that you ask the robot, press the button, so he does the total hip replacement. It will be going for the cuts. You have to make him reach up to that portion. There will be a need of data, huge data, more the results. And then based on the data, can the computer upgrade itself or we'll have to upgrade it? That is one thing. Second thing becomes that the data, if it is coming from companies, there may be a bias. So that also has to be watched. To sell a machine, they may be coming with data which is there. There will be rules and regulations. Finding the rules and regulations for the new technology, which is not well known, is in itself very difficult. And then there will be ethical issues. Can a computer operate? If it operates, whose fault is it? If it is done wrongly, will the surgeon be at risk? Or will the maker of the robot will be at risk? So many things to be thought. And then the software program, there may be hacking, there may be malware, the data may be altered. So all these things are there. Finally, when a patient will come, he is speaking to a computer. He may not feel like speaking to the computer. So what is the acceptance by the healthcare workers and the patients? And of course, the machine will not have a heart. There won't be much empathy. That can come only from humans. So one can never substitute humans. So these are the limitations. Let us discuss one by one. So what are the technical limitations? Well, you have to identify patterns to demonstrate correlate easily. Causal relationship cannot be determined and cannot implement clinically in practice. Lot of technical limitations. Neural network needs to be trained on huge amount of accurate and reliable data. Medical data to train the artificial intelligence is difficult due to privacy concerns, copyrights, and non-uniformity in data structures. Where more and more scientific papers in the country come, in which the data may be manipulated, it may be just made from air. We have to take care that the data should be in such a way that it is never manipulated. Maybe the interpretation is not coming to our help, but later on it will be a true data. And that is what one of the chairpersons mentioned, that the data should never be monitored, means manipulated. So the data can be a process structured data, such as vital charts, laboratory values, or it can be unstructured data, like clinical notes, radiological and pathological reports, annotations, opinions, and which may not be chronological. So if they come in this way, there may be a bias in using them. The performance of the artificial intelligence is directly dependent on the data on which it is trained. So if there's a data bias, the result will also be altered. And this bias may be in relation to race, age, sex, disease epidemiology, all of them. So these are the limitations. What can be the difficulties in regulations? Well, there is a limited expertise with regulating authorities. There is no consensus how to structure clinical trials, and there is no way to assess reliability or bias for decision made by modern machine learning algorithms or black box. So deep thought, and maybe the regulations will be different for different specialties, maybe different for healthcare, for agriculture. So these things have to be coming out separately. If you see into this paper, there were 129 devices in radiology, 40 in cardiology, and 21 neurological devices, which got a limited approval by US FDA. So getting an approval is also difficult, and having it completely becomes more difficult. So these are the difficulties. And perhaps the most difficult set of questions to answer in artificial intelligence in the context of ethics are, what will be the threshold for safety? You all must be knowing William Frankina, who gave you the 3 tenets of ethics. First, do no harm. Second, prevent harm. And the third is do good. So up to where will we be going with these machines has to be found out. And will the standards be different for humans from the machines? This also has to be found out, because the machine will be more precise. Coming to the hacking and malware limitations, well, ethical and unethical hacking of data and software is a reality nowadays. Exploitation of data to your use can be disastrous. Technology giants of today themselves are fighting against the evils of hacking and are falling miserably for medical workers avoiding such scenarios. And it can be a real challenge. Leaking of personal and confidential information can be of massive medical legal implications. When it will be leaking in the career, you never know. So it is better to avoid it. Acceptance by healthcare workers. Well, healthcare workers are reluctant to accept artificial intelligence with open arms, and there are good reasons for it also. Literacy among healthcare workers about it is very low. This is our first conference when we are getting trained into it. Sometimes the use of artificial intelligence becomes time consuming and hinders the usual patient-doctor interactions. And there may be a fear that will we be replaced? Will the doctor write a prescription? Will be there a computer prescribing machine to tell the symptoms and the prescription is ready? So all those things are there in the mind. But of course, that will be based on the data, and data keeps on changing. Human life is not mathematics 2 into 4, it is biology. So there is definitely a role of humans which cannot be surpassed. But then, will patients be comfortable facing a robot or computer screen instead of their physician? There will be nuances of the human patient-doctor interaction, and it will be missing in an artificial intelligence setup. And of course, there will be no emotional questions left. There is the question of responsibility as well. Who will be responsible for the harm caused by artificial intelligence mistakes? The computer programmer, the company making the computer, the regulator who has made the rules, or the clinician? But a harm has been definitely been done. So everybody will be having a scapegoat, and that cannot be accepted. There will be transgression rights also, as to should a doctor have an automatic right to overrule a machine's diagnosis or decision? Well, I had a time when I happened to be in London and navigation had just come. Now you have taken a machine and you have taken a consent from the patient that we will do this surgery on navigation. So navigation tells you that at this level you have to do the section, and human hand doesn't go 100% to it. So out of fear, although everyone knew how to do a total hip replacement, total knee replacement, they used to take cuts, slices, and then do the cuts, which did not use to match. But legally they were safe. And that's why most and more people coming from navigation showed that navigation was not becoming very helpful. It used to give an idea, but you could not stick to it until unless you are having a robot with you. And now the Mako robot has come. So let us see what will happen. And if you feel based on experience, I am going against the machine, it will be just a matter of court. Finally, humans are humans. They need love, affection, respect. If a computer says, you are in safe hands, don't cry, you are safe, maybe people will not feel it. But if a doctor goes and says that I have examined you and things will be okay, so that will be the right thing. So the fear that a technology might be making humans out is never going to be there. But then one should not forget the movie Robot, coming from the Indian scenario, where Rajnikant was made into a robot, and then he could just keep on generating himself whatever you did to him. But those things are of fiction, a long way to go. Our machines, our artificial intelligence has never reached there where a machine will start controlling the world. There is the question of cost effectiveness also. If a company comes out with a robot and sells only 4 in the country in 5 years, of course the cost will be 15 crores and 20 crores. How can it come to a low level? But yes, if the knowledge goes and every institute starts purchasing a robot, maybe the cost may be coming up. So this is one of a major limitation. Then data collection, storage of data and retrieval are expensive in the long run. The systems may just get a crash. There may be lack of backup, and then getting the data back can be expensive, devastating, and at times not possible at all. And then there may be some unethical institutions who can charge real high prices for sharing of important data, and which can prove to be detrimental. So as we all know, that artificial intelligence and robotics are helpful in keeping you well in the early detection of illnesses, for diagnosing illnesses, making decisions, going for treatment, in the end of life care, for research and training. But then starting it in healthcare sector, the Niti Aayog has identified the following 5 barriers. First is lack of broad-based expertise in research and application. Second, absence of enabling data ecosystems, access to intelligent data, which data you have to rely on. The high resource cost and low awareness for adoption of artificial intelligence. The privacy and security issues, including a lack of formal regulations around anonymization of data. And finally, absence of collaborative approach to adoption and application of artificial intelligence. So with this, I have given you a brief insight as to how to start artificial intelligence services in your own center. Thank you.
Thank you very much, sir, for a wonderful presentation. So, as sir has rightly pointed out, so there will be definitely a lot of limitations, be it ethical, be it doctor-patient relationship, the kind of empathy. So, all those things what machine cannot do has been emphasized. I profusely thank you, sir. And I request Professor Sinha to hand over the memento to Dr. Aloka. So we are winding up the session, but there may be few questions definitely, but we are already late by nearly half an hour, and we are not finding access to the chat box also. So I request all the delegates and audience, if they've got any, those who have joined, so they may clarify some questions if it is there. Or those who have joined virtually, if they've got any questions in the chat box, so we'll take it during the panel discussion. I think 2 of our speakers and all of the speakers are there in the panel discussion between 12 to 1. So there are some questions which are there, can be definitely taken during the panel discussion. So I thank all the co-chairs for their wonderful presence and cooperation. Thank you very much.
Thank you, sir, for the wonderful first session. I'd like to request Director, sir, to please come on the dais and present a memento to our chairpersons. Thank you, sir. For the next session, I would like to request Dr. Meenakshi Sinha ma'am, Dr. Rachita Nanda ma'am, and Dr. Satyajit sir to please chair the next session.
A very good morning to all of you. And I am sure you all would agree, we are having a academic treat, of course, and it's ongoing. Treat is ongoing. The fascinating world of artificial intelligence. And we had beautiful lectures in the morning, 4 sessions. And we are starting with the second session. And this will start with a topic on artificial intelligence in the field of anesthesia. Of course, very fascinating again. The speaker in this case here is Dr. Tushar M. Choksi from Vadodara, and we invite him to start his presentation.
Good evening, friends. Today's my topic is artificial intelligence in anesthesia, current trends and future prospects. My lecture outline will be audience poll, introduction and definition, history and evolution of AI, stages and types of AI, how AI works and uses of AI, history of AI in healthcare, history of AI in anesthesia, current status of AI in anesthesiology, future of AI, will AI replace anesthesiologists, journal articles from AI in anesthesia, conclusion, take-home message, my verdict, cartoon and thanks. There are certain questions I want to ask you. Do you know you are already using AI in your practice? How will AI affect or change clinical decision making in anesthesiology? Will AI reduce errors in anesthesia practice? Will you accept AI in anesthesia practice in future? Or will AI replace anesthesiologists? Yes or no? So which medical technology and digital health innovation can expect the brightest future in the next decade of anesthesiology? And from these technologies, 10 technologies, artificial intelligence is the king in this, all the masters technology, and they will rule the next decade of the anesthesiology. So what is the artificial intelligence? Artificial intelligence is the capability of the computers to respond in a manner resembling human intelligence. My dictionary definition is artificial intelligence is the development of computer systems that are capable of performing tasks that normally require human intelligence, such as decision making, object detection, solving complex problems, and so on. And if you see that all the technologies are using artificial intelligence which are available in this world, and AI is like electricity. Without electricity, we are not thinking today's world like that. Without AI, we cannot think of this world in future also. And these two people, Marvin Minsky and John McCarthy, they have given the artificial intelligence definitions and name in 1956, and they are called as the fathers of the AI. What are the aim of AI? Mostly there are 4 aims of the AI. That first is decision making, solve the complex problems, increase the accuracy of the brain on computer, and perform the high level of computation. So it is an approach to make computer, robot, or products to think how smart human think, to study how human brain thinks, learns, decides, works, and when it tries to solve problems, and to improve computer function which are related to human knowledge, for example, reasoning, learning, and problem solving. And ultimately, goal of this is a technological singularity, the point at which technology overtakes the human. There are some terminology came in artificial intelligence. That is, first is artificial intelligence, in that you know that machine thinks without any human intervention. Second terminology came is machine learning by Arthur Samuel in 1959. And here it provides the statistical tools to explore data. So here machine learns automatically from past data without any confusion or any program. Then came a deep learning. It's a subset of the machine learning only by Russian scientists. And here human brain thinking, also called deep neural network or deep neural learning by the computer, is there. And all these three things came together and it forms one of the specialty, and that is called a data science. It is a multidisciplinary field that uses scientific methods, process, algorithms, and system to extract knowledge, and it applies all mathematical rules. Believe me, this data science will rule all over the world in next decade. So these are the basic structures of complete artificial intelligence. So evolution of AI started with the AI, ML, DL, and data science. In 2030, we will see that from every aspect of the subjects will have artificial intelligence in their heart. So if you go to the history of AI, then even 380 various mathematicians, theologians, philosophers, professors, and authors used about mechanical techniques and calculating machines and humans. And from 1900, the people took the robot idea, and first robot was built in Japan in 1929. In 1950, the John McCarthy gave the official birth of the world AI. Then in 1960, the first industrial robot was developed to work on a General Motors assembly. In 1970s, Wobot, the first anthropomorphic robot, was built by Japan Waseda University, and it features included movable limbs, ability to see, and ability to converse. In 1980, Mercedes-Benz built a driverless van. And in 1990, Deep Blue, a chess-playing computer developed by IBM, and it became the first system to win the chess game against a human. Then in 2000 to 2010, AI conducted its trending, like they have developed Kismet, and Honda released the Asimo robots. That is the artificial intelligent humanoid robot. So from 2010 to present day, the AI has developed tremendously. In 2010, Microsoft launched a Kinect for the Xbox. Then in 2011, Apple released a Siri. In 2014, Microsoft released a Cortana. Then again in 2014, Amazon created Amazon Alexa. That is a home assistant that developed into smart speakers. In 2015, Elon Musk, which is the richest, second richest person in the world, who has developed the autonomous weapons and car even. In 2015 to 2017, DeepMind AlphaGo, developed by the Google as a computer program, and it defeated the various human champions. In 2016, Google released Google Home, the smart speaker that uses AI to act as a personal assistant. In 2017, Facebook Artificial Intelligence Personal Lab introduced chatbots to communicate with one another, and we are the witness of all people with the Facebook platform. In 2018, Samsung introduced the Bixby, which is a virtual assistant in all smartphones. These are the landmark years in the history of the AI: 1950, 55, 74, 80, and 2000. And 2011, the landmark year of the artificial intelligence in the anesthesia. Since last decade, the anesthesia has developed tremendous changes in their subject. What to expect for AI in 2020 and beyond? First is natural language processing. Second is machine learning and automated machine learning. Third is autonomous vehicle. And chatbots plus virtual assistant. These all four things will together, they will rule over the world in their all the aspects. There are some stages of AI. Artificial narrow intelligence, that is a weak AI. Machine has narrow defined role of work, like Siri, Alexa, Sophia, self-driven car. Then there is a artificial general intelligence, that is a strong AI. Machine starts thinking just like humans, yet to create and developing all over the world. Artificial super intelligence, that is a super strong AI. Computers or machines will surpass human beings. It is not exist, only seen in science and fiction movie. And there are four types of artificial intelligence. That is a reactive machine AI, limited memory AI, theory of mind AI, and self-awareness AI. In reactive machine AI, it works on the preset data. In limited memory AI, it works on the past data. In theory of mind AI, it works on the emotional data. And self-awareness AI, it involves a machine that have human level consciousness, and pray to God it will not exist, because it is the ultimate example of the artificial intelligence in our day-to-day life. So there are some domains of AI, how it works. Just like from artificial intelligence to machine learning to deep learning to robotics to expert system, then physiologic and natural processing, natural language processing, and this is the way artificial intelligence whole cycle completes. So uses of AI in all the way, you name the thing, you name the subject, they will work as with the use of AI, like construction, metal industries, aeronautics, automobile, roads, highways, robotics, factories, windmill, solar energy, electricity, smartphone, computer, medicine, air condition. Everybody is using artificial intelligence in their subject. So now we'll come to artificial intelligence in our healthcare. There are some historical aspect of artificial intelligence in healthcare. In 1960s to 70, first problem solving like dental software came in the market, and most significantly, it's the early use of the artificial intelligence. In 1980 to 19 brought the proliferation of the microcomputer and no new level of network connectivity and applied to intelligent computing system in healthcare. And in 1990, AI program have developed and applied to each and every aspect of the diagnosis process, treatment protocol, personalized medicines, and patient monitoring with care. And in 2010, the role of anesthesia started in AI. AI started in anesthesia. Then various specialty in medicine have shown an increase in the research like radiology, imaging, telehealth, electronic health records, robotic surgery. And in 2019, we are witnessing 800 uses of AI, like assessing breast cancer risk from the histopathological imagery, guiding antivenom selection from snake images, and diagnosing skin lesions. So AI is used in healthcare in drug development, disease diagnostic, analysis of health plans, health monitoring, digital consultation, surgical treatment, managing medical data, personalized treatment, and medical treatment. So this is the way all the part of the surgical or medical or specialty wise, we are using artificial intelligence in healthcare. But there are some pros and cons. What are the pros? Through AI, there are better data-driven decision. It increases disease diagnosis efficiency. Treatment time cut in half. Integration of information, up-to-date information. It reduces unnecessary hospital visit. It creates time-saving administrative duties. But there are certain cons also. Concerns regarding privacy and security, lack of curated healthcare data, high initial capital investment, lack of interoperability, reluctant from staff to embrace AI, and potential for increased unemployment. This is the biggest problem, unemployment. Now come to artificial intelligence and anesthesiology. History of AI starts like historical development. Anesthesia was the earliest subject to implement artificial intelligence, and anesthesiology was the first established the concept of pharmacokinetic, pharmacodynamics, clinical PK/PD model, and they were developed pharmacological robots through AI. In 1980, servo anesthesia theory started, and which was the embryonic form of the automated anesthesia and robotic anesthesia. In 1990, TCI machine was developed and it applied into clinical practice. And with the gradual improvement of the anesthesia monitoring, especially anesthesia depth EEG monitoring system, the open loop and closed loop anesthesia automatic system established. And in recent years, in 2010 to 2020, anesthetic robots, technological robots, diagnostic robots develop rapidly. Since 2011, AI is anesthesiology is developing tremendously. Like, what is the current status of AI in anesthesiology? 2011 to 2020, anesthesia robots are developed. There are two types, manual robots and pharmacological robots. Manual robots includes the capture intubation system that designed to utilize the video laryngoscopy and robotic arm to place an endotracheal tube. The use of the Da Vinci surgical robot to perform regional anesthesia block. Then they develop the Magellan robot to perform peripheral nerve blocks. Then again they develop the Max Sleepy robots that gives the intravenous sedation machines designed to administer propofol narcotic muscle relaxation, that is the auto anesthesia. And lastly, in Canada, the eye control RP machine was developed like for the closed loop system, and which makes the own decision regarding the IV administration of remifentanil and propofol with the parameters of the patients and surgeons. So currently, AI involved in all anesthetizing patient who requires like pre-operative assessment of all past medical problems from the history, physical examination, laboratory evaluation, mask ventilation of unconscious patient, the diagnosis and treatment of any complications during or following the anesthetic, observation of all vital monitors during surgery, removal of the ET tube or even placement of the ET tube, And from 2020 onwards, anesthesia practice with AI will be like that. AI in pre-anesthesia checkup. Like Google Translate will be very useful in PSC. We will talk in the patient's language, and we can ask, like suppose if I get a patient from the Tamilian region, then if I talk in English, then my talk will be converted into the English text, that will convert into Tamil text, and then convert into Tamil speech. So communication with patients through AI in their language will be routine and already established. In operation theater also, future anesthesiologists will command all gadgets and lights in OT by AI, which will be connected with the different AI system. Like example, if you give order to Google that increase the height of the OT light, then by voice command only the light height of the OT table will be adjusted according to surgeons and surgical field. Like if you give Alexa or Siri that brighten or adjust the OT headlight or increase the AC cooling to 20 degree, so they will do that job by AI. And in our future anesthesia workstation will be also operated by AI with just voice command with data entry. Our monitor will be controlled and self-checked by AI. Even switch on and switch off anesthesia will become a reality through AI in future. So some AI enabler and functions are already in some of our OT machines and monitors that we are witnessing day-to-day life. AI in tele-anesthesia. With AI, you will be virtually present with the patients and colleagues anesthesiologists to guide them in their perioperative period in all procedures. You can give anesthesia from the distant part of the OT. Even you can control all OT gadgets with your smartphone AI apps. Teleanesthesia is not a new concept, but combined with AI, it is a very useful for teaching CMEs and conference. Like I am giving a webinar talk just now. And with combined augmented reality and AI will be change the concept of teleanesthesia, and you will be giving virtual anesthesia to distant OT patient. And it is a reality, like teleanesthesia from Canada to Italy, given by Dr. Hammerling and colleagues from the Montreal hospitals. In 2025 onwards, we will witness like smartphone anesthesia practice, teleanesthesia in any part of the world, artificial intelligence and augmented reality, anesthesia, robotic anesthesia, nanomedicine in anesthesia, genetically targeted medicines, that is genome anesthesia, auto anesthesia or OrthoTV. This will be a reality in 2025, and we are going to witness that part. So these are the algorithm for the AI healthcare model in future. It will be worked by only artificial intelligence on augmented reality. So if you see that like pediatric anesthesiology, neuroanesthesia, AI anesthesiology will be a subspecialty of the anesthesia. Here, anesthesiologist needs a good mix of the cognitive and dexterity-based labor. So AI will primarily result in the automation of the cognitive work. It may be that our hands prevents full automation of the specialty. So you need not to worry about that. Robots comes in the anesthesia assistant, or anesthesia will be taken by robots, or artificial intelligence will be taken by the anesthesia. But our cognitive work will be taken by, but our dexterity work will not be taken by this artificial intelligence. So AI-based automation system gains further capability, and they may be able to perform semi-autonomous anesthesia maintenance, where the AI-enabled machine takes over specified domains of the anesthesia maintenance. Anesthesia might never be fully automated because it involves dexterity based labor, I told you, and current robotic devices don't have exact dexterity required for tasks. However, AI could be used in anesthesia to develop more advanced clinical decision. So a renewed emphasis on the doctor-patient relationship will be developed by AI. So my question is, will AI reduce errors in anesthesiology? Yes. Safety versus complexity. Human dexterity works will not be replaced by the AI anesthesia or robotic anesthesia. But AI can control the gadgets, monitors, but anesthesiologists will require all the times to do dexterity work, like to fill the syringes, to put chest electrodes, or to take clinical decision in odd situations. So AI will catch the stupid mistakes in our practice and optimize the patient care. But at the same time, AI will introduce new errors that human would never make. Will AI replace the anesthesiologist? It's $1 million question. There are clearly cognitive tasks that AI will eventually assume. AI is not able to deal with the many areas of decision. Like when the patient's well-being is deteriorated until all surgeons want an anesthesiologist to talk with them, and talking to robot or machine isn't the same as addressing the guy who has been doing anesthesia for your patients for a long time. So I don't think that AI will replace anesthesiologist anytime. We should start actively using and testing AI that is available in order to experience it and learn to incorporate in our practice. AI today will help anesthesiologists to skip the boring stuffs and hopefully make them more focused and smarter. So, however, in the future, we might see particular role being replaced. The first people to go will likely be those roles that are very task-based and lack creativity. The future of artificial intelligence in anesthesia is unpredictable. But you see, there is a 5 years from now, we might see the amazing game-changing invention as well as continuous steady progress towards more intelligent self-thinking monitors, anesthesia machine, and TCI pump. There is again super specialties coming in the anesthesia through artificial intelligence that is called the intelligence control in anesthesia. It is nothing but it's automatic control and artificial intelligence in anesthesia. Like our closed loop system with anesthesia depth monitor is a good example of this intelligence control in anesthesia, which we are calling auto anesthesia. And it is widely applicable even today also. This is the blueprint of this intelligence control. And this is closed loop anesthesia. Here the input is drugs and output is monitor. And here the machine will decide through AI which drugs will be given to the body, and it determines the right drug with the right dose with the right time by artificial intelligence, which will be taken by this monitor's data. There are some journal articles which I have gathered. The PubMed research I gone through, and more than 1,000 articles in journals are written about the artificial intelligence and anesthesiologists. But the best article I have found is Artificial Intelligence and Anesthesiology, Current Techniques, Clinical Applications and Limitation, and 6 themes they have described. That is the depth of anesthesia monitoring, control of anesthesia, event and risk prediction, ultrasound guidance, and pain management. So if you see, the artificial intelligence has the potential to impact the practice of anesthesiology in all the aspects, ranging from perioperative support to critical care delivery to pain management, like novel artificial intelligence system for endotracheal intubation, machine learning models for to detect the post-intubation hypoxia, then machine learning approach for preoperative anesthesia risk prediction, prediction of bispectral index during target control infusion of propofol. And here, if you see that Dr. Hammerling has first in 2012 have done first robotic tracheal intubation in humans using the Kepler intubation system. After that, he has done the first robotic ultrasound-guided nerve blocks in human using the McLean system. The same people and same team. Again, after that, they started a MaxLiP automated anesthesia system. That is the first totally automated administration of the anesthesia in May 2008. And he is the father of robotic anesthesia. I consider him is also a father of artificial intelligence in anesthesiology. And he has developed a vision for the future of anesthesia. And from airway control to anesthesia control, like pharmacological robot, closed loop for hypnosis, closed loop for anesthesia, analgesia, anesthesia robots, tele-anesthesia, regional anesthesia procedure, everything will be done by robotic anesthesia through artificial intelligence. So this is the current robotic and artificial intelligence theater what we are facing now. And here, this is the typical OT machinery, gadgets, and artificial intelligence through which we are passing every day. And anesthesiology in today's time with wires and gadgets. But my vision in 2030, AI will replace this type of complex anesthesia monitoring machine into only one button anesthesia, that is closed loop anesthesia. And they have only one button to control ventilation, hypnosis, nociception, neuromuscular, hemodynamic, temperature, and metabolic control. And there will be only one unit where you have only one button that will be asleep or awake. If you want to give anesthesia, then put the patient on asleep button. If you want to awake that patient, then put the patient on awake button. And in between, if you want to relax, then you take the coffee from the same unit. So in 2030, switch on and switch off anesthesia machine will be a reality. So with AI, hours of boredom, minutes of thrill, seconds of terror will go away, and wisdom anesthesia will be accurate. So in my conclusion, application of artificial intelligence and machine learning have shown promising result in anesthesiology. It is clear that AI will find many applications in anesthesia care in delivering real-time results. The contribution of artificial intelligence to general anesthesia have got advancement in monitors, TCI machines, and closed-loop systems. The field of post-operative pain management and chronic pain also have benefited by AI. AI will increase the training power of simulation, thereby improving education in anesthesiology. Much more work is required to understand exactly the scope that AI will play in anesthesia. But in general, AI will certainly continue enhancing the patient experience and anesthesiologist expertise. So my take-home message is artificial intelligence in anesthesia is the use of complex algorithm and software to estimate human cognition. It will never replace anesthesiologists. AI or robot will be a pilot, but we will be always there as a co-pilot. AI will definitely reduce the errors in anesthesia practice. In near future, we will all witness the changes of anesthesia practice with AI. Artificial intelligence in anesthesia put zero complication rate in our practice, which we can't recognize sometimes. Ultimately, you have to accept the artificial intelligence in your practice, which you are already practicing. So my verdict is the potential of artificial intelligence in anesthesiology changing patients' lives beyond recognition is both exciting and challenging. And the anesthesiologist has to accept the use of artificial intelligence in their future practice for learning the art of modern AI-enabled anesthesia machine monitors and gadgets. So we will be in 2030, we will be a robotic anesthesiologist, and this will be a reality. We can give the anesthesia, tele-anesthesia from our home also. Even in future, artificial intelligence will be under litigation sometimes, and we are the assistant to the robot as a anesthesiologist. So finally, we have to accept the robots and AI will be our pilots and teachers in our practice. But AI means artificial intelligence, but I also consider AI means anesthetist intelligence also. Thank you.
Dr. Choksi, it was a wonderful, nicely presented and a very elaborate description of not only the benefits, but you also pointed out very rightly the limitations of the artificial intelligence being accepted as substitute for the anesthesiologist. And as you said, the AI may not be artificial intelligence, but anesthesiologist intelligence. So very nicely said. And if there are any question, I suppose it will be taken during the panel discussion from the audience. If there are any question, we'll take a note of it. And with this, I will thank you very much again to you. And I will request my colleague, Dr. Rachita, to call the next speaker.
Good morning. So the next speaker is Dr. Tapritesh Sethi. He is the founding head of the Center of Excellence of Healthcare in IIIT Delhi. I welcome him. He will be speaking on artificial intelligence in medicine and public health, a very relevant and apt area for our institute. Thank you.
Thank you so much, Dr. And thank you, the organizers, for giving me the opportunity to speak at this forum. Let me just start sharing my screen and I'll get started. So is my screen visible? I hope my screen is visible.
Yeah, it's visible.
Perfect. Thank you so much. So I will be talking about AI in medicine and public health. I'll focus on some of the works that we have been doing at our lab and our institute during the last 6 to 7 years. But I'll start with something which is relevant to us right now as we speak. So this is, you can see the date here is 25th of January 2020, and there was a news story that said that an AI epidemiologist sent the first warnings of the Wuhan virus. And you can see that it was still not given a name. We still had not sequenced it, so we did not know whether it was a coronavirus or not. And yet we knew that something was coming. And this was done by a company called Blue Dot based in Canada. And the way it was predicted was by triangulating a lot of unconventional data sets. For example, flights data set combined with what people are saying online and so on. So which means that it was possible to combine all these different sources, heterogeneous sources of data, to actually create an early warning system for a pandemic such as the COVID-19 pandemic. And 18 months after this, we're still grappling with the surveillance of new strains as these come up. However, so the founder of this company, Dr. Kamran Khan, is actually a pediatrician and an epidemiologist now working in data science. So there's also value in domain experts actually to start venturing out into data science and machine learning, and then bringing more intelligence to healthcare. And this is not something which is just woo-woo science. They have been doing this for a long time. They have been publishing this in top venues like The Lancet. They did this for the Zika virus when it started spreading from Brazil, and also for the H1N1. So, which was just setting up the stage for the idea that we are already in the stage where AIML in public health and medicine is highly relevant and is needed. My own personal context, I did my MBBS, and then I decided to move into research and did a PhD in computational biology. And during this time, over the last 15 years or so, I've been working mostly with building models and decision support systems using machine learning and AI. So I will be talking about mostly the work that has come out from our lab, mostly in the last 7 years or so. During this time, I've been associated with the All India Institute of Medical Sciences, New Delhi, as a fellow of the Wellcome Trustee between India Alliance and the Department of Pediatrics, and the project that I'll be speaking of later as well. I am also leading an initiative at IIIT Delhi, which is essentially Center of Excellence funded by the government of Delhi, where the goal is to bring more AI, ML, and IoT-based technologies to the healthcare through research, education, and other. So this is pre-COVID time when I used to show this slide to convince the audience that we need health systems transformation and we need to move towards automation and digitalization to transform the systems in India. But I mean, this is a statement from Health Systems for a New India, a book published by the Niti Aayog, which speaks about the potential of introducing a digital transformation. This is before COVID. Now we don't need to make these statements, but these are still relevant for most of us, that we do need to move from healthcare as an enterprise towards at least healthcare as automation of some processes which can be managed by intelligent systems. And then, of course, long-term goal is having precision medicine, personalized medicine, which is a little bit far away as of now. We must go through the digitalization and the digitization and automation before we get there. So in the Center of Excellence, our key research focus is to build research in AI and ML for healthcare, capacity and skilling through courses and internships for students and faculty development programs, to connect with the industry, to see how can some of these solutions can be scaled up and can be taken to the market, and also to interface with the policy and the policymakers and implementation on-ground partners, who bring these things to the real world deployments. So we are a technology institute, and although I connect with medical institutions, we do not implement these technologies on the ground. So there we rely upon our partners. We have been, for example, partner to the Delhi government in the COVID initiative as a technical advisory group for building some of these, and also with a lot of NGOs and grassroots organizations to take some of our technologies to the ground. These are the things that we essentially have set out to solve, having data platforms and digitalization, recording, reporting, planning, new devices, education and analytics and scaling, decision platforms, predictive models, evaluation strategies of machine learning models. Because as in the previous talks, wonderful talks before this, we need more evaluation of AI models before these really make onto into the real world. So now I'll come to our own research from the lab and not just the whole center's focus or the institute's focus. And the key takeaways that I would like the audience to go away with in the next 20 minutes or so is that AI in healthcare comes in many flavors. And a lot of those flavors are already existing in the workflows that we currently do. Back in 1970s, it actually started with an expert-based AI system called the MySyn system, which was started at Stanford for guiding an antibiotic policy and prescription. But the way AI now is thought about as is machine learning with heterogeneous data. And machine learning has subfields like deep learning, as was also mentioned before, and is also overlapping with other areas such as natural language processing and so on. So which means that putting heterogeneous data sets together, where you might have structured data, unstructured data, or even no data, essentially simulating data to create what if scenarios. What if I gave this drug to a patient without actually having data on that, right? And basically letting the decision system evolve on its own. So I would like the talk to evolve in these areas where we talk about structured, unstructured, and simulated data. And in my humble opinion, the pinnacle of AI in healthcare is going to be contextual AI, because it could be descriptive AI, it could be predictive AI, it could be prescriptive AI, but unless it is contextualized into the setting, um, it may not actually make its way to the real world, because our context is very important when we take healthcare decisions. By context, I mean population, geography, even within a hospital, different departments. Think about my antimicrobial resistance. How does it change from ward to ward and department to department? So one model is not going to work. We have to contextualize it to the setting in which it is meant for, and yet have something that is generalizable. So these two conflicting things, where we want to generalize AI to release it into the open world and yet contextualize it, is the tension in the AI world about how do we bring these two things together. And I'll talk about some of this in the next 20 minutes. Let's start with AI in healthcare with structured data. And here I'll use an example from our work, which we call the Safe ICU project. It is our initiative at the Department of Pediatrics at AIIMS New Delhi, where we essentially have created a data lake for all the patients who get admitted to the pediatric ICU. And this initiative started in 2015 and supported by the Wellcome Trust TBT India Alliance. And so far, we have warehoused more than 1.5 million patient hours. This slide is a little bit old. More than 1.5 million patient hours of continuously monitored data from these patients over the last 5 years or so. And the whole idea being that without data, we cannot have AI. And without quality data, we cannot have AI. And to build quality data, I mean, we can rely upon commercial vendors, but then if we want to achieve bespoke level of quality, for example, if you want to raise a mobile phone alert when a particular sensor goes off, we need to really start from the ground up. So we did that in this ICU. It started with sepsis programs. That's why Safe ICU, Sepsis Advanced Forecasting Engine. But now we have expanded to a lot of other conditions as well. Our recent focus has been on shock, hemodynamic shock, and I'll talk about it a little bit. We started really lean by interfacing monitors, writing software and interfacing them with small credit card sized computers called Raspberry Pi, so that we don't spend a lot in buying computers and servers before we actually test it out. But once we tested these things, we really started getting data at a minute level and at a second level resolution from these monitoring machines. And that's how we built the 1.5 million hours and counting data resource at the pediatric ICU at AIIMS. One thing in being from a clinical background, I do realize is that if we just go in and say, here is a model, take it, clinicians and even I would not trust the model. We need to build trust from day zero or day one of building AI technologies. And that means that AI has to be built within the context of the system. It cannot be just transplanted unless it has been proven worldwide. So one of the things that we did was in order to create trust, we started building these dashboards pretty early on. And one of the reasons also was that AI needs a lot of data to train. So for the first 2 years, we were just building dashboards. For example, what is the quality of data? is there a mismatch between what's happening on the monitor and what's happening on the treatment charts? How is the antibiotic usage in the past 1 week in our ICU? What's the oxygen saturation range in which the baby or the child is in during the last 6 hours or 12 hours? So all of those kind of things, and for example, oxygen monitoring is a quality metric. So we actually conducted now the study is out since a long time. So we actually conducted a big data enabled study where we showed how much this can be actually modified if we showed these dashboards to nurses and clinicians. But once we had these data, we went on to build real ML prediction models. And by prediction, I don't mean look at an X-ray and predict whether it has tuberculosis, because that is actually detection or screening or at most diagnosis. By prediction, we mean in the ICU settings, if the disease onset happened at the red line in the time in the longitudinal journey of the patient, can we predict it at the black line that's here? And this gap can be 3 hours, 6 hours, 12 hours, 24 hours, depending upon what we are trying to predict. So can we look at this data before the black line and predict what's the outcome that's been calculated at the red line? And we could calculate the disease onset, for example, for shock by monitoring the shock index at every second of the patient's journey in the ICU. So, and then combining it with some other features as well. So we also built some multimodal features into our models. For example, thermal imaging was one thing that we realized early on that is a hugely untapped area where basically this could be used for making ICU decision support systems. The idea behind this is actually, again, coming from first-year medical school understanding that in conditions like shock, the center is warmer, peripheries are cooler, especially in hemodynamic shock. And then basically, can thermal imaging detect that? And you can see here is a patient, here is a child who actually is showing this reversal of gradient as they are recovering from shock to no shock. And you can see the difference in temperature between the abdomen and the feet from the left side to the right side, which recovers. And we saw that that gradient actually reverses. And then we automated the whole process using AI. So essentially, our imaging system takes the image of the child or the baby. It automatically uses something called HOG features, and now we're using deep learning as well to segment out the body parts. And we did not directly go to deep learning because the data sets were small. Deep learning requires tens of thousands or millions of images, actually. So our data sets were small. So we actually used domain knowledge to build the models, and that's why they performed well. And so the model segmented out the body parts and then calculated the gradient. And you can see that it was automated. So if you're wondering what's this dip and what's this dip here, these are just the diaper regions where the temperature drops. And it achieved more than 90% accuracy of segmenting out the body parts. And then these were fed into a machine learning model for prediction of shock, forecasting of shock at 3, 6, and 12 hours. And essentially, I had a slide here missed because of the shortage of time, which shows that more than 80% accuracy and 75% positive predictive value and negative predictive value to predict shock up to 6 hours ahead of time. So at 12 hours, it was about 70%, which we believe needs improvement. So currently, we are using deep learning strategies to take it to a video-based monitoring system, but more details are there in this paper and a recent preprint, which is currently under review and is posted on medRxiv, which talks about video-based learning using deep learning. So in the interest of time, I'll move to the next, which is AI with unstructured data, where we don't have these neatly organized data, although we had 1.5 million hours, but these were like neatly formatted as tables and backend databases. But what about unstructured data, such as clinical notes or data that exists out in the wild on the internet? What can we do with what can we do with unstructured data with AI? And this is an example where a paper in Nature last year, a letter in Nature, which is exciting because these language models, which read text and make predictions, are very exciting. So this is a paper which talks about predicting the material science properties of substances which have not yet been discovered. And that's exciting because then, just by reading the literature from the PubMed on material science, the models were able to, without looking at the periodic table, figure out what the material science properties are just by reading the text, and then also predicting. Then some of those substances were validated to really exist in the recent past. And these are the same kind of models which actually make predictions when we are typing typing in the Google search window or in the Gmail that what word should come next. These are called word embedding models. They make use of deep learning and natural language processing to understand the context of words and derive meaning from it and grammar from it on their own. So we were in our ICU building a project which was related to our previous Safe ICU project, which we call the Washkaro project, because we realized that a lot of readmissions with sepsis happened because of unhygienic practices at home. So our thought was, can we provide the right information to the right people in the right format at the right time, which means people who don't get to read things like WHO reports, people who don't get to read English news, people, for example, who need it the most in terms of hygiene. And then the right format means in their own languages as audio files, and at the right times means timely, in a timely manner. So we were using word embedding models, and I'll come to the pipeline next. But these were being built for sepsis, but became really important for the COVID when COVID struck India. So we immediately repositioned our project for WASH in COVID, and the Washkaro app was born. Essentially, what we do is we use word embedding models to look at what the WHO was saying or the Ministry of Health and Family Welfare was saying in their reports. We summarize these using AI methods and matched them using something called cosine distances and similarity scores. That how do WHO documents, Ministry of Health and Family Welfare reports, and what is being reported in the news, how do these match with each other? And the matched articles were then fed into a translate engine and a text-to-speech engine to provide bite-sized audios in Hindi, which were then basically disseminated through the app. And the users can give a thumbs up or a thumbs down to the relevance of the article in that particular context. So we were online with the Washkaro COVID app for about 4 months. After that, Google changed its policy that only governments can provide COVID information. So our app was then repurposed to tuberculosis. But for the time which we were on Play Store, we showed that the relevance of count of the articles actually increased as more and more people gave feedback, which means this is a learning public health intervention system where we can provide the right information if a crowdsourced relevance count is actually obtained. So this was one of the first apps in crowdsourced machine learning for providing WASH interventions in COVID, and was presented at the WHO. We also find, for example, that more females engaged with the app in Hindi than in English. Again, that is something which helps us in targeting that how should we design our intervention strategies going forward. Very similar word embedding models were used to track evidence as these were emerging in literature. And as clinicians, we know HCQS came in, retracted, and so many things that happened during this time. But our model, which was reading literature as it was coming, peer-reviewed literature, this is March 2020, this is August 2020. And by August of 2020, it was pretty clear that COVID is a thromboembolic phenomenon also, in addition to being just a respiratory disease. Because you can see that our word embedding models actually captured these thin streamlines of evidence. By evidence here we mean how do word embeddings came together in close association in space or in time. So between March to August, we see that a strong theme of coagulopathy, thromboembolism, acute kidney injury, etc., emerged, and we are now using it to predict what is likely evidence that's emerging next. And we showed that mental health is an emerging evidence area for COVID, and these are all available freely, openly on a dashboard publicly hosted, and papers are also available on the same dashboard. More recently, we have used language models to read the DNA. And our idea there is that since DNA has 3 base codons, very neatly organized as word boundaries, could we really read these DNA sequences and see how are, just like evidence emerging in literature, what is evidence emerging about strains and their emergence? And to our surprise, what we found was the way our word embedding models captured the spatio-temporal relationships without any human intervention or knowledge domain about what is a phylogeny, what are lineages, nothing of that sort, but it was able to organize into these structures and show that, for example, in England and Scotland are very close together in the underlying grammar space of these genomes, and in England and Brazil are distant in the grammar space. So these clusters are represented here for 16 different countries. This was trained on more than 3 lakh samples, sequences that were available on GISAID. Next, what we did was we asked this question that, are there any grammatical patterns which predict how are the new cases going to be in the next month? And not all dimensions or not all the underlying grammatical patterns are predictive, but we find that some of these, for example, this dimension 3 was actually predictive. And I'll skip the statistical analysis, you can go and read the paper, but you can see that there is a strong leading relationship in cross correlations for being predictive of new cases emerging. I'll skip the rest. We showed that this actually captured the Delta variant and the Delta Plus variant. It's currently under review. We hope to launch this very soon as a dashboard for monitoring new strains as they emerge further. In next 2 minutes, just I will show how AI can work with data when no data is available, right? You just have some environment to train in. For example, this Mario player learns to play on its own, just given this directive that you have to stay alive, gather maximum score, finish the game in the least possible time, right? These kind of things have also been used to learn to fold proteins. How do I fold the next sequence in the protein? And this breakthrough in protein folding has been achieved by using a very similar technique, simulation technique, starting from scratch, which is the reinforcement learning. This was achieved by Google's algorithm called AlphaFold 2. AlphaFold 2 basically uses reinforcement learning, and you can see that in the competition, in the worldwide competition, it beat the next best by an order of magnitude high, which led scientists to say that now basically protein folding is a solved problem, which will make drug discovery much simpler. We use reinforcement learning in our own lab to address public health problems. So when we realized that vaccines are in the second phase of trials in August 2020, we said that how is the policy going to be around that about distributions of vaccine? And we thought, can we use reinforcement learning to really, just as a Mario player learns to maximize the score, can we use reinforcement learning to minimize cases by learning the policy of distribution of vaccine across the states? And using all the contextual factors for those states, like hospital beds, deaths, recoveries, population. This is a challenging problem because it is not as simple. And we are not even considering vaccine hesitancy in this. But even without that, it's a complex problem because it's not important that if we are high at this time, but are we close to the burnout? Are we just kicking off? So all those things are important. We showed that our models actually are learning to minimize the new case rates. And this is again, the dashboard is available publicly and a paper is in second revision. So essentially we show that at all time points, we could potentially save a higher number of cases, active cases, than the current policies. I'm not saying that the current policies, because we know that there are other factors also, hesitancy and supply chain, etc. But this is something where we actually showed on this dashboard that how can we effectively learn to allocate resources. And this could be applied to oxygen, this could be applied to beds, all of that. Finally, to contextual AI, this was a paper that we had sent out, published early in 2016, late 2015, which basically talked about learning contextualized decisions for public health in India. I'll skip the details, but just a message was that using contextual AI models such as these, where you can ask, okay, if I know the state is Delhi, what should I be intervening upon? And taking it to bespoke levels. And we show that we were looking at respiratory illnesses. We show that LPG consumption across districts was the highest factor that may help in mitigating obstructive airway diseases. And we know that unclean cooking fuel is a huge contributor in obstructive airway disease, in COPDs. So I'll again skip the details, but this just wanted to say that these kind of models where we build these explainable, transparent models where a policymaker can ask, okay, if I know that this is the node, what can I intervene on by looking at it? And the transparent AI ML and contextual AI ML is probably going to be very important for the future. We also did this for learning interventions for mitigating HIV transmission in sex workers in 5 different states of India. And very interestingly, found that the most important intervention is financial literacy. Now, our partners on ground actually told the ones who work with these 5 different states, we don't directly have these data, but they actually said that it's important because women who are more financially empowered are also more empowered to say no to unprotected sex with clients. So now we are actually doing this in a pilot trial. We are delivering the intervention prospectively and seeing if what the AI model says actually worked. This was published in the NeurIPS, which is one of the top AI conferences in the computer science world. However, all these success stories look good, but there are challenges. Unavailability of large labeled data sets in medicine is a big challenge because typically medical data cannot be shared openly and experts are extremely expensive. So expert time is very expensive. We cannot just crowdsource it and send it to Amazon or Mechanical Turk for people to just start labeling an X-ray. It needs very expensive experts. Ethics and bias has been talked about in the previous talk as well, that data sets themselves are biased and we need to be safeguarding against those things. Generalization into unseen settings. One of the results that I didn't talk about today was about our ICU models actually generalizing to about 208 hospitals in the US settings and in a different age group, which is adult age group. Still, we think that we really need to test these out in many other Indian settings before we say that these will work to actually save more lives. So we definitely think, and that paper is also in medRxiv currently in review, unclear regulatory landscape. And that's a gray area because how do you regulate AI? Do you regulate it as a device? What are the legal implications of it? And who signs off? All those things. Finally, deployability needs integration into clinical workflows. The model may be extremely good. Google's model on diabetic retinopathy was excellent. But when tried out in Thailand, the challenge was workflow integration. And it could not be used as well, because it led to slowing down of the workflows. And we know that's a huge problem in India also. Concept drift, medicine itself is an evolving field. We gather new knowledge every day. So how do we take all those things into account? So it needs to be an evolving AI. So with that, I'll summarize and wrap up my talk by saying that AI in healthcare, I'm optimistic about it. But there's also challenges. We need to come together with domain experts to work together to be able to take it to the ground. There's broad range of applications. You can start with learning patterns or learn new knowledge or simulate new scenarios, but the decisions will come from contextual AI, which combine all of these together and work like an assistant rather than a decision maker in the clinical settings. So I'll stop here and acknowledge my funders, my collaborators, and my students who have made all this work possible. Thank you so much.
Thank you, Dr. Sethi. for explaining very well the critical areas in a hospital like the ICU where we can use artificial intelligence, and in areas like the present day pandemic. So here also we'll take the questions at the end of the session or during the discussions. Thank you so much.
Peripartum depression, it is a very challenging disease to diagnose, and it is also equally challenging to treat. So our next speaker is Dr. Sonali Quantish. She is professor in ETH Zurich, Switzerland. We welcome you, ma'am, to the session, and she will be delivering her talk, What are the digital health solutions for perinatal depression and anxiety?
Thank you. Can you hear me? Can you hear me fine? Hello?
Ma'am, we can hear you.
Okay, and can you see my slides as well?
Yes, ma'am.
Okay, great. So thank you for the kind invitation for this conference. Special thanks to Dr. Achitananda who invited me. Excellent talk so far, and I'm really looking forward to all the other talks following this. So my talk would be on digital health solutions for perinatal depression and anxiety. And I hope that I can talk about how AI can help in delivering these solutions. It's a little bit about myself. So presently I'm at the Institute of Molecular Systems Biology at ETH Zurich, and prior to that I spent 12 years as a computational biology group leader in pharmaceutical companies. Prior to that, I was a postdoc also at ETH and a PhD in biochemistry from the University of Zurich. So I grew up actually not very far from Raipur in Rourkela in Orissa, and I studied in BHU and IIT Bombay before moving to Switzerland. My interests right now are the use of digital health for perinatal depression and anxiety. And one of the things that I'm very much interested in is that citizens should control their own data and a new model of data privacy and security. And of course, related to this talk, prediction of depression and how can we predict response to antidepressants. So, what is perinatal mood disorder and why should we care about it? So the fact remains that 1 in 5 women suffer from some sort of anxiety or depression during pregnancy or 1 to 2 years following the birth of their children. In India, it varies from 9% to all the way to 35%, depending on where the studies were done. So these are quite high numbers, and consistently we see around 20 to 25% globally. The numbers remain consistent. However, less than 10% of women ever get screened or treated on time. And that is, there are many reasons behind it. And one of the main reasons, at least in India, is lack of adequate number of mental health professionals. For example, we have 0.3 mental health professionals per 100,000 individuals. And there is lack of consistent screening, detection, and treatment guidelines during this time, during the perinatal time, which exacerbates this this problem. From the women perspective, there is a fear of repercussion. There's still a lot of stigma associated with mental health during pregnancy and postpartum, and there is a lack of awareness that this is a medical condition and can be treated, and therefore not a lot of women come forward. And of course, there are consequences to that. And one of the big consequences is maternal suicide. And one of the kind of astonishing figures for me is that 36% of the global female suicides deaths in India, despite Indian women making up 18% of the global female population, is pretty high, and not all of them are in the perinatal period, but it is quite high figures. And then there is the problem of infanticides. There's consequences to the mother, to the child. There's economic cost as well. I couldn't find figures for India, but there is billions are lost in healthcare costs when perinatal depression and anxiety is not treated on time. And then the last 2 years have been especially difficult. The sudden lockdown without proper planning, it has made many mothers across the world unable to reach social workers and medical professionals on time. And there's been a rise in unplanned pregnancies and unsafe abortions. And this obviously also has increased the mental health problems during this time. So we have done a lot of study on why is this happening, where are the gaps, and what can we do about it. And so the current situation is we did a lot of surveys, we spoke to a lot of women, to healthcare professionals across the world, and the three main things that came out was, one is there is, as I said, there is a lack of awareness and access to screening and treatment for all women, and that is where a lot of women fall through the cracks. Second, misdiagnosis. I'll talk about this later, but self-reported questionnaires and ad hoc methods are used for screening for depression or evaluating treatment decisions at this time, and this leads to a lot of misdiagnosis. And then, of course, there's the fear, stigma, and distrust of sharing mental health problems at this time. And this is what are the three main or at least 3 steps in the right direction that we can start with that can address some of these issues. For example, patient-centric digital solution is something that can reach more women who don't have access to healthcare professionals at this time. Accurate diagnosis for depression and anxiety, and response to antidepressants and antipsychotics is very much needed. And whatever system we come up with, it needs to have trust in complete privacy, security, and integrity. And this is also something we are working on. However, today, because I'm speaking about AI, I will talk about this particular solution that we are working on in more detail. So these are the current gaps in screening and diagnosis. So it's not that screening doesn't take place, but what happens is the screening instruments that we use are not sufficiently accurate or inclusive enough to, first of all, reach all women on time, and second, diagnose them properly. Edinburgh Postnatal Depression Scale is the most widely used screening instrument to screen for depression during pregnancy and postpartum. This is a 10-point questionnaire where if you score 10 or greater, or you score a positive on question number 10, which is thought of harming myself has occurred to me, gives you a positive score for possible depression. Now, this is a screening tool. It's not a diagnosis tool. So what happens is that women who are even screened as possibly depressed, if there is no treatment follow-up, or if there is no follow-up plans in place, then they also fall through the cracks. This is a self-reported questionnaire, so there's a lot of bias in this, not only from the women's side, but also from the healthcare professional side. And then there is a huge potential for misdiagnosis, because not all women who present themselves as depressed during this time have unipolar depression. Many of them, at least a quarter or more, present themselves with bipolar disorder, which EPDS is not designed to catch. And the consequences can be disastrous, because the treatment for bipolar disorder is different from unipolar disorder. So there is a lot of chances for not catching complex mental health disorders by just going for EPDS screening. And then last but not least, it's not culturally sensitive. For example, so we are working very closely with NIMHANS, and one of the things that has come up with the conversations is that even though EPDS has been translated into many Indian languages, a lot of these context, which was developed in Edinburgh in the 1980s, do not translate into the Indian languages. For example, things have been getting on top of me is something, this is not how we talk. So there is a lot of potential for misunderstanding the questions here. So based on all this, we came up with the idea of, can we use nonverbal speech analysis and AI to accurately, well, first of all, screen and diagnose depression, and second, predict depression early enough so that we can catch it early enough. And and one of the other reasons why we wanted to do this is that studies have shown that so the first line of healthcare professional that women go to when they are pregnant are gynecologists or obstetricians, and there has been studies that have shown that the primary care professionals have a 50% success rate when diagnosing depressive individuals. So there is a potential of either over or under treatment, and this is what we want to avoid by using biomarkers that are not biased, and that is why we came up with speech. Now, speech is a diagnostic aid. It can it is one of the biomarkers. It is not the only biomarker that we can use, and that needs to be very clear that it can only augment clinical decisions at this time. It is not meant to replace clinical decisions, which are based on the background of the patient, the history of depressive disorders, and many other things. So here, prediction or diagnosis of PMD using voice features and AI should be used as a diagnostic aid, or has the potential of being used as a diagnostic aid. So before I go into how we are doing this, let me clarify a little bit more about how human speech works. So human speech, it's a very sensitive output system. It is even slight physiological or cognitive changes can lead to acoustic changes, which can be then measured and analyzed. The process of speech starts with the intent to speak, which then gets mapped into the language code inside our brain. And then it is stored into this short working memory, which then generates neuromuscular commands for our vocal cords, vocal folds, and our muscular action of the lungs as a source and filter operation to vocalize our speech. Now, what happens is that when we have cognitive disabilities or let's say cognitive impairments, this short-term working memory gets affected, and that in turn affects the vocalized speech. And this is what, so the speaker, it executes neuromuscular commands which can then be analyzed as acoustic. The vocalized speech can be analyzed as acoustic features, linguistic, or affective features, which means that we can look at just the duration, voicing, intensity, pitch, or timbre of the voice, or we can look at the linguistic features, that is, how is the semantics, what are the pauses, what is the syntax of what the person is saying, or affective features, as in, is the person speaking with confidence, with empathy, with sincerity? And all these features can be then looked at and analyzed in more detail to predict or to diagnose whether this person has cognitive impairments. And this is not a new field. There's been a lot of research that has gone on in this area. For example, in this paper, this shows that all the acoustic features here have been looked at in various psychiatric disorders to see whether they are they show increase or decrease in features, and this is one of the ways in which we can, even for schizophrenia or dementia patients, where you cannot go for affective or linguistic features. You can look at the acoustic features and try to find out whether we can predict cognitive impairment there. So there are a lot of speech recognition data sets, as I said. So for example, there are automatic emotion recognition data sets, many databases that have captured these data sets. There's emotion speech synthesis data sets, data sets for medical applications, many data sets. But as the previous speaker, Tav, who gave an absolutely fantastic talk, by the way, and I missed seeing him in Zurich when he came to talk, which I hope he comes again. But as he spoke about contextual AI, the thing is, there are many data sets out there, but are they the right data sets? And I completely agree with it, is that if you do not start with the right data sets, then there is more potential for bias and misdiagnosis than when you don't. So there are many speech data sets out there, but are they the right data set? AI systems, they learn to make decisions based on training data, and many other previous speakers from me, they have articulated this in detail about how what kind of what kind of algorithms can you use, what is the process, but one thing remains constant, is that if you don't feed the right training data, the output is not going to be what you would like that. And when we looked at these databases, well, they do look at all these emotions, anger, sadness, happiness. But the thing is, postpartum depression is sometimes can have all these emotions together. Postpartum rage is a huge symptom of postpartum depression. But then there's also stress, and there is also dissatisfaction. So would you take these data sets together or not? And when we looked at it, there are no training data sets out there that evaluates voice-based emotion recognition in pregnant and postpartum women. And this is a huge problem in this space, because gender data gap, it's a huge issue for using AI in pregnancy. When we think about using any kind of machine learning, any kind of artificial intelligence for this subpopulation, one of the things that always stands out is how little data is out there, and it's for historical reasons that women were not included in clinical trial. Pregnant women have not been included in clinical trials for the right reasons, but there's also a lack of real world data. Structured real world data, or the correct kind of data. And why is it important? Well, the thing is, if we are going to look at voice changes during pregnancy, or changes in voice, one of the things that happens is that voice change, there is a change in the pitch, the timbre, the frequency in voice during the third trimester in pregnancy. This has a medical term as well. Now, the thing is, if we only take voice samples from women who are not pregnant, or from data sets, benchmark data sets, then we will possibly miss out this, or even worse, misdiagnose that a woman has postpartum depression. There is a bias in a lot of algorithms which are out there. For example, Google's speech recognition algorithm, it is 13% more accurate for men than it is for women. And Google is actually the highest performer when you compare it to Bing or other IBM systems. There is a bias because a lot of this algorithms, they are not trained on the right data sets. And what I mean by the right data sets is that it is not trained on, it does not take into account gender, it doesn't take into account race. As I mentioned, a lot of these data sets before, they have been trained on the European ethnicities. So this is something that we want to avoid when we come up with a voice recognition algorithm for diagnosing and predicting postpartum depression, that we do not force fit it into populations that will not benefit from this. And this is something that Tav put very eloquently in his presentation as well. So the problem is there's a significant gender data gap for pregnancy and postpartum, and which means that any use of AI for this subpopulation is particularly susceptible to bias. So that is why we thought, before we can go ahead and do any kind of machine learning or any kind of AI to diagnose or predict depression, we have to first generate the right data sets, generate it in the right context, in the right population, and then go ahead with AI. So what we have done is we have created a web application that has created a remote monitoring system where women can log in and record their voice and have access to self-care, peer support, and professional support, which will incentivize them to use this solution. And while doing that, with their consent, we can then use their speech samples to do feature extraction, as in extract all these features here, and then do statistical modeling or machine learning using different, then look at the mental state. And so the advantage here is twofold. One is you are deploying a solution that can be used in the real world, because speech samples that are read from a particular paragraph that does not reflect the real world. Second, you can basically give access to care to women who do not have access to care. And then the third step is, we have, along with our collaborators in the University of Alberta, we have looked at benchmark data sets that are closely related to depression and anxiety, to look at different algorithms to see which performs best. And first, we would like to replicate this in our data sets. And then we can release the product for early detection of PNDs. As I said, it is very important with the context of where we want to release it, and so the studies that we are doing are in NIMHANS in India, so that we take the cultural context and the healthcare context, healthcare system context into place in India, and also in Switzerland with the university hospitals here. So this is where we are right now. We have the digital web app that we are testing right now in India while collecting voice samples. This is the features of the app, so that we can work with the gynecologists and the obstetricians to provide care early on, and remote care to every woman who needs it. And at the same time, can we screen, and I didn't talk about this, but to use AI to enable prediction and screening, at the same time use predict treatment response to antidepressants and antipsychotics. This is one of the areas that, so I don't have time to go into this in detail, but this is also one place where there's a huge gender gap, data gap, and we need to generate this data in order to do any kind of machine learning. So what we are trying to do is we are collecting data from women who have had or who are being prescribed antidepressants or antipsychotics, and looking at many different features to see is there something that we can use to predict response. And the reason is because as they have been excluded from clinical trials, a lot of this is trial and error, and we need to do better for prediction in women for response to treatment. And of course best practices, and this is something that I think task shifting for postpartum depression, for looking at postpartum depression is very relevant, because lack of mental health professionals, access to mental health professionals, means that a lot of women are not referred to them. And if we can train primary healthcare professionals to just go for best practices, and then a lot of women can also be treated on time. So that was all that we are doing, but there is a lot of use of AI and machine learning in perinatal mood disorders. There's been a lot of studies, and there's this artificial intelligence in pregnancy for those who are interested. It's a scoping review which came out recently, and as you can see, there's a lot of different algorithms that have been used to look at prediction of postpartum depression, perinatal depression intervention, prediction of labor complications, or preeclampsia. None of them have used voice, and once we start using voice, we are also thinking of using other multimodal features such as video and stress indicators to see if we can improve the model. So the key takeaways here are that perinatal mood disorders are a global epidemic. It really needs urgent attention, and because it has been made worse by the COVID pandemic. Digital solutions mitigate, at least in part, the lack of access to timely care that currently exists. Current screening methods, they lack the cultural sensitivity, specificity, and complexity to address this, and we need to have other methods of screening. So one of the methods that we are currently looking at is voice and AI-based screening and diagnosis, and because it offers a non-invasive, easy to access solution, but in order to do that, we need to have training data sets that adequately represent the cases that we want to test. And so before doing any AI, any machine learning, deep learning in this subpopulation, we first need to address the gender data gap. And if you are a healthcare professional who's working in this area, please reach out to me or the group, and we'll be really happy to collaborate with you, because we really need to address this right now. Our group and an excellent set of advisors. Thanks to them, this is obviously not a work of one person, and our collaborators in India and in Switzerland, who have been absolutely a delight to work with. Please reach out to me if this topic interests you as well. I'll be happy to talk to you, or if you have any questions that I cannot answer today. Thank you, and I'm looking forward to the questions, or maybe later in the panel discussion. Thank you.
Thank you, Dr. Sonali, for having us such an excellent talk on why we need to have digital solutions for perinatal depression. So as we all know, India faces a huge shortage of mental health professional, and equally you highlighted that there is a stigma which is attached to the mental health disorder, and females, they are not coming up for diagnosis of their diseases. And you very accurately highlighted how the speech therapy, how the speech can be recognized by the artificial intelligence, and it can give us the speech biomarkers for diagnosing it. Thank you so much for highlighting all the nits and bits of this talk. Thank you.
My pleasure.
I think with this, we come to the end of this session. And I would like to thank, along with both the co-chairs, thank the organizer and Professor Alok Agarwal for inviting us to be a part of this session. Thank you very much.
Thank you, ma'am. I'd like to request our Dean, sir, to kindly come on the dais and present memento to the chairpersons. And now we'll be starting our most interested session, a panel discussion on artificial intelligence. May I request the chairpersons, Professor Dr. S.P. Dhaneria, Professor Dr. Virat Galhotra, and Professor Dr. Padma Das, to take their places on the dais. And the moderator is no one else but our Director and Chief Executive Officer of AIIMS Raipur, Professor Dr. Nitin M. Nagarkar, sir. And the session is important because it is giving you an insight into what is artificial intelligence and how to go about it. The learned panelists with us are Dr. Mahendra Bhandari, Dr. P.K. Sinha, Professor Vikas V, Dr. Sonali Quantius, and Dr. Karthik Taneja. You can see them already there on the screen. So I hand over the mic to Professor Dr. Nitin M. Nagarkar, sir.
Thank you very much, Professor Alok Agarwal. And he's been the main force regarding this particular CME on artificial intelligence in healthcare. And we've heard the learned speakers since the morning, and wonderful talks and a lot of insight regarding role of artificial intelligence, first of all in our life, in the ways we are going to live our lives in coming decades, and of course, especially in healthcare. We now go to the panel discussion, and again, we've got glittering specialists with us. But before that, I thank the chairpersons, Professor S.P. Dhaneria, Professor Padma Das, Professor Virat Galhotra. We'll also be joined by Dr. Taneja online, who will be the chairperson also. My special thanks to National Academy of Medical Sciences, Professor Churamani Gopal Madam. Our special thanks to our president, Professor George D'Souza. He is also going to join us online very soon and will also be the chief guest for today's function. So without wasting any time, we go straight to the panel discussion. We've got panelists, Dr. Mahendra Bhandari from US. You've just listened to his wonderful talk on robotics. He's one of the senior most in this particular field with decades experience. The last time we met physically was in Jodhpur, sir. I'm sure Professor Bhandari remembers that wonderful conference which was held at AIIMS Jodhpur. Dr. P.K. Sinha, the Director and Vice Chancellor of the Triple IT here in Naya Raipur, and you listened to his talk in the morning. It actually set the tone for today's discussion. Professor Vikas V, who joins us from NIMHANS Bangalore, and he has a lot of experience regarding the role of particular AI and robotics in neurosurgery. We have Dr. Sonali Quantis, you just listened to her. She's from the ETH in Zurich in Switzerland, and she's talked about the perinatal mood disorders. We're also joined by Dr. Karthik Tane from the UK, and he represents Google there in the UK. So thanks very much, and I'm sure that my panelists are able to listen to me. And I will go to the first question now. Before that, just again to set some tone regarding the role of artificial intelligence in healthcare. We all know, I think it's just a repetition because it only goes to show the importance, is artificial intelligence is the development of computer systems that are capable of performing tasks that normally would require human intelligence, such as decision making and solving various complex problems. And you know that in AI, like has been discussed right since the morning, the various use of complex algorithms and software to emulate human cognition in the analysis of complicated medical data. And AI is the ability of the computer algorithms to approximate conclusions without direct human input. So my question first is to Professor Bhandari, sir, because you've already talked in detail, but still, I mean, what role will artificial intelligence play in the future of medicine? So this question is for Dr. Mahendra Bhandari, sir.
Thank you, Dr. Nitin Nagarkar, and I very much, very fondly remember our discussions in Jodhpur, and thank you for inviting me. First thing I would like to address the negative impression about any technology. And that attracts the attention because for the simple reason that it really disturbs our comfort zones, you know. When the robot came, we had the similar arguments, and endoscopy came, the same thing happened. I feel that, and medicine should see in other areas like gaming, like business intelligence. And Amazon is exploiting, Dr. It was told previously that and it's known that even before you get your packet or think of ordering, it is already lying, and they are all algorithms working. If your Tesla car drives much better than you, I don't see that the technology is any different, but it is the difference. And I understand that medicine, we are dealing with much more sensitive issues like patient lives and human beings, but certainly cars are also dealing with human beings on freeways. So technology is there. Only thing which lacks is the medical personnel, because building AI models and seeing it through effective clinical practice tools needs much more beyond collaboration. It needs to really work with the team. You need to really, even whether you understand or not, to understand their viewpoint, and they need to understand our domain knowledge to do so. I think it will play a big role, and there are success stories, and there are reasons why it is not advancing. But if medicine doesn't exploit the enormous power of computer and the growing connectivity speeds and availability of data, India particularly, because I have spent my most of the best period in India for 47 years, and I am in US for 15 years. So what I can tell you that India has enormous power of the data because of sheer volumes, great infrastructure, great surgeons, and institutions like AIIMS. I think they should take a lead. And as the previous speaker said, that it is really, Dr. Sethi's speech was wonderful on giving the reasons why the models don't work, why we don't focus on the data. I think it needs a major shift from our familiarity with the known variables, giving relational databases and making generic predictions. Then we have to get to the personalized medicine. So I think it has a great scope.
Thank you very much, sir. Absolutely, it's got a great scope in future. And as we know that artificial intelligence has been enhancing, the various activities in our daily lives and will come in years to come. Various areas where we are expecting that AI will play a role. Healthcare is definitely one of them. And of those, whether it's radiology, drug discovery, patient risk identification, patient monitoring care, analysis, and the list is huge actually. So there will be so many ways in which it's going to affect our lives in times to come. So my next question is to Dr. P.K. Sinha, the director of IIIT Naya Raipur, and we are already working together in many activities here for the last few years. So my question to Dr. P.K. Sinha, sir, is what are the specific challenges in deploying AI in healthcare? Dr. P.K. Sinha, sir.
Yeah, namaskar. First of all, I'm thankful to Dr. Nagarkar for giving me this opportunity to be part of this intellectual deliberations that are happening today. So actually the challenges, some of the challenges have already been addressed by some of the previous speakers. While we are marching ahead in the technology front, the acceptance and collaborative effort, I feel, needs to be increased, as Dr. Bhandari also mentioned. One thing is whether the doctors and patients are ready to accept the technology, whether it is actually robotics in healthcare or other types of intelligent machines in healthcare. What we are actually seeing is basically it should be assisting human being rather than replacing human being. So once it is assistance, like we use assistants during the expert surgeons, they use assistants to actually help them, but actually the major part of the surgery is performed by the specialist. So same way, we are actually seeing that the acceptance will be there only if these machines are actually serving as assistive devices, not as devices which will actually do the job of the experts. The second thing is the patients. Actually, a lot of discussions were there where machines will be able to actually interact directly with the patients, but the emotional quotient, the acceptability by the patient, are the patients ready to be actually treated by or to be actually guided by the machines in their healthcare? The second thing is regulatory. Regulation is another thing. And answerability. Who will be answerable if there are actually, because this is the life and death type of in medicine and healthcare, a lot of things actually happen where we are directly dealing with human life. So who will be answerable if something goes wrong? That was very nicely covered by Dr. Alok Agrawal. Okay, and many such things are there where the acceptance is going to become a big issue, and our psychological barriers actually have to be addressed in addition to developing the technology. So I'll stop there. Maybe others have to add to this.
Right, sir. Absolutely. I think you very well summarized it. And I think Dr. Alok also in his previous lecture has mentioned. Obviously, there is a lot of highly sensitive data, which is the data privacy, the confidentiality of the data. And many health systems are still not equipped to process the massive amount of data that is produced. And definitely what we have also been discussing is the empathy and the emotional aspect, which may not be there with the machines, the helping human hand, which is so important. So my next question is to Dr. Vikas V from Nimans, Bangalore. And the question is, will AI worsen the disparities in healthcare? Because we are talking of a futuristic technology for healthcare. So will AI worsen disparities in healthcare? Question to Dr. Vikas V.
Thank you, sir. Thank you for inviting me to this talk. It's been a wonderful day so far. And the only sad part of the story is not being physically in Raipur, which I would have loved to. Thank you all for being in part of this meeting. Now, each step in technology has been looked at as a method of improving patient outcomes and in general the lifestyles of people. So every technology which has come, like Professor Bandari spoke about endoscopy or robotics, came with an idea that the technology solves some particular problem. Now every solution is in that realm. AI in particular has this advantage. It's far more democratic than many other technologies such as robotics and maybe even computer science. Say with the availability of devices on which these systems run, we have a last mile connectivity which has been unparalleled in human history. So it is that which is going to leverage and make it a more equitable solution than many other technological solutions which we have seen so far. Of course, having said that, there is always going to be a marginalized group who do not have access to even smartphones or any other kinds of tech, which is going to. But ultimately, every technology looks at improving the front line. You know, we cannot look at a solution which can take care of every single person in the planet. So the front line changes, the front line becomes more inclusive, and that is what is the core principles of AI. The technology, the controversies, the ethics, of course, that is all part of this part of the problem. I mean, we cannot have the Amrit without and say that there is no wish associated with it. So it's always part and parcel of any new technology, and we have to acknowledge and accept. AI gives the advantage of leapfrogging a lot of technological barriers. Barriers, if you remember, the closest example which you can think of is the telephone with a line. A telephone with a line had a lot of problems in connecting every single person in this vast country. But mobile phone networks and newer platforms ensure that that problem is completely off the table. So that's the kind of leverage which AI would give to the healthcare profession in the next coming decade. I think we are in the first year. The decade is going to be very exciting.
Yes, thank you, Dr. Vikas. Absolutely. Rather, it's going to help us in future, and it will address issues of access to healthcare facilities, particularly for a country like ours, which is a large country with rural areas, and that area suffers from poor connectivity, limited supply of healthcare professionals, and this can be done through AI-driven diagnostics, personalized treatment, early identification of potential pandemics like we've been facing this time, and imaging diagnostics. So my next question now is to Dr. Sonali Quantius, and she has already shown how important it is to utilize AI for the various mental disorders. So the question is, can artificial intelligence replace humans, that is doctors, medical care professionals, in the future?
Yeah, so thank you. A very loaded question. So thank you again for inviting me. I think it has been absolutely wonderful learning about AI. I'm not an expert by any means, but it has been great to see how AI is being used in the healthcare context, apart from my field of expertise. So coming to the question, will AI replace doctors? Well, the obvious answer is no. But there are nuances to this answer, which I'll go into detail. Medical doctors are healthcare professionals. They have been trained first as generalists and then specialists to go deep into detail about a patient's, about the human physiology, about how to deal with patients, what to take into context. So there is a diagnosis issue, and then there is the treatment issue. And AI is, I mean, AI is a broad term. I will use machine learning in this context. Machine learning is a tool that can learn from data. But what it lacks right now is the dimensions that I think medical professionals bring into the field. That is the dimension of understanding the context beyond what the data provides. And so the data that you feed into the system, let's say for machine learning, will never be able to encapsulate everything that you need to make into a decision. There will always be gaps in that data. And that is the gap that I think personally that you will never be able to predict in order to make that diagnosis or treatment. That is where I think taking into context the patient history, the a lot of the treatment decisions or the diagnosis decisions are made from past experiences that a data will never be able to have in detail that the doctors have that that separates a human uh, prediction versus a machine prediction. So in the present, absolutely not. I do not think AI is going to replace doctors. But having said that, there are certain context, which is a particular part that a machine can do better than a human being or even a whole department can do, is access to data or information that a single individual will not be able to have. And that is why I think there are nuances to this question, as in AI will never replace doctors, but it can hugely augment the decision making capabilities right now that medical professionals have. Second, I also think that a technology, a tool such as machine learning will always have um, it's a self-learning system, and so it will always need to have medical professionals, computer scientists, social scientists, everybody together to 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 make it better. And I think that is why it will not replace, but there is a huge chance that it will be a commonplace in 10 years' time to augment the clinical decisions that medical professionals do.
Can't replace what the doctors do, but definitely the time has come where the technology which is there will be complementary to performing these various tasks, whether it is surgery, whether diagnostics, whether applications to different fields. So my next question is to Dr. Karthik Taneja, who looks after the sales of Google in the UK. So I think he's the right person for this question. So what is the future of artificial intelligence in the healthcare market?
Thank you very much, Doc Saf, for inviting me, and very nice to be on this very esteemed panel. And also a big hello to everyone over there in Raipur and online as well. I think it's a very good question. I think, if you look at the business of healthcare through artificial intelligence, I think the time is right for it to have a massive impact. And I have been listening to all, for a long time, for all the panelists who've been speaking about it. But also, I think there is a tremendous opportunity to have a major impact on how public health and how health of general populations is looked at, is managed, and is taken care of. So in terms of the technology is there already. There is massive amount of work that is already being done in machine learning, in data science, in predictive data analytics, in overall well-being, and that technology is now being used to solve some real challenging problems that we were not able to solve till now, despite our tremendous intellectual capability. So just take some examples. Like, we have now started developing some very interesting tools and solutions to look at all aspects of healthcare, whether it starts from preventive healthcare, public healthcare. You spoke about robotics, surgery, and so on and so forth. And there is a tremendous market. I am of the firm belief and opinion that this market is going to explode with with technology, tools, and gadgets, which will define the future of healthcare. And this will have the kind of impact that we have not seen over the last hundreds of years. Every year, obviously, every year technology advances. Every year we see great progress in the use of technology, artificial intelligence, so on and so forth. But the rate of technology is accelerating. It's not just doubling; it's accelerating at an unknown pace. And in fact, even we, when I was at Google and now at different companies, we are all actually now behind it and are trying to catch up with the pace of accelerated technology change. And this always happens whenever technology comes up. The technology comes up, then the consumers start adopting it. For second, the professionals start taking up. Third, the consumers start adopting it, and finally, the government and policy catches up. So, I think there will be a huge traction over the next decade or two, and we'll see a tremendous change in the whole market and dynamics and the business of healthcare going forward.
Well, excellent. I think it's absolutely the way forward, and we expect that this particular segment will continue to grow at a very high pace. And in the next few years, we expect that it will not just the developing or the developed countries, the whole world is going to witness this change. So I think before we go back to some more questions, there were questions I think which were being asked by the participants who are online through their chat boxes. So there's a question which I think I'll pose as we have received. The first question is, sir, to Professor Bhandari, sir, and it's from Dr. Chetan Anand, who wants to know something about AI in surgery. So the specific question is, the human resource required to teach algorithm models and pattern recognition is huge, and how to utilize the trained resources in India towards this end?
I think it's a very pertinent question. Before that, with your permission, I would like to say a few sentences about how technology is taken and AI is not different. Could I say something and then I'll answer the question?
Sir.
See, take doctors. We have been solving problems of the patient, taking help from anything, whatever it may be. And I don't see why patients have accepted robotic surgery, not because robots are scary or something. Henry Ford was the birthplace of Vattikuti Urology Institute, did the first robotic prostatectomy with Da Vinci. And I know the first patient. I was not here, but I have been in touch with Dr. Menon since he started. The first patient who you tell that your prostate would be done with the help of a robot and we have no experience. And you know what was his answer? He said that, look, I have been working in Ford company and we have been using robots since time. The Detroit was a hub for robotics. We have been using robots, and I can tell you that robots do much better than human beings. So even if you have not done, take my confidence and do it on me. I'll be the first patient.
The reverse, yeah.
So what I'm trying to tell you that all these negativities would be addressed. I don't say that ethical issues would not come, And as very rightly Karthik said, that this is the way it follows, that they would be unscrupulous people, they will exploit it and the law will take over. But the technology, as long as it is improving patient outcomes, I don't see any reason why it would not do. Now, answering the question of manpower and the time constraints, I will tell you that I work on live donor nephrectomy, so I deal with transplant surgeons. Transplant surgeons are mainly urologists and transplant surgeons and extremely busy. And we have an undertaking that we will build the deep learning models for them, computer vision models. But they have to label the data because we don't have resources to label the data. And besides that, it's a very domain specific data. If you are labeling, as Sonali said, that if you are labeling it as same thing for numerical data as well as video data, if you are telling it's a testicular vein, how would you expect the model to pick up that until you have rightly labeled it? So we had a condition that we will turn them into pre-processing, turn them into frames, and we'll give them jobs and they'll annotate the data. You will not believe 3 transplant surgeons have come back at home at 10 o'clock and they'll do 200 or 300 images. They'll do multitasking and keep doing something else or attending the calls and all. So I think it is a matter of interest. In other images and car industry, there are a whole lot of commercial people who are labeling the data. But let me tell you, it's not very far off when automation is coming even for what you call supervised learning models. Like we annotated and we reduced our image selection from 40 to 74% simply by automating and using AI and using some ground truth models to improve the selection. So automation is going to take place. I think there is enough possibility, and I was trying to suggest to Dr. Nagarkar, we probably talked in Jodhpur also, this has to be linked to something symbiotic. You can't use a resident to label the data only and give him his name in the paper. I would say perhaps data labeling, according to me as a surgeon, is the best way to teach surgical anatomy to your students than cadavers. I can see you, I studied from MBBS like every surgeon, and then we did the surgical anatomy is totally a different ball game. And I would recommend that somebody has to be bold enough to begin somewhere and teach the anatomy of surgery of any organ wherever you have and link up with the data labeling. So I don't think it would be a problem. It is the problem of your familiarity. We feel that it is totally a game of technological people and computer specialists who knows Python and R and all kind of things. No, you don't have to know all that. Only thing you have to have interest because you are sitting on gold mine, data is with you. You have a knowledge about that data. And without you, no computer expert can really make sense out of that data.
Thank you, sir, for very nicely explaining. One question is from one of the participants, a basic question. What is the difference between AI and IoT, Internet of Things? I think no better person than Dr. P.K. Sinha, sir, to just explain the basics for the participants.
Okay, very quickly, Internet of Things is the next generation of the Internet. And the previous generation of Internet, actually data had to be fed physically by human beings, okay, because it consisted of only computing and computer devices. However, we realize that as long as we feed data physically to the internet, the amount of data acquisition will be limited, and only what we feed will actually get into the system. So the technologists came up with the idea of smart objects which have sensors of various types. Like in healthcare, we have temperature sensors and other type of sensors. Similarly, in the real world, we have a lot of different type of physical sensors associated with objects. And the idea was these sensors will automatically actually sense different type of parameter, contextual parameter, and will feed to the internet or the system. So what happened in Internet of Things is objects and data acquisition, smart objects came in addition to the computing devices which were connected to the internet, and the expansion of internet happened from computing devices interconnection to also interconnecting these smart objects. And because of this, the acquisition of data started happening automatically, like we see cameras fitted everywhere, and the cameras automatically capturing the movements, the images, etc. Okay, for at different places, and later on, when required, we analyze the images, we analyze the videos, and try to actually find out what happened because of certain crime happening at certain place or certain type of things to be analyzed to be. So Internet of Things is basically expansion of internet to actually automatically capture data from the environment in which that actually device is lying, and this is very important for contextual and automatic data acquisition. Now, AI actually, as we have been discussing since morning, works on data, data, and data. Okay, the more data we have, okay, the more decision making will be accurate. Okay, so actually, IoT is fueling or it is accelerating AI research. So that's what is the basic behind AI and IoT. I'll stop here in view of the time. Thank you very much. I hope this makes it clear. IoT is actually accelerating AI, okay, because the data acquisition is happening automatic.
Thank you, sir. Thanks very much for explaining very well the difference between AI and IoT. I think we are coming to the very end of the session. So I think we have one question, which I think I'll give to Dr. Karthik Taneja. Is it possible to have emulators as a precursor to AI robotic surgical systems? Dr. Karthik, please.
Yeah, sorry, I was muted. So I think there are a couple of things to look at it from that perspective. Though I'm not the best person to answer this question, but I can give you a general understanding of how the robotic systems are evolving, and what is the future of that. Now, if you look at it, there is a company by the name of Boston Dynamics. I would suggest you go and have a look at it. The way the robotic science has evolved over the period of the last 10, 15, 20 years is just massive. And now what we have seen is that the robotic science is getting into each and every field of human endeavor, whether it be medicine, of course, and surgery, of course, but also in terms of sports, in terms of military combat, in terms of managing traffic, in terms of managing crowds, etc., and even in surveillance and crime management, etc. So the science of robotic is increasing at an accelerated pace. We have also seen the increased intervention in surgeries, and where very a huge amount of precision is required to drive that forward. So there are three things which are kind of driving this. Number one is it is becoming cheaper and more efficient and more precise. Number one. Number two is the technology itself is becoming all in all more pervasive. And number three is it is able to collect data, use machine learning, and improve on its own to drive better efficiencies and better outcomes. So I think there's a very, very bright future on this, and it will continue to grow over the next many years.
Thank you very much, Dr. Karthik, for explaining very well. So I think now we come to the end of this particular very brilliant session, I think, by the glittering participants here. I think Dr. D.K. Taneja wants to make a comment, sir. And then Professor Dhanire will please take over.
Thank you so much. Sincere apologies for joining you late as I was busy in another Zoom. And this is the panel discussion on all the newer technology and about the artificial intelligence. And I have just whatever I've heard it. You see, there is a fear whenever there is a new thing coming up. I am now 80 years, and Dr. Surochuramani, same age group, we all people, like Mahendra was telling, that how we train ourselves just by examining and clinical examination, and now we have come to the robotics. So whenever there is a new technology coming, there is always a fear whether we will be able to adopt it, whether we will be able to bear the cost of that, whether what will happen to the manpower, whether we like to have undo with many of the staff that we are having it. But we must not forget that technology will always take over. And this is what we have learned ourselves, computer, we have learned image identifiers, we have learned the use of geometric tracing. Now we are using a computer navigation in our all joint replacement surgeries. So all these things we have learned over the years. And eventually the overall outcome of the result of are better, which is for the benefit of the society. It has been a great honor to have all the eminent speakers from all over the world who have been here, and our president, Dr. Surochuramani, and our secretary of the National Academy of Medical Sciences, Dr. D.K. Gupta, an eminent pediatric surgeon, and this is under the banner of National Academy of Medical Sciences, and I, being the chairman of the CME committee of the National Academy, I once again thank you very much for being with us and taking part in this enlightening discussion on a very, very important and a burning subject. Thank you very much.
So, in this session, I, with my colleague, chairpersons, express sincere thanks to Dr. Mahendra Bhandari, P.K. Sinha, Professor Vikas, Dr. Sonali, Dr. Karthik Taneja, for participating in this panel discussion and sharing their views in this panel discussion. This session has been a session of very fruitful learning for all of us. I also express sincere gratitude to Professor D.K. Taneja sir, my teacher, for sharing his views. So on behalf of all my co-chairpersons, I express sincere thanks to our director, Professor
Please unmute.
Thank you, sir. Moving on to the inauguration ceremony, I'll like to request Professor of Department of Physiology, to kindly come forward and conduct the ceremony. हाँ सर.
अभी
A very warm good afternoon to all the dignitaries, guests, members of AIIMS Raipur family, and delegates with great joy. On behalf of organizing team, myself, Dr. Ekta Khandelwal, welcome you all for CME on Artificial Intelligence in Healthcare as a part of NEMSCON 2020, organized by AIIMS Raipur. As we have discussed a lot about artificial intelligence, this is just a few words regarding it. Artificial intelligence in healthcare is an overarching term used to describe the use of machine learning algorithms and software to mimic human cognition in the analysis, presentation, and comparison of complex medical and healthcare data. With this small introduction, now I invite dignitaries to the today's CME with request to come on the stage and occupy the distinguished chair. Please give them a warm welcome. Sir, please. Kindly give them a warm welcome. Our esteemed director, sir, Dr. Nityanand Nagarkar. Our dean, sir, Dr. S.P. Dhaneria. Organizing co-chairperson, Dr. Alok Agrawal, and our organizing secretary, Dr. Amit Chauhan. Rest of the dignitaries are present with us online. I'm profusely elated to extend floral welcome to all our esteemed dignitaries. I welcome our honorable chief guest, Professor Dr. George A. D. D'Souza, President AIIMS Raipur. We feel honored to have you with us, sir. I thank him for providing his gracious presence to join us today to enhance our joy. Sir, we welcome you. Now may I request Dr. Alok, sir, to present flowers to our dynamic director, sir, the man of distinct vision and a fountainhead of illuminating ideas and the inspiration to all of us. We welcome you, sir. Give him a big applause, please. Now, we extend our welcome to our respected Professor Dr. Saroj Chudamani Gopal Ma'am, President NAMS, and Dr. D.K. Gupta, Secretary NAMS. Welcome you, ma'am and sir. Thanks for your gracious presence. May I request Dr. Padma Das to present flowers to our respected Dean, sir. Dr. S.P. Dhaneria is an idol of knowledge and experience to all of us. We welcome you, sir. We welcome you, sir. Now, may I request Professor Meenakshi Sinha to extend floral welcome to Dr. Alok, sir. Madam, please. Give him a big applause, please. Thank you. Now may I request Dr. Santosh Rao. Now may I request to Dr. Santosh Rao to extend floral welcome to our organizing secretary, Dr. Amit Chauhan, sir, please. Thank you, sir. Light fade away, darkness. Light symbolize knowledge and wisdom, free will. Now may I request all our respected dignitaries to illuminate the lamp and begin the CME. Please, sir.
शास्त्र संगम सा है अनुपम ज्ञान तीर्थ अकादमी अमृत संचित ममोदधि से आयुर्विज्ञान अकादमी शोध माया विकल्प आयुर्विज्ञान अकादमी अमृत संचित महोदधि आयुर्विज्ञान अकादमी ज्ञानोदधि का कलश मनोहर ज्ञानोदधि का कलश मनोहर आयुर्विज्ञान अकादमी विद्वचन सागर मंथन से सिद्धिक भव्य अकादमी मास अप्रैल 1961 दिवस 21 साकार हुई ज्ञान ज्योति।
Thank you so much to all dignitaries. Now it's a time, we are not wasting much time. I would like to invite the backbone of the function, Dr. Alok Chandra Agrawal, for his welcome address. So,
Please put the slides on. So, on behalf of All India Institute of Medical Sciences, Raipur, and with the blessings of our director, Dr. Nitin M. Nagarkar, sir, I present this welcome address to you all. Professor Dr. Alok Chandra Agrawal, also Associate Dean Academics and the head of the Department of Orthopaedics, and I welcome you in the capacity of being the organizing secretary for this conference. This CME is being organized under the aegis of National Academy of Medical Sciences and is a part of NAMSCON 2020. We are happy to have the blessings of Professor Dr. Saroj Chudamani Gopal as the President of the National Academy of Medical Sciences and Dr. D.K. Gupta, the Honorary Secretary. First of all, I would like to welcome our chief guest, Professor Dr. George A.D. And we are thankful to him for permitting this CME and giving his time to be the chief guest and monitoring each and every. I welcome you, sir. I welcome Professor Dr. Saroj Chudamani Gopal, Madam, the President of National Academy of Medical Sciences, for having faith on us, the ability of our director, sir, to conduct the National Academy of Medical Sciences. I welcome the Honorary Secretary of National Academy of Medical Sciences.
Hello.
Who has got to come out with the functions at the time of COVID-19 pandemic. And is the Director and CEO of AIIMS Raipur. I welcome you conference. With the technical guidance, we have been able to conduct this program. Mute. I would like to welcome our speakers of eminence, the foreign faculty, Dr. Mahendra Bhandari, a robotic surgeon, the first robotic surgeon, Dr. Karthik Taneja, the former CEO from Google, from UK, Dr. Sonali M. Quantius from Switzerland, a child from Raurkela who did her PhD in Switzerland and now has come to this great position. Professor Dr. Saurabh Vashne, the Executive Director and CEO from AIIMS Devgar as one of the faculties. Professor Dr. Sanjay Vadhva, the head of the Department of PMR from AIIMS New Delhi. I welcome Dr. Pradeep K. Sinha, the Vice Chancellor and Director, People IT in Air Airport, and you have seen his deep knowledge and depth in his presentations towards artificial intelligence. We have with us our interventional radiologist, the deep, dynamic Professor Dr. Narendra Kumar Bodhe, Professor Dr. Sarita Agrawal, head of the Department of Gynae, is again one of our faculty, and she will be presenting online today. We have a young clout with us, Dr. Rupa Mehta, additional professor in ENT, Dr. Anil Sharma, assistant professor of neurosurgery, Dr. Vandita Singh, associate professor, Department of Pathology, and Dr. Seema Shah, assistant professor of biochemistry. I welcome you all as faculty and for learning artificial intelligence during the CME. Then we have Dr. Ashish Kumar Singh, who comes from Patna, Director and Chief of Anup Hospital, who owns a Mako 15 crore robot. And you will be seeing the way it is operated during his lecture yet to come. I welcome Dr. Tusharam Choksi, and you have seen his lecture already, where he spoke about artificial intelligence in anesthesia practices. You have interacted with Professor Vikasvi during the panel discussion from Nimhans, Bangalore. I welcome you, sir. I also welcome Dr. Tavpritesh Sethi, Associate Professor of Computational Biology from Indraprasth Institute of Information Technology, New Delhi. We'll be having physically Professor Dr. Satyendra Puljarle, Head of the Department of Orthopaedics from Medical College, who is routinely working with navigation systems. So he'll tell his experience. We'll be having Dr. Manju Agrawal as an Assistant Professor of Pharmacology, Medical College, Raipur, who will speak on AI in pharmacovigilance. We have with us Professor Sumit Gupta, who is in the Center of Digital Economy in IIM Raipur, and he'll also enlighten us on artificial intelligence. And I also welcome all the faculty from AIIMS Raipur, all delegates. Till morning, there were 625 registered delegates, all fellows and members from the National Academy of Medical Sciences, our support staff, DDA, FA, SC, and AO, our students, postgraduates and senior residents, and our nursing staff and students also who are registered and attending the session. So Atiti Devo Bhava, I welcome you all. Thank you.
Thank you, Alok sir, for such a warm welcome. And sir, your everlasting effort and is inspiration to all of us. And I really want a big applaud for his. He is actually a one-man army in himself. Thank you, sir. Now, may I request our esteemed Dean, sir, Professor S.P. Dhaneria, for his kind address, please, sir.
Honorable Professor George D'Souza, President of our institute, Honorable Dr. Saroj Chudamani Madam, President, National Academy of Medical Sciences, Honorable Director of our institute, Professor Nitin M. Nagarkar, Dr. D.K. Gupta, Dr. Alok C. Agrawal, Organizing Secretary of the CME, Dr. Amit Chauhan, esteemed faculty members, and distinguished delegates. This CME is organized on the topic of artificial intelligence in healthcare by the Medical Education Unit of AIIMS Raipur. This is the whole day academic activity, and our team has put very hard work in organizing this whole day activity. I express sincere gratitude to all the learned speakers and resource faculty members in this CME for sparing the time and sharing your knowledge, wisdom, and expertise with all of us. Certainly, this has enlightened all of us. What is the utility of artificial intelligence? What can be the possible limitations, and how to judiciously use it in the field of medical sciences? I express sincere gratitude to Saroj Chudamani Madam and entire team of National Academy of Medical Sciences for extending all the required support to our organizing team. I express sincere gratitude to our President, Professor George D. D'Souza, for accepting our invitation to be the chief guest of the function and blessing all of us on this occasion. Dr. Alok Agrawal has actually led the team of organizing committee, and he, with entire team of faculty members and residents, deserve immense appreciation for the hard work, commitment, and dedication for organizing this successful CME. I wish this CME a grand success. Thank you very much.
Thank you very much, sir, for your kind words. We are really very happy to have you with us. Now, it's a time to have an address from NEMS respected Professor Dr. Saroj Chudamani Gopal, ma'am, President of NEMS. Ma'am, can you hear us? Ma'am, can you hear us?
अनम्यूट कर दीजिए उनको.
Ma'am, kindly unmute yourself. आप अपने आप को एक बार unmute कर लीजिए, ma'am.
Hello?
Yes, ma'am, you are very much audible. We welcome you, ma'am. Then we can ma'am, you can hear? Ma'am, just unmute yourself, ma'am. Kindly unmute yourself. We have unmuted you. Yes, ma'am.
Am I now audible?
Yes, ma'am, you are very much audible. We extend our hearty welcome to you, ma'am. We are waiting for your address. Please, ma'am.
Again.
Ma'am, you have again muted yourself. Kindly please unmute yourself. Now, ma'am,
Am I audible now?
Yes, madam, you are audible.
Ma'am,
Ma'am, kindly on your video. Switch on your video.
Am I visible now?
Yes, ma'am.
Please go ahead now. It's okay.
Okay. So, at the very outset, I would like to thank Dr. Alok Agrawal and Dr. Nagwekar, who have really agreed so open-heartedly to conduct this CME in very trying times. I may like to welcome all the dignitaries on the dais, Dr. Nagwekar, Dr. Alok Agrawal, Dr. D'Souza, the faculty from abroad, Dr. Mahen Bhandari, Dr. Sonali, Dr. T. Singh, and very well-drawn faculty from within the country, Dr. P.K. Sinha. And I think I have been hearing to the deliberations from the morning. They have been really, really very well, very informative. And this subject of artificial intelligence does have great significance. And as such, our country has done fairly well in the computing sciences. And I'm sure with the volume that we have of the human race with us, we would certainly be able to come out with the glaringly good software for which would be very highly conducive, not only for our own country, but even globally for various decision-making things in the diagnosis, prognostication, where we have artificial intelligence has lot more role to play. And certainly artificial intelligence has two wings, the software and the machine part. And I'm sure India has done very well in software, and it should be able to do it even better in this kind of work that we are envisaging, to have greater data, knowledge accumulated for various symptoms, various history measures in the diagnosis, various clinical findings, various investigative findings, and all put together could give to a greater depth of precise diagnosis and help in management of the diseases. And surely enough, we are not lagging behind very much, even in implementation at the level of machine technology. And we would certainly be able to stand very well to this challenge also. We are doing fairly well in robotics, and the robotics could be like Da Vinci robotics, but then there could be need of robotics in the small fields as well. And I have a full faith and confidence that we would be able to do well in future. And this particular CME would be able to inspire many budding minds to devote themselves for this cause of using using artificial intelligence for the benefit of human beings at large. Thank you very much indeed for so well organizing this conference. I'm indeed very grateful. Thank you.
Thank you, ma'am, for your such a kind, motivating words. We are really very thankful that you can join with us. Now, I cordially invite Dr. D.K. Gupta for his kind address to our august audience. Sir, please.
Okay, very good afternoon, each one of you. Very warm greetings from the National Academy of Medical Sciences. Honorable President of AIIMS Raipur, Professor D'Souza, Professor Nagarkar, the Director of AIIMS Raipur, Dr. Alok Agrawal, the brain behind this symposium and the chief organizer of the Symposium of the Artificial Intelligence, the Dean, Dr. Dhaneria, and Dr. Chauhan, and the team in the background, the speakers from India and overseas, participants, friends, ladies and gentlemen. The symposium was to be held somewhere in April on 18th, but COVID at that time had shown the toll, and this was postponed. So we are happy on behalf of the Academy that better late than never. So it is being held today, and there is a galaxy of team of speakers who are experienced, who have the knowledge, and who can show the path for future in this new field. We are aware in India when computers came, and the credit goes to our late Prime Minister Rajiv Gandhi. Then in the field of medicine, the endoscopy came, especially the laparoscopy, then the robotics. So limitations are there, reservations are there, but slowly when people feel that yes, these are part and parcel of our life to improve our existing facilities and requirements, these become acceptable. So the main purpose of this symposium being held by the Department of Medical Education at Raipur to create an awareness and sensitize the people about the present status and the future role of artificial intelligence, which is going to affect our life in every field, not only in medicine, but also in every field of our life. We heard some time back Bill Gates has got his house that when he enters, automatically the lights are on. When he enters the bathroom, the shower starts and it goes off when he's out and all that. So these are part of the artificial intelligence that they have incorporated already. The talk in the morning by Mr. Sundar Pichai that revealed their thought processes for the future. And these are the things which are really needed. Sometime back, you might have also heard that the time is not far off when we should be able to know by artificial intelligence what the person has in his mind about you who is sitting in front of you without talking. And that is what is we are looking for. Time is not far off when we should be able to communicate with animals, what your dog feels, what your cat feels, angry or lovable, uh, is he in a mood to harm you? So all these things are extremely important. The day is also not far off when other living organisms like plants should also have a communication with the human beings. And that is what is required. It may cause serious implications when two politicians are just sitting close by and not talking to each other. Just by body language, the artificial intelligence can give you a lot of information. So, friends and ladies and gentlemen, on behalf of the Academy, we thank you very much for holding this symposium. Dr. Agarwal especially needs compliments and congratulations. And the Academy has already approved that the outcome of the symposium should be published in the form of a monogram, and Academy will be happy to support it. So wishing you all the best, wishing all the faculty members participating in this symposium the best of their contributions. And thank you very much. Have good deliberations. Stay safe. Corona is still around. Okay, namaskar.
Thank you very much, sir, for such an enlightening address. We'll definitely look forward for such kind of innovation in future. Now, I humbly invite the Director, Sir, CEO, AIIMS Raipur, for his address on introduction to the course to our August audience. Sir, please.
Thank you very much, Dr. Ekta, and warm welcome to everybody to this wonderful CME on artificial intelligence in healthcare. My warm greetings to our chief guest, Professor George D'Souza, who is the president of AIIMS Raipur and has been the guiding force for the development in the last few years, whether on the academic front, whether on patient care, research, everything. So thank you very much, sir, for giving your time and guidance at every step. Madam Churamani Gopal, very respected president of NAMS India. Last time also we had the wonderful stem cell conference, and we always look to NAMS to guide us through and take our institution to the next level. And this association, I'm sure, will be fruitful for all of us, the faculty members, the resident doctors. Everybody will gain so much from it. Thanks again to Dr. D.K. Gupta for his enlightening talk as to how artificial intelligence is really going to change the way we are going to live our lives in the coming decades. Warm welcome again to Professor Dhaneria, Dr. Chauhan, and especially Dr. Alok Agarwal and the entire team here, which has really worked day and night for the last few weeks in spite of issues related to the COVID pandemic. All our faculty members have really worked hard for it. My special thanks to the galaxy of speakers from across the globe. They have given their time in spite of the constraints of it's sometimes day or night over there. The time gap is there because they're in different parts of the country, different parts of the world, but everybody is available here online and have been listening to the deliberations right since the morning. So again, I welcome all our faculty members, staff, resident doctors to this particular CME. And yes, definitely artificial intelligence was considered as a disruptive technology, but rather it's a transformational technology. It's going to transform the way we live our lives. And medical profession is also, the science is an ever-changing science. And wherever we can have the two together, where we have the cutting edge technology along with the developments in medical science, I think the benefits will be passed on to our patients. So we are at the cusp of the development. We are still at the early period of development of artificial intelligence. And like Dr. Alok Agarwal in his talk mentioned, that the Niti Aayog has given special emphasis to development of artificial intelligence in our country. And healthcare sector is one of the core areas which has been identified. I think the workshop or a CME of this nature has not been conducted frequently in our country before. It has brought together minds of diverse faculties, whether they are from the information technology, they are from the computer sciences, the medical field researchers, basic researchers, and a very large number of participants online who are available here today to watch this particular program. So again, thanks everybody to this particular CME. And I'm sure there will be a lot of sensitization which is going to occur today, a lot of take-home messages, something which we know about, but we've been experiencing, and we'll definitely gather a lot of information. This information will be useful for the future development of our own medical profession. And we all welcome you to AIIMS Raipur. Thank you very much. God bless you.
Thank you very much, sir, for your kind, motivating words. You are a source of everlasting inspiration to you, for all of us. And because of your continuous motivation and inspiration, we are able to organize such kind of academic feast. Again, thank you very much. Now, I cordially invite our address by Chief Guest of the function, Professor Dr. George A.D. D'Souza, President, All India Institute of Medical Sciences, Raipur. So, we welcome you and we're waiting for your address. Thank you so much.
Thank you. Dr. Nitin Nagarkar, Director, AIIMS Raipur, other dignitaries on the dais, faculty, invited distinguished faculty, students, and participants. Good afternoon to all of you. I thank the organizers for inviting me to this important national CME on artificial intelligence in healthcare. I welcome and thank the distinguished faculty for taking time off on a Sunday to be part of this important CME. I also take this opportunity to congratulate the director and the faculty of AIIMS Raipur in organizing this timely CME on artificial intelligence in healthcare. As AI systems are going to progressively increase in our day-to-day practice. Artificial intelligence has got this science fiction-like name, but it is quite old, with the term first being used in Dartmouth in a conference in as late as 1956. But it is in the last decade with newer technologies and techniques like image classifiers and an exponential increase in computing capabilities that it is poised to affect healthcare in more ways than we can imagine. It is now being used in diagnostics, therapeutics, surgery, patient management, drug discovery, administration, and many more. Newer and newer applications are being found where AI is useful. It is particularly useful where images are the data points, like in dermatology, ophthalmology, and radiology. In dermatology, it has achieved results as good or better than physicians in diagnosing skin malignancy. In India, there's a major project underway in the Arvind Eye hospitals across the country to diagnose diabetic retinopathy. And here again, it has achieved a high degree of specificity, making it an effective tool to screen for diabetic retinopathy. Both these examples are very relevant to our country, as these applications can be used for screening diseases in parts of the country where specialists are not available. In diabetic retinopathy, this is expected to be a major game changer. I will not dwell on the various uses and potential uses as it is being covered comprehensively in this CME. As we begin to accept this technology more and more in healthcare in our country, I would like to raise a few points that need to be addressed simultaneously. The success or otherwise of AI is dependent on the availability of high quality data. It would mean the acceptance and use of EMRs across the country. This is a humongous task and quite expensive. Its implementation in the West, despite even providing incentives, has been a challenge and even today is not 100%. We will have to consider solutions for this. This may be an advantage as we are still in infancy with respect to solutions for this, so that we can create solutions with a degree of uniformity and reliability, which could then bring data which is more easily and effectively used. Data again raises another concern about privacy and the use of data also in monetization. The questions to be asked are, do we need consent from patients? Can anonymized data be used without consent? Can hospitals sell their data? Can industry sell their data? Interpretability is another important subject that needs to be addressed. Often the interpretation of AI solutions is in context for what it is taken. A solution for the admin or nursing may not be the same as that required for a physician to make decisions. It is also important for the physician to understand how a conclusion came about if she has to convincingly advise his or her patient. Further, as time goes, AI is expected to have a physician de-skilling effect on future generations, which can have unexpected consequences. Example, there's supposedly an AI solution which said that asthma is protective against severe pneumonia, but we know the other way. There are serious ethical concerns. Accountability, transparency, and privacy are only some. Who would be accountable for an error made by an AI system? How can we be transparent when using AI in diagnosis when we do not know how the process that came into making that conclusion? And the privacy issues are of real concern. I've read somewhere that Facebook used posts to predict and advise on suicide without consent. In another example, they could use the steps that you walk, which are picked up from your iPhone or your smartwatch, match it with your healthcare data, and sell it to insurance companies who could then increase your premium because you're a lazy guy who walks less than 100 steps a day. Genetic testing companies are already selling data to pharma and biotech. And if they do to insurance companies, you are in trouble. This is not to take away from AI the tremendous benefits that we could have in healthcare, but to know and to address and develop safeguards. As Jeff Catlin of LexAlytics said, AI can't be expected to do it all. It can't take the challenging problems out of our hands for us. It can't solve our ethical dilemmas or moral conundrums. The tech companies, healthcare institutions, and government agencies need to work together to take care of the rights of the individuals whose data they are going to use. To this, one has to add the medical legal concern. A decision made on the basis of AI, if wrong, who will be responsible? Is it going to be the firm? Is it going to be the hospital? Or is it going to be the doctor who used the tool? These are real questions which need to be addressed. It is well recognized that AI-led clinical information systems have also unintended consequences, including alert fatigue. You would have seen this in the ICUs, increased workload, disruption of interpersonal communication, and specific hazards against which one has to be vigilant. For example, if there is a false negative in a mammogram, it is likely to be missed if only CAD is used, while it would have been picked up if the mammogram was seen by the radiologist. Lastly, clinicians will with the evolution of AI, have to adapt to a new role as information aggregators, interpreters, and patient supporters. This will also mean that medical education will have to train a new generation of clinicians into their new roles and to be able to understand, interpret, and use these new tools effectively to make patient care better, safer, and more cost effective, while maintaining the highest ethical and moral standards. I wish the CME all success and fruitful deliberations. Thank you.
Thank you, sir, for such a kind words. And I extend heartily thankfulness to you from whole AIIMS Raipur family and our organizing team. And we are delighted with your presence. Thank you very much, sir. Artificial intelligence is a simulation of human intelligence processed by machines and especially computer science, as we have learned this in quite details. Now it's a time to distribute our token of remembrance so that we can remember this beautiful academic feast. With your permission, sir, now we are beginning the ceremony for distribution of memento. Now, may I request Professor Alok sir to kindly produce token of remembrance to our esteemed director, sir. Kindly give him a big applause. This is such a beautiful team. Thank you, sir. Now, may I request Dr. Manisha B. Sinha to present memento to our dean, sir. Thank you, sir. Thank you, Dr. Manisha. Now, may I request Dr. Sarita Ramchandani to present memento to our Alok, sir. So your smile is contagious, definitely. Thank you, Dr. Alok. Thank you, Dr. Sarita. Now, may I request Dr. Amritva Ghosh to present memento to our organizing joint secretary, Professor Amit Chauhan. This mask is COVID, new normal to us. Thank you, Dr. Amritva. Thank you, Dr. Amit. As all thing comes to end, this is the time for end of this inauguration function. Now, may I request Dr. Amit Chauhan to kindly deliver vote of thanks to our august audience. Thank you.
It's a great honor for me to have been asked to offer a vote of thanks on this CME on artificial intelligence in healthcare. First of all, I'm grateful to our chief guest, President AIIMS Raipur, Dr. George A. D'Souza, sir, for permitting and patronizing this CME on artificial intelligence in healthcare. Thank you, sir, for taking out time from your busy schedule, joining this CME and boosting our confidence. I want to extend my sincere gratitude and regards to our director, Professor Dr. Nitin N. Nagarkar, sir, who has spared his utmost valuable time and energy to be amongst us. His vision, leadership, and guidance have made this program a success. Someone once said, leadership is the ability to see future before it happens.
The plan to organize this CME on paradigm shifting topic like artificial intelligence coming from our director sir itself speaks. Artificial intelligence will be the new future. Thank you, sir. I would like to thank our Dean Sir, Professor Dr. S.P. Dhaneria, for his constant enthusiastic promotion of interdisciplinary academic collaboration. Thank you, sir. I want to express my sincere thanks to Professor Dr. Alok Chandra Agrawal, who has worked day and night to ensure that this program sees the light of the day. Coordinating with so many people and making this hybrid mode CME successful in such dire times of COVID is not easy, and he has made this very beautiful. It's really admirable to see how Sir always see projects through from conception to completion. His great inputs and organizing skills proved vital in making this program a successful and academic feast for budding young minds and experienced hands. Thank you, sir. I thank Dr. Saroj Churamani Gopal, President, National Academy of Medical Sciences, and the whole NAMS family for allowing us to be a part of NAMSCon 2020 and supporting us at every step. Ma'am, we thank you for your constant presence in today's program and hope for successful collaborations in the future as well. I would like to thank all the speakers of this CME for their excellent presentations, especially our international speakers who were dead on time in spite of the gap in time zone. Thank you all. I would like to thank all the offline and online participants for attending and making this CME successful. I'm happy to say that more than 650 participants have registered and joined in this CME. Thank you all. I take this opportunity to acknowledge the contribution of all the faculties of the Medical Education Unit, AIIMS Raipur, who came forward to volunteer in organizing this CME. Their attention in detail in their respective roles has made this CME run smoothly. All the residents and staff of the Department of Orthopaedics who have worked hard to make this CME successful deserve our thanks. I'm sure the experience of organizing this kind of program will be helpful in our future endeavors. I thank the auditorium staff, the people of the IT department, electric department, and BVG staff for their contribution. I would like to thank Avinash and the group for their help in the audiovisual department and Yara Darda for catering services. Finally, I would like to thank all those who have worked behind the scenes to make this CME successful. Thank you. Now we'll break for a short lunch. For all the participants who are present here, lunch is arranged, so please have it. And we will join at 2 p.m.
Thank you, sir. With this inauguration ceremony is over, I have an announcement to make. We are not doing a break. Our chairpersons are here, speakers are here. We continue with the CME, and lunch packets are there for all. They can go one by one, have their lunch packets, and start. So I take this opportunity to invite on the dais Dr. Chavli, KD Chavli, sir, HOD Department of Forensic Medicine, Dr. Ajay Bohera, to come on the dais as a chairperson, and Dr. Nakul Uppal. Please come so that we can continue with the CME in a timely manner. The speakers for this session are Dr. Saurabh Varshane, Director AIIMS Devghar, Dr. Bodhe, Dr. Sarita Agrawal Madam, and Professor Vikas V. Three of the speakers will be online in this session.
A warm welcome to all the delegates, the speakers, and we are ready with the next session. Our first speaker for this session is Professor Dr. Saurabh Varshney. He is Director, CEO of AIIMS Devgarh. Sir, we are looking forward to your talk. He'll be talking on scope of artificial intelligence in otorhinolaryngology. Sir, please. Sir, excuse me, sir. You are muted. Can you please unmute yourself first? Yeah. Thank you, sir. We can't hear you, sir. Please. You will need to unmute yourself.
Okay. Now I am audible.
Yes, sir. Right, sir.
Okay. Fine. So a very good afternoon to one and all. Are my slides visible? Can you see the slides?
Sir, as of now, you have not started screen sharing.
I have shared it.
I think you'll have to do it again.
Okay. Go back. Are they visible now?
I think so. Yes, sir. Yes, sir.
Okay.
That's right.
Okay. I'm just making them full screen. Let me know if they're still there. Are they still there? Hello?
Hello. Yes, sir.
Okay. So, very good afternoon to one and all. My regards to Professor Saroj Churamani Madam, Professor D.K. Gupta, Sir Secretary NMS, Professor George D'Souza, Professor Nagarkar, Director AIIMS Raipur, and Professor Alok Agarwal, who has kindly invited me to discuss this topic of importance and be part of this very important CME under NAMSCON. I bring greetings from a holy city of Devgarh, which is in state of Jharkhand, and it is famous for it, one of the Jyotirling. So my greetings to all who are participating today. When the topic was given to me to talk about scope of artificial intelligence in otorhinolaryngology, honestly, I like to confess that although I was, before joining AIIMS Devgarh, I was working as head of Department of ENT at AIIMS Rishikesh, and I was working in the most sophisticated, most updated, most advanced theaters, doing the most advanced surgery, having the most advanced equipment in my OPD. But I never thought about what all contributions artificial intelligence brought in my specialty, that is otorhinolaryngology. I was performing robotic surgery. I am a trained robotic head neck surgeon, and I was using navigation, and all things were I was using day and night, but I was not deeply thinking about. So once the topic was given to me, I started reading and thinking what all other contributions present and will be in future in my field of specialty, that is otorhinolaryngology. So I'm thankful to NAMSCON for this platform. As already discussed since morning, the Niti Aayog is already focused on looking at artificial intelligence as a future need. Since it is morning, many speakers have already elaborated. The artificial intelligence has two components. One is artificial, one is intelligence. Whatever is artificial is man created. So this artificial intelligence is a man creation. The word intelligence contributes that it has to think, reason, and understand, either equal to a human being or sometimes better than a human being. That is what we are calling artificial intelligence. Since morning, I think very nice presentation have been done by very eminent speakers talking about various definitions have been given to artificial intelligence. The gist is that it should simulate human intelligence, demonstrate human-like intelligence, should we have concept of learning, problem solving, and decision making like a human being, and perform tasks to the same standard or better than a human being. So that is what artificial intelligence is. I think it has been discussed this morning that it's a machine learning and deep learning. There are two components of artificial intelligence. Machine learning is simply the tool. Deep learning is sort of software, the data we feed in and we analyze, which helps us in various components. So if we see artificial intelligence, the innermost circle is the deep learning. The outer circle is machine learning. And then it can both contribute what we call artificial intelligence. So first, we have to collect the data information. Then there should be a tool to analyze it, which we can use. And then we can use this in the interest of the patient or mankind as a healthcare. There are various indications of using artificial intelligence in healthcare. I think the same slide was shared by Dr. Alok also. So I've also taken from the same source. If we talk about our learning, training in healthcare, we remember these iconic photographs that how the anatomy was taught, how the anatomy transferred, and how we are teaching our students anatomy today on virtual platforms. So this virtual platform anatomy, which is being used in all the major medical colleges, is a very practical example of artificial intelligence. If I confine to my subject of specialty, otorhinolaryngology, it's a small branch, but is having a rapid advancement and very new technologies are being used into routine clinical practices. So I came across a very recent publication, which is of 2020 November, and they did a systematic review and they identified 90 studies which were using artificial intelligence in otorhinolaryngology, and they analyzed that, analyzing medical images, voice analysis, medical clinical diagnosis and treatment. They made 4 components and they brought out that 42% of artificial intelligence is used in analyzing medical images in the field of otorhinolaryngology head neck. That is the temporal bone anatomy, head neck anatomy, the planning for the surgery, the training for the surgery. This was used almost 42%, and which was followed 26% for the diagnosis and treatment. And rest 2 components were only 15%. So it is still a long way to go. Another major publication, which was published in February 2019 by American Academy of Otorhinolaryngology and Head Neck Surgery, it is a very biased publication which says the merits, but it also talks about the limitation, the challenges. The main challenge there focus is the machine errors may complicate patient care. So this, I think, morning also was discussed. So I'll take one by one the contribution in my field, imaging. When we talk about anatomy of human body, the anatomy of head neck is considered to be the most complex anatomy. So imaging, which has multiple layers, the input layer, convolution layer, the convolution layer, and the fully analytic layer, this is very helpful in planning diagnosis, in planning the treatment, and planning the surgery extent using this artificial intelligence, which is very much being used in various countries, even including our country. We have been using it. We are using artificial intelligence in anatomy and radiology for 3D reconstructions. We try to make a 3D reconstruction of the tumors, of the pathologies in relation to vital structures, particularly related to skull-based surgeries. So this is very helpful. And many specialties, they are known as image-heavy specialties, where imaging has a very significant role in planning. So ENT is one of them. So artificial intelligence has a great contribution in this planning. If we talk about diagnosis, the first use of artificial intelligence in ENT was done in analysis of auditory brainstem response, ABR. And it was automated analysis of ABR, which was the first use of artificial intelligence in otology way back in 2002 or 2003. Subsequently, to diagnose cases of benign paroxysmal position vertigo, which is a very common condition of fall among elderly, that a software was created which analyzed about 92,000 nystagmus videos, and a data bank was created, and to diagnose cases of benign paroxysmal position vertigo, because there is no specific test to diagnose BPV except for the symptoms and nystagmus analysis. and the sensitivity of this was more than 80%. Subsequently, it has been used and being used in a big way in voice analysis. One of my colleagues was talking about role in obs gynae. I was listening to her presentation, and she said that trimester voice analysis, they are using the software. And then ENT, we very frequently use video stroboscopy and voice analysis, which are both a model of artificial intelligence. In voice analysis, the analysis for diagnosis and prognosis of the condition. Recently, I have published an article about teleontology in India. Seeing the COVID era, we are developing devices which can be used for community screening as a teleontology or teleaudiology tool, which is totally based on the concept of machine learning and deep learning, that is artificial intelligence, that we can screen the community without sending an expert, and the data can be transferred, analyzed by a software, and we can analyze the conditions sitting at a tertiary center at any remote area. So this is another field where it is coming up very well. Then another software has been created to do a community examination of primary health care. The government of India is coming to wellness clinic concepts, and primary healthcare setup is being strengthened seeing the COVID era. So computer-aided diagnosis of middle ear conditions is software has been developed, which is known as digital otoscopy. So anyone can use this, and there are already pre-programmed images which can identify the tympanic membrane condition, give you a diagnosis, so that the person who is requiring a referral to the tertiary care can be referred. So the accuracy of this software is 93.9% with a sensitivity and specificity almost 85 to 90%. If we talk about technology being used very much in head neck, is a narrowband imaging, which is also used by our GI colleagues. It is narrowband imaging, which is very useful in identifying early or pre-malignant conditions, and we can intervene and give curative. So this is another indication of artificial intelligence in diagnosis and treatment planning in ENT and head neck. Then the second component is the training. If we go by training component, simulation training. Our temporal bone dissection labs are mandatory for postgraduate training, but it is many times difficult to get a temporal bone because you have to retrieve from cadavers. It's difficult to get cadaver these days. So there is a software available which can train you almost like a normal temporal bone, which variable difficulty index, various anatomical anomalies can be created, and a person can be trained for the simulation training based on the concept of artificial intelligence. You can also practice a patient-specific virtual reality otologic surgery before performing the real surgery on the patient. So it has a significant role in malignancies of the head neck. The hyperspectral imaging for differentiating between normal head and neck tissue and the malignancies have sensitivity and specificity as high as 95-96% and accuracy of 96%. Further, the artificial intelligence is being used in head neck cancer by our radiotherapy colleagues because they create a three-dimensional tumor volumes to accelerate radiotherapy in dosing and planning. So which becomes a very specific with minimal side effects and better tolerance in the patients where artificial intelligence is playing a role. If we talk about the patient treatment, then the best example is the hearing aid. If we see that about 20 years back, the hearing aids were a very, very low technical advancement. Today, we have hearing aids, which are digital hearing aids, which has a wide dynamic compression range, which means that hearing aid adapts themselves to the surrounding, or it can adapt themselves to the need of the person who is using the hearing aid. So this is a very big revolution of the artificial intelligence. And these hearing aids are available in our country, and many of my patients are also using this hearing aid with great satisfaction. So this is a very big achievement of artificial intelligence in field of otology. We have a very practical example of cochlear implant that children who are deaf and mute since birth. They cannot hear, they cannot speak. So they are, I will not say a liability, but they are not productive for the society. So cochlear implant, which we all the otologic surgeons are trained, most of them are trained, we all are doing it. So we are putting an electrode into the inner ear, and we can make by birth deaf and dumb person hear sounds and speak and be an independent person. So this is another creation of artificial intelligence in otology. We are doing a lot of endoscopic skull-based surgeries, and navigation is a very, very important tool, which is again an example of using artificial intelligence, because we have been performing, I perform endoscopic skull-based surgeries using navigation. So that gives us accuracy, precision, and minimal complications, and safe removal of very, very difficult surgical field tumors. So this is another field where artificial intelligence is playing role in ENT. Then we have been performing robotic surgery. I think Professor Bhandari sir is the pioneer, and he is the CEO of Integrity Foundation, which is the main organization for the robotic surgery in the world. And robotic surgery is basically, it's not that robot performing surgery, it is man using robot to perform the surgery, but the accuracy and precision is because of the artificial intelligence programming of that robot, and which helps us in giving dexterity of the fingers, which gives us access advantage in difficult areas in head neck, because we do a lot of trans-oral resection surgery using a robotic surgeries, and we go deep to the larynx, pharynx, where hands cannot go, but robotic arms can reach and we can perform surgeries. So it is a big advantage. Here is a small clip of one of my patients. We operated how the robotic surgery is being done head neck. We go through the oral cavity in a tubular anatomy where hands cannot reach easily, and we use a robot to perform this type of surgeries. So further we go, recently I am working on a project with IIT Roorkee, and we are developing a software to for the correction of the quality of voice for elderly population, and particularly the patients of Parkinson's, because the first symptom of Parkinson's is unclear voice and they cannot communicate. So with IIT Roorkee, we are developing a software which the hardware has already been developed. So this is the hardware we have developed. And this is the analysis of the voice, which is converted by software into a clear audible voice. And we are almost half done with this project. So we are using artificial intelligence here for this cause. The next use of artificial intelligence in ENT is we are trying to collaborate with various organizations in rural areas, and the digital platform for ENT workup, digital otoscopy, laryngeal endoscopies, nasal endoscopies are being done elsewhere, and the analysis are done by artificial intelligence analysis, and those cases and treatment. Now, any technology you talk about, first, the thing is that it has some chances of error also. So if we talk about chances of error, the first challenge we are going to face is that this can only be used if we create large data banks and data sets. In country like India, we are doing extensive work, but we are not very good in data keeping and data ethical concerns have already been talked in the morning, that hacking of the data, sharing of the data of the patients will be a concern. The doctor-patient relationship, which is a very, very strong component of medical care in our country, will be disturbed if we are using artificial intelligence. How can we ensure that artificial intelligence is generalizable and safe for all? It is one challenge. Then medical decision making shift from physician to intelligent machines, how reliable it will be, and if in the morning, I think Dr. Alok has already discussed this. If any harm is created using artificial intelligence, then who will take the responsibility of that harm? That is the medical legal aspect of it. So the key point I would like to say is by use of artificial intelligence, otolaryngology is in its infancy, but the benefits show great promise. We are in the era of evidence-based medicine. I will be very honest, the evidence is still lacking. We have to build evidence before saying yes, it is very useful. So we have to go through the three phases: feasibility, validation, reliability. Then only it can be approved for use in many otology conditions. So the question still remains, we have to first have the validity, reliability before encroaching on it. And if we talk about future, yes, although it is developed in high resource settings, the technology has equally significant application in low resource settings, facilitate quality care in the presence of limited resources. So what I mean to say is the technology can be only developed with the developed resources areas, but is very useful in low resource area like our country, where the resources are very limited, number of patients are increasing, the number of a genetic population is increasing. So we have to have a resource where we can to cater to more people and manpower requirements reduce. This is the need of the country. So that will be taken. So with this, I'm again thankful to organizers for giving me the opportunity and preparing this. I'm thankful because of this. I also read a lot of literature about artificial intelligence. Thank you very much. Thanks. If any question come in, I'll welcome to take them. Thank you.
Thank you so much, sir, for a very crisp overview of artificial intelligence and its uses in diagnosis, treatment, training in ENT and head and neck surgery. I think we can take questions at the end of the session. We might have received questions in the chat box, so we can take them up at the end. Okay. Yeah. So the questions must be available in the chat box, and I think these can be replied there itself by the speaker individually. So we can't think of artificial intelligence without imaging. And the moment we talk of artificial intelligence, the first thing that comes to mind is imaging. So our next speaker is our own faculty colleague, Dr. N.K. Bodhe, Professor and Head of the Department of Radio Diagnosis, and he'll speak on the topic Scope of AI in Radio Diagnosis and Imaging. Sir, please.
Thanks a lot for the introduction. And before this odd time, it goes, let us have a slight change before we go on to So this, you just experienced what was there as a part where we could see two different systems, two different songs. And of course, there was a slight change in the content of the songs also. On your left, what we have here is the old-timers' way of composing songs, sitting in a room. And what is this that was done in the form of some sort of techno music, if not you call as completely techno. And the backbone behind this is these. These are the music composers of yesterday. And this is A.R. Rahman, our own music composer. He uses the computers for his own music composition. Okay. So with this introduction, I will just come to the start with what is the scope of AI in radiology. We already are working as a part of a team developing some AI projects with certain teams in the engineering colleges. And before we go ahead, we'll just have my acknowledgements. The organizing team including NAMS and the team under Dr. Professor Alok Agrawal. Our director, AIIMS Raipur, as I said, officials of the NAMS, AIIMS Raipur and SCTIMSC Trivandrum, since when we had actually started this work long time back. Collaborators at NIT Raipur and IIT Bhilai, our IT team at AIIMS Raipur, my team of the Department of Radiology, the support team of the imaging equipment too, and patients whose scans were the data, as we call it, the time of today. We have been dealing in details since morning regarding robotics. As we say, there is a cognition or a soft thing which is attached to various robots which are seen here, putting a hand on the chin, trying to silence somebody, or now we have these as two soft things, whereas the hardware things. So what is behind that is this particular aspect which you are saying. Robots do not work on their own. What is it? In radiology, the robot is a medical imaging software and other things which are added up to that software to make it actually work for our automations, which will enable us to make our life easy. Please, I'm stressing the word here, to make our life easy. It means not to replace us, but to make our life easy. Okay? So in radiology, we could have the use of robots for design of tools for diagnostic and intervention radiology. Also, as a part of software, we work on the images that have been already acquired for various automations. So as you said, as you have seen in the morning, this is the physical form of the robot, but what goes behind that is the software. So basically, whether you have only two arms or pincers going into the surgical field, but it is the data which is fed in the back which is being shown. So what is that in radiology? It's software, or also called as images. Okay. So what is this particular thing? We deal with DICOM, that's a digital imaging communication in medicine. Tools in images from simple measurement of a lesion. As you see, you must have seen in the reports, the lesion is 5 millimeters in dimension. What does that mean? We use an electronic caliper and we measure it. That's the simplest form of artificial intelligence, but that is because you have incorporated into that software that this much distance or a calibration is supposed to mean that this is 5 millimeters. So going on from that particular thing, and as we go on to different modalities, it is the density, attenuation values or ounce filled units on CT scan. However, so far we did not have any objective value on an X-ray, which is also called as opacity, or on ultrasound, which is actually termed as echogenicity. Certain MRI systems do have objective values which say it's a relaxometry value. And we have definitely heard about a term called CAD, even before and since morning as well. It's computer-aided diagnosis. Now, these are terms which are interchangeable and sometimes replaceable at times depending on what you are doing. So what is the thing behind it? It's data, big data in radiology coming from radiographs, X-ray, or radiographs which is termed, and this could be in terms of even mammography or DEXA scan or dental X-rays OPG. And then you go to the other modality which is ultrasound, CT, MRI, and digital subtraction angiography. And a combination of all these things is stored in a bank called as PACS depending on the size of your server. As you go ahead, we may see some interesting images here, but at the same time, I may go into the jargon again, which you might have heard since morning. And we are seeing these are the X-rays, the ultrasound. You can see the CT, we are showing a stroke over here. I mean, it's an infarct, an MR image, and a DSA image. So these are the images which we come to terms like what we define or give the data as an input to the imaging software or an algorithm before it is called a software. So for X-rays and mammography, similar things, it is the opacity, lucency, or the grayness of the structure or the image, which for bones and fluid structure, it is called opaque on X-ray. The fat and air is seen lucent. And the combination of different components is seen as gray. Now, what does the modality data do with the AI? It actually does store the data about the location, size, shape, age, gender, and variation. All these parameters are looked for their appropriateness by storing or giving an input of maximum data, whatever is possible. And then the system actually tries to see what is a variation from this appropriateness, that is where it detects. So as we say, the same thing is applicable for ultrasound as echogenicity, and the images are in grayscale mostly, but we can have Doppler inputs also. A CT, it is, as I said, hyperdense is bone, blood, and calculi. Hypodense is fat, air, and fluid. The gray things is in reference to the organs. Again, the appropriateness is checked here. And as we say in CT, again, this is particular thing inappropriate. Okay, so this is the normal structure, and this is the abnormal structure, as we say. And likewise, this is the structure of the aorta, which is having a stent. This is what is detected as a variation by the system after we give the data input for a large number of cases. As for MRI, it is having T1 and T2 variations, which can lead to components of different types of appearances. And as we see, the fluid appears differently. Edema of the fluid of the edema and the normal fluid appears differently on T1 and T2 and flare. And that is the data which is given to the system when we build an algorithm. Now, DSA, when it is said it's used in interventional radiology, the images are still DICOM images, but have info about the temporal profile. And they subtract the bone. Again, the same variations has to be applied. And we try to see what is normal. If this is a normal DSA image, if there is some outpouching, the system or the algorithm should be able to detect that. Okay. I may not go to the details of all this stuff which is there because it has been already dealt, but still I'll rush through this slide. The jargon or terminologies that you have heard are machine learning, deep learning, neural network, some underfitting, overfitting, segmentation, validation, testing, some ground truths, some radiomics, the biobanks, and there are certain laws of robotics also. So when it was as mentioned, these are different capacity of the machines where we have these particular categories as steps where it is in going from machine to the ANN. It is a higher version of intricacy that can be made. So when you say machine learning as was dealt in the morning, it is unsupervised, reinforced, supervised, and semi-supervised, where we can actually give the data and label it or then test it later with a ground truth, which is said that we need to know what is a cyst. When we say that this is a cyst, the next time when the patient, when the system sees a cyst, it will label it on its own that this should be called as a cyst. So deep learning is a subcategory of machine learning with multiple layers of interconnected algorithms and hierarchical importance. Suppose it was an image. Now with the image we add the age. With the image we add gender. With the image we add fever or no fever. So this is called the deep learning when the the algorithm actually keeps on learning with multiple added inputs. And when these layers keep on increasing in number, we get to know what is an artificial neural network. So these images, when we add up these layers, suppose we added only one part and then we go into the other part of adding clinical input, of adding the patient's scenario, patient's examination findings. This is how the system goes on getting robust and more. That's the reason why we say we need to have feeds. A recurrent network is the best network here, where the output actually feeds its own input. And that is where we need to make the system stronger and become stronger by the time. Now, what we say is the training of ANN. Where and how is the problem of the training data set. So as we were seeing in the morning, pre-labeled images were being called or talked about. So we actually label a particular image that this is a cyst or this is a tumor and give it to the system. And when we give that to the system, after that, again and again, we then need to test it on a data where it wasn't subjected to any of this algorithm. So when this validating data set is there, this should be entirely different from the training data set. Why I'm asking or telling all this stuff is whenever we are trying to make any algorithms in correlation with in collaboration with the engineers, we need to have enough information from the clinicians also where the patients are sent for the data. Now there could be some overfitting and underfitting, which we will not be dealing here right now, but we'll just lay a stress upon computer-aided diagnosis, which has been a clinical application of AI in radiology. When we say it is for a precise case scenario, it's not an artificial intelligence in general, but when you say it is for lung, then we say that, okay, it is an a computer-aided diagnosis algorithm for a lung nodule, or for a colonic tumor, or for a breast lesion, or prostatic hypertrophy or tumor. So what is the application, direct application that comes is disease detection in radiology. So pediatric bone age was used, estimated by using machine learning techniques, breast cancer detection, chest radiography interpretation, which is one of the most difficult portions, the liver lesion characterization on USG and CT, the brain tumors, sometimes prostate cancer detection. These have been actually seen and in vogue already. The disease, apart from the detection, what is important is the disease risk stratification. By seeing the image, we should be able to tell, or the system should be able to tell from between the benign and malignant disease, or whether it is a high versus low risk, or good versus poor prognosis. So images, we can report it, but what will it lead to is more important when we show for risk stratification. Now, recent application that we are saying is there is some predicting the outcome of neonatal, neurodevelopment, which could be hampered in cases of preterm children. That had been studied already, and it was actually with 84% accuracy. There could be evaluation of imaging sequences on MRI, which could predict or detect or categorize the disease like multiple sclerosis, which is also almost a dysfunctional brain at times. Virtual anatomy teaching for the students, virtual autopsy for storage of data for later use. These are quite a significant application that is there. What happens in this is the automated segmentation for tumors and other diseases, and the application for that is like vital info on the functional performance of the tissues and organs, disease extent and burden. There are certain things like we do cardiac evaluation by doing an echo and find out the ejection fraction and other indices. Whereas if you do a cardiac MR, you just click it and it will give you the Doppler, it will give you the LV function analysis in a jiffy. Brain tumor segmentation on contrast T1 can be used very efficiently for stereotactic radiotherapy. Lesion segmentation in prostate or liver also can be done in a similar manner. Now, when you extract features, this was only segmentation. What is important next is whether a round tumor which is having a very nice margin is benign, or a round tumor with some speculations is malignant, or there is an overlap. So this is something called as feature extraction. And this is what is done on diagnostic images, the final product of which is a quantitative feature or parameter, measurable and mineable from the images, and it can extract up to 400 features from a region of interest in CT or MRI or PET. These are the things which, as you saw before, the images were used for the planning of cochlear implant or other ENT surgeries, which were seen in the previous presentation. And this is what can be used by feature extraction also in tumors. Now, it also supports to build a digital twin for a person, because it actually makes patient signatures. As we said here, this is a large repository of data for that brain. Suppose the patient has had a tumor and his brain is being scanned every 3 months or 6 months. So it basically creates a repository of the data in the form of a digital twin for that particular brain of that patient. But what is important here is the PACS, and this is what is the role of imaging biobanks. The PACS not only gives images, but at the same time, the radiologist works on it, creates some quantitative analysis, and that adds up to the image rather than the modality itself. So that actually gives rise to a big data as we are talking about. It also helps us as for the radiologist to optimize the dose of radiation to the patient so that we feed the data long up to what our patients we have done in the last 6 months, 1 year or so. And we say that only these protocols are required. So then the next time the patient comes with a similar diagnosis, we have to do these protocols only. The optimization of dose can be done. It is an optimizing tool for assisting the technologists and radiologists to have a patient-centric, personalized protocol. Likewise, it assists us in structured reporting. Okay, like some problems or some situations are there which is normal. Like if we do a CT abdomen, everything else is normal, but the renal cortical cyst is there. So what will happen? These small things which are called as common data elements will be detected by the system itself, and it will keep the system ready for a more aggressive interrogation of the data by the radiologist. It can also help in prioritizing. What is prioritizing? Whether we do an emergency bleed patient first, or we do a malignancy first, or whether we do an indolent case at a later date. This will be helped by AI. And this is what is a big thing. Now, what we come to at the end of the session is what we have as challenges. It's a big data we have to understand, and it is sometimes because of an overfitting and too much of data is there, or unorganized data is there. Because of which there is something called required as curation. We know this word as curator, where it is required to curate the data, and that is what you have to stratify the data as, okay, either you want to stratify by gender or by tumor or by infection, those sorts of things. And this is one thing which has been consistently raised since morning, that it's a laborious thing and requires robust validation also. It is useful only in common diseases where the data is large and not for a rare condition. Like I would like to tell you a famous example, which I always try to tell, that if there is an aortic arch, we tell the system will detect that the aortic arch is this. It is a type 1 branch of type 1 aortic arch, or the brachiocephalic is arising now as a first branch, or there is an aberrant subclavian branch. But the system, unless and until there is a variation, system will not detect the fourth vertebral artery, or rather the fourth branch, as a vertebral artery directly arising from the aorta. In fact, it will say the subclavian artery on the left has become narrow. So normal branch is brachiocephalic, common carotid, and left subclavian. But instead of the vertebral artery arising from this, it is arising from the aorta. And if the data corruption is not taken care of before, the AI will detect this as a small subclavian artery. And that is where the data validation is a must. Okay. Sometimes disease-specific confusions can happen. And that generally we can see one good example is of a stroke, where MRI will give you a diffusion-weighted imaging changes. But on CT, where do we require? This is required at a mass scale. If the patient is having an infarct in the brain, which was there before as an old infarct, and now the patient is having some acute infarct, the CT and the AI system will detect only the old infarct, and that has been proved with an 84% specificity, similar to that of a radiologist. But the accuracy of detecting an acute infarct is still not as much with AI, unless it is paralleled with an experienced radiologist who is seeing it. Coming again to the regulations, we said always the fear whether if the AI comes, the radiologist is not required. But the radiologist is required because you have to have his knowledge of medicine and clinical physics, the equipment and its physics, and this imaging protocols which will be there. Naturally, it translates into the question, who will own the legality of any problem that happens? Everybody has been telling the same thing since morning, whether it's the developer of the algorithm, or the validation person who is a doctor, or a person who relied on the algorithm for making the treatment decision. Okay, so this is what we have been telling since morning, and now it is a concept that we need some overlap between a medical field and a engineering field, which we used to say there is a biomedical engineers, but now there are people who are interested in AI. We already have projects there working with the institutes, and why it is required is the data which is there, you cannot actually have the validation or testing of the data, testing of the algorithm, unless and until the patient is of a medical background. Okay, one interesting fact which I'll put verbatim here. Once upon a time, the US wanted to use the neural networks to automatically detect camouflaged enemy tanks. The researchers trained a neural network on 50 photos of camouflage tanks in the trees and 50 photos of trees without the tanks. Wisely, the researchers had originally taken 200 photos, 100 of tanks and 100 of trees. They had used only 50 of each of the training set. Only 50 for the training set. That is the input data before you develop an algorithm. The researchers ran the network on the remaining 100 photos, and without further training, it classified all the remaining photos correctly. 100% success. Okay? But the researchers handed the finished work to the Pentagon, which soon handed it back. The reason being, it's complained that in their own tests, the neural network did no better than a chance of detecting the tanks or discriminating the photos. It turned out that in the researchers' input data set, the photos of camouflage tanks had been taken on cloudy days, while photos of plain forest was taken on clear days. The neural network had learned to distinguish the cloudy days and the sunny days, and based on that, it just clicked it. So you have to understand, it's not just the data or the machine, all the algorithms or the composers, but it's the robot that we develop, the man behind the machine is more important. Thank you.
Thank you, Dr. Bode, for this wonderful talk. And like you have said, and like all other speakers earlier have said, there are many multiple applications of AI in the medical field. However, there are many challenges, there are many lacunae. I think a talk on medico-legal issues or on the applications of AI would have completed the whole spectrum of topics. I think that would be covered in the next time. Now, if there are any questions from the audience, you can take them up. Okay, so now I would request Dr. Nakul to please give a token of appreciation to Dr. Bode.
Good afternoon, everyone. We'll go on to the next talk. And in the previous talk by Dr. Bode, we saw a fascinating amount of application of AI in imaging. But now I'd like to bring to the dais one of our in-house faculty, a dynamic, ever young HOD, Dr. Sarita Agarwal, and I request her to speak on the role of AI in obstetrics and gynecology. Ma'am, please.
Very good afternoon to all the dignitaries on offline and online both. And at the outset, I must thank to the organizers, NAMS, and all other people who organized such an intelligent conference, or the CME on artificial intelligence, which actually gave me an opportunity to become little bit intelligent on the topic of artificial intelligence. And when I was exploring this, I realized, yes, what wonders can be done with the use of artificial intelligence, but that definitely has certain limitations. So I'm going to speak on the artificial intelligence on obstetrics and gynecology. We have learned what artificial intelligence is. It is just like mimicking the human brain and behavioral pattern, and capable to perform solving and learning like a human brain. But how does it differ from human working? We know machines are not susceptible to sleep deprivation, distraction, information overload, and short-term memory loss as the human being does have. So it can be superior on that aspect. But artificial is always artificial. It has got its own limitation. What an intelligent human brain knows, that only can make an intelligent, artificial intelligence based technology, which is going to take us the pathways for the decision making and understanding how it can help in our medical field. So we have learned a lot about what is machine learning, what is artificial and neural networks and all. I'm just going to talk about the implication in obstetrics and gynecology. So when we talk about the machine learning, it is on data. In the training phase, we give the data with the outcome, and the machine interprets the patterns and then makes an algorithm, and then during testing phase you give only the data and the machine gives you the diagnosis or the risk scoring and all, which can be done either by the machine learning or by the artificial neural network. So the use in obstetrics and gynecology of these two subsets are in cardiotocography interpretation, non-stress test interpretation, and certain obstetrics and gynecological risk calculators. And of course, in artificial intelligence, when we have the multifactorial data, it gives you the weightage factor. How much is the weightage of that particular risk factors, and then based upon that, you can decide and have a scoring system, and then you get an interpretation in risk calculation. Then the other system which is used is a natural language processing, where the data is identified by the machines, either it is a text-based or the dialogue-based, as in the Alexa and Amazon. Alexa, switch on the fan, switch off the fan, and Alexa, tell about this, something like that, and the Alexa says everything. So in this way, the computer algorithms are there which are going to interpret your speech. The human speech recognition is there, and which actually talks to you about the decision making in certain things. So we have done our own research on the speech modulation during the human reproductive cycle, that is the menstrual cycle, and we have come up with certain inferences. I'll be talking it shortly at the end. And then the computer vision, which is Dr. Bodhe has talked a lot. The computer has a vision which it interprets various images and gives your results. That is the CT images, USG images, which has got a lots of use in the gynec oncology and the prenatal diagnosis. And beyond that, the expert system can help us in decision making based upon what next, or that is based upon the reasoning. And then it can have the troubleshooting, like the problems when it is there. Of course, it will warn you that there is certain trouble in that. Like in subclavian RT part, it can say, computer can get confused and can tell there's some error. So this troubleshooting part can also be there in artificial intelligence-based systems. So in obstetrics, it is useful right from the prepartum stage to the intrapartum monitoring to the postpartum stage. And the certain developed examples of that is in the cardiotography and non-stress test. If you look at this graph, we have a complex pattern of graph where we look for the beat-to-beat variability, the acceleration, the deceleration. Then we look for the relation with the uterine contraction, how it is behaving in this pattern. It is all in the graphical recording. Similarly, in the non-stress test, we are looking the same acceleration, beat-to-beat variability in relation to the fetal movement. So when the human interprets this thing, this minor graphical pattern, the temporal pattern can be missed, or the certain things can also be misinterpreted. And this human error of misinterpretation gives a sensitivity to only 60% of this recording. Of course, with an expert and the trained person, the sensitivity can be much better. It shows a high intra and intra-observer variability and is highly subjective, which leads to hypoxia-induced encephalopathy in the newborn, increased cesarean section rate, and then lots of medical litigation because we have to keep the record of this tracing. So how you can avoid this? There comes the role of artificial intelligence. You give an input data, you can just put that graph. The computer will automatically read this graph based upon the artificial intelligence techniques, and these data segments are formed for the normal and the pathological cases, and then it will alert. This is abnormal, and these are the abnormalities detected on that, and based upon that, you can take the decision. The three systems which are being well set examples of use of artificial intelligence in CTG analysis are the infant study protocol, the CAFE, that is the computer-aided fetal evaluator, and the system 8000, which are been validated for that. They are the highly integrated system involving complex algorithm, and they are able to overcome the difficulties encountered in the CTG. There are n numbers of study available on the literature on that, which concluded that the AI-based model for the CTG assessment are more consistent, there's no observer bias, and reduces perinatal and maternal mortality. However, there are the systematic reviews and the meta-analysis, which has said it does not appear to improve the outcomes relative to the expert observer. So when we talk about the expert observer, of course they can do everything and the machine may not be better than the expert or they can be comparable. So what we want, when the expert observer are not available, our machine should be giving the comparable results. So that is what in our labor room, crowded, 1:1 ratio of observers are not there, expert observers are not available, our PG residents are monitoring, our midwives are monitoring. Then what? So here comes the role of automated AI-based CTG monitor, which will definitely give a right interpretation, and then you can suggest for the right intervention. So what we have to do, the graph is machine is recording, you have to fill the data, and then it will give the result. What is the bit-to-bit variability? What is the acceleration? What is the deacceleration? How much is the deacceleration? And that will give it which category 1, category 2, and category 3 CTG is there. And based upon that, you can decide the management. But if you have a data which is able to interpret results as well as can vouch for the decisions, give you the alerts. Yes, if category 1, go ahead this. If category 2, look into these parameters and take the decision. And category 3, you have to rush for the delivery. So like that, the softwares can be trained on this way for the instruction, for the decision, what next also, so that we still don't have developed the, this is one study of the infant study protocol. They have designed a protocol in which they have the control arm and the intervention arm. In the intervention arm, the CTG machines are able to take the decisions, and the CTG based decisions are being followed, and in other, the interpretations are by the observers, and the decisions are also being taken by the observers. So once the result of this analysis are not willing to make a graph, it requires some skills to do that. So what the artificial intelligence does, that is an ARC partogram designed by Dr. Ram Pandit, and I'm also the part of that work. We are giving the data for preparing that, and we may be coming out with a partograph. We just fill up the data, like pulse this much, temperature this much, the fetal heart is this much, the cervical dilation is this, the contraction is 3/10, like this. And once you feel, the graph will be plotted automatically. And now this graph will be interpreted by this machine, and it will tell if this progress is normal, progress is, there is a deviation from the progress. The advantage of this partograph will be you can simply fill this in your tabs or in the mobiles, and then it is a web-based system can be there. So the consultant who are sitting at home can observe this on the web-based monitor, and the real-time plotting can be observed by the observer. See, the resident is doing the partograph. I'm not sure he's by the observer. See, the resident is doing the partograph. I'm not sure he's filling there in the wards or not. But if it is in real time, I can see on the web, on my laptop, or on my mobile itself, whether this plotting has been done or not. So I can keep and watch whether the trainees are monitoring the patient properly or not. At the same time, this is able to give you the alerts. This is normal, this is abnormal. Now, if the uterine contraction is normal, it will tell, start oxytocin drip. If it says the fetal heart rate accelerations are there, then it will tell, stop the oxytocin drip. Or you can plan for the delivery. So like that, alerts can be there. And this will give you the decisions. It tells you about the do's and don'ts about labor monitoring. So You can monitor the labor on site as well as the remotely, and the supervised care is always available. This partogram is still under the process to come up. Then AI for the fetal diagnosis. We have the multiple risk scoring system for the FGR, prediction of preterm birth, prenatal diagnosis of fetal abnormalities, risk of aneuploidy and the other chromosomal aneuploidy, and of course, there's an artificial intelligence has revolutionized the role in the fetal echocardiography. This is how the IUGR and the normal fetus, various parameters are being studied, and they're able to identify the healthy versus FGR system. Then the Doppler pattern can also be analyzed, and based upon that, the Barcelona apps are available where you feed the data, and then it gives which stage of the FGR is there and what next. And this is available on purchase. Then for the prediction of preterm labor, we measure the cervical length, and that is the strongest predictor. But apart from the cervical length, we have many other factors like the socio-demographic profile, the previous obstetric performance, and the other associated medical disorders. And then the Singh et al. Has studied that if you do an amniocentesis, look at certain biochemical parameters on amniotic fluid, which are actually the inflammatory markers, and that will actually add on to the prediction. Then they wanted to stratify the risk. And for that, the ANN is being used, and the risk stratification was done, and the two new factors had been identified. They are having a valuable role in the prediction of preterm labor. So the risk stratification can also be done with the AI-based softwares. Then electrohistography, you are just putting an external transducer, recording the uterine contractility. Home-based monitoring can be done, and the preterm labors can be predicted. So these are the various things. Then obstetric imaging, Dr. Bodhi has talked a lot about that. I'm just going to tell you the fetal anomaly scan, where obtaining a right view of a moving fetus becomes difficult when you're analyzing the structural anomaly. The Leica may be less, and you may not be able to get the right plane where you want to take the images. So there's an automated system in which the ultrasound can pick up the right image and then give the biometry, and then can tell about what abnormality is there, and the different images can be correlated, and then a final result can be done. So this is the fetal HQ, a device system. Similarly, the Sono CNS fetal brain system, 5D CNS brain system, they are all the advanced technology where the AI is being used in image formulation and giving you the results. Then screening for the gynec cancer, of course, the thin PAP system, automated screening of the papinicular stent, where the device scan the entire slide within few seconds, identify the risk abnormal areas, and then the robotic microscopes are there. We are going to focus on the particular area, and then the results are available. So thousands of slides on the screening, field screening, you can be studying it in very fast with a good accuracy. The focal point GS imaging system is an FDA approved for this fasting imaging of the liquid-based cytology. Then there's a compilation of the molecular biomarker, cervical intraepithelium. See that lots of studies are available where the HPV different types and the genetic expressions also being correlated, and finding of the results are there. Then the colposcopy, field worker, you can do, the images are available. You know, the person is doing an image on one part, and if these images are being connected with an AI clouds or the AI local server, then images can be interpreted, and then it can guide from where, which is a suspicious area, where from the biopsy to be taken. Similarly, again, this has been very useful in narrowing the gaps in the colposcopy diagnosis between the tertiary hospital and when it is done in the field or in the peripheral center. So it is really a very useful system, is an implication. Of course, all centers are not available, and it can be also a teaching tool sitting on the distant site. You can train the people who are sitting in the remote places. Similarly, in the ovarian cancer, the genomics, the proteomics, the radiomics, the histological clinical data can be compiled, and the integrated analysis tells you about the image biomarkers and helps in risk stratification, treatment selection, prognostication, and then what next. See, this is an IOTA system has come into the existence, International Ovarian Tumor Classification System, where the new factors were to be analyzed. Then this comparison was done, and the weightage of the color score in the presence of solid area was identified as an important factor marking the risk of the malignancy score. This again, IOTA ADNEX model is available by which you can identify where it goes. Artificial intelligence and in vitro fertilization, the N number of factors are there which predict the outcome following the IVF, and then the artificial neural network can predict this, and based upon that, prognostication can be there, and then patient counseling can be helpful. Then the time-lapse imaging of the embryo has definitely revolutionized the management in the IVF management, because it has an embryoscope which is able to have the continuously monitor the growth of the embryo, and based upon that it decides which embryo is good embryo, which embryo is the bad embryo, and then single blastomere transfer and 4 and 5 embryos are built up in one cycle. You want to implant only one, then of course you want to know which one is the best to be implanted, and the time-lapse imaging has given you to identify the best embryo. Single embryo transfer can be good. Now I'm going to talk about my own research project on the prediction of timing of ovulation by the digital speech processing techniques among the women with the infertility. A pilot project is done. The study is completed, yet to be published. In this, what we did, we recorded the woman's voice from day 5, alternate day, till day 21. And we know the hormones are going to change the voice pattern, the frequency, the intensity, and the volume. And based upon this, the whole cycle this has been done. We are in the training phase where we have collected the data, and we are able to identify, yes, this data shows a different pattern during the whole reproductive cycle, and based on that, we are trying to find out the timing of ovulation. This will be definitely a help. Once the app is available, women can monitor when the ovulation is going to happen, and based upon that, she can have the planned timed intercourse, or the IUI can be planned, a repeated visit to the hospitals can be avoided. So we get the graph pattern of the different voices like this. We face lots of challenge in the device variability, the noise signal, the incorrect pronunciation, the low-level voice, and this all being sorted by using the different mechanics of the artificial intelligence, like random forest anomaly detection. Now we are able to find out the good data for the voice interpretation and getting an ovulation prediction. And the recent data speaks to the sensitivity of 85% with the specificity 100%, the positive predictive value is again 100%, negative predictive value is 74% with accuracy of 85%. But our studies, and it's not a short study, we still have to go ahead to prove that yes, it is validated one and we can get this. So the final word about the artificial intelligence is the way forward in the future. But can AI replace clinical experience and have the sixth sense that the most clinicians feel in the challenging cases? We think yes, like this. Would it be a modern allowing an artificial computer-based algorithm to be a wingman to Darwin's much accepted theory of survival? One thing is for sure, one can see a wave coming. It remains to be seen how we ride it. So the human brain can only make an intelligent artificial brain. Therefore, it can never be a replacement. Artificial intelligence can never be a replacement for the human skills and experience. We have to think how much we are going to use it. Thank you very much.
Well, ma'am, that was really a mind-boggling variety of work for OBG, and it's fascinating to see that you've been doing some research on AI in your own specialty.
I request Dr. Behra to please present a token of appreciation to Professor Sarita Agarwal for her fabulous talk on artificial intelligence in obstetrics and gynecology.
Online. The next presentation is by Professor Vikas B. from Nimhans, Bangalore. Is Sir present?
Yes, sir.
Sir. So, sir, welcome to AIIMS Raipur. So, your topic is artificial intelligence based surgical decision making.
Yes.
Sir, welcome.
Thank you, sir. Coming back to the virtual podium, thank you again. I thank once again the organizers, respected chairpersons, teachers, and friends. My topic for the date is artificial intelligence in surgical decision making. So I have a dual affiliation like IIIT in Naya Raipur. I am a PhD student in International Institute of Information Technology, Bangalore. I'm a faculty at AIIMS, Bangalore. So the work which is being presented over here is my own PhD work, which is being carried out over the past 4 years. So we've been having collaborative work, a medical institution and an engineering institution for the past couple of years. The focus from our side is on surgical and assistive robotics, which we are in need of. And IIIT has graciously supported us through this venture since 2018. We are also in the process of setting up a similar lab in NIMHANS, which is obviously it's Corona time and things are not moving as they need to be. So as spoken earlier, the focus is on neurosurgical robotics. We have two platforms, about a little bit of which I'll speak later on in the talk. So from morning, we've been listening to artificial intelligence like this fancy car, which does a lot of wonderful things, which is robust, moves very fast, solves a lot of problems, and it's very glamorous. So what I'll try to take you through in the next couple of minutes is what is underneath the hood. How does the engine of artificial intelligence run, and how does a doctor, a medical professional, look at the whole field, and how do you design a problem? So to give you a flavor of the topic, I would like to present two independent problems which we face and see how we can work through that and arrive at a solution. So people from non-neurosurgical specialties may be listening to this for the first time. So a brief introduction. You must have heard of aneurysms in the aorta and in the other parts of the body, popliteal aneurysms. Similar aneurysms happen within the cranium, and we perform surgery to treat these diseases. So the surgical process is obviously very complex, and the treatment which we do is clipping of aneurysm. So what we do by clipping of aneurysm is complete occlusion of the aneurysm from the circulation, and also ensuring that there is a patent parent vessel. So these are pictures of which make you aware of the kind of problems which we face. So the what is seen in the left lower part of the screen is a single aneurysm which can be treated through multiple options. So even though clipping is a single name, the type of clips, the way in which the clips are put across the aneurysm can vary, and you can see that in the various configurations which are. Now, this forms a very ideal artificial intelligence problem because there is no one defined solution to this problem. There are multiple solutions, and an optimum solution is what we would like to provide for a given patient. So, how do we proceed through this problem? So this shows some line diagrams which indicate how the problem is developed. So we have a vessel of which the aneurysm is a balloon-like outpouching. The aneurysm is what has ruptured. There is a neck of the aneurysm across which the clip has to be placed. So placing the clip is the challenge that the surgeon has to do. Now, what are the challenges? If you look at the diagram B, we see that that's the ideal configuration in which a clip is placed right across the neck. There is patent flow through the parent blood vessel, and the aneurysm is completely separated from the circulation. So I can represent that with a line. A similar line can be used to represent another straight clipping, but the clip actually involves part of the parent vessel wall, thus reducing the size of the vessel. That is figure A. Clip C is obviously wrong because part of the aneurysm is still not secured, and then it can cause a rebleed. Now, if we look at this as straight line problems, the problem is a little more complicated than that, even in a two-dimensional drawing. So if you have an obliquely placed clip, say for example D and E, both of them are differently placed, but they have a non-optimal outcome. Now, this is how we can state a problem. So this is the problem set, and decisions have to be made on how to solve this particular issue. So we look at an artificial intelligence 2D model. So we have converted a 3D model, which happens in real life, to a 2D diagram. And we have said that we need a straight line which bifurcates the aneurysm from the parent vessel. And that line can be anywhere between the aneurysm and the parent vessel, and we need to optimize that. And there is also this issue of angle of clipping. So the angle of placement is also important. So the first step of the procedure would be to ensure we build a framework. So a graph is built on top of the diagram, by which we say that this particular representation can be made. Towards the right side, instead of placing a clip, we say that we draw a line A and B, AB, which can be represented by a mathematical equation. Now, this mathematical equation represents the line and can be used for computational purposes. Now, I told you that the angle of clipping and the direction of clipping is also important. So we will modify that line to form what is called as a vector. From PU and basic math, we know what a vector is. So a vector has a particular dimension, which is the length, and also a direction. So these two can be encompassed in a vector. Now, if you look at the right side, what I've done is I plotted every single one of those vectors which are applicable. So you have short vectors like C, E, and F, which is inadequate. Wrong vectors like C, D, and G, H, which are inappropriate. And the correct vector AB. So this forms the problem statement, which we can actually go on to the next stage. Now, neural networks are constructed through software. So we can define in a software various parameters, very simple parameters. In fact, the design of this particular neural network would hardly cost about 20 lines. So in 20 lines, we can define the input, the method of processing, which is ReLU. This is actually a simple perceptron. And then we define that the input numbers, see, X1 and X2 are the input numbers, which go into this particular perceptron and provides an output. So this forms the forward part. Now, all of recent advances in deep learning have helped due to have happened due to one single term called as backpropagation. So backpropagation is a method by which we can change the values of activation and the weights associated with these functions, and by which we can get a desired output. Now, desired output in this case is that appropriate vector as against those inappropriate vectors. So how is backpropagation done? So within the software, we can write a parameter like this. So you have aneurysm, you have a parent vessel. In the beginning, we have flow in both parent vessel as well as an aneurysm. By adjusting these weights of X1 and X2, we can do backpropagation over multiple time steps, by which we get the output as no flow in the aneurysm and flow in the parent vessel. So this indicates that a very simple method can be used to develop a artificial intelligence paradigm. So this is, we are looking at a problem from de novo, from starting from the patient and going all the way to a particular solution. We switch gears. Second problem. So you must have heard of brain tumor surgery. Brain tumor surgery is very similar to tumor surgery being performed in other parts of the body. Now, as a surgeon, it is important to treat brain tumors because most of them are malignant. Surgery still forms the mainstay of treatment, and there is always the risk of neurological deficit. There's also the risk of leaving behind residual tumor, which can cause further morbidity to the patient and most probably death. So this is a photograph from an actual operative microscope. Now, to give you a context, the central part, which is looking red in color, is the tumor. The peripheral part is the whitish area is the normal brain. So this is an actual operative photograph of how a brain tumor looks on the table. And by looking at the bipolar forceps, you can make out that it is a microscopic view, and microscopic view through an operative microscope, which is handled by the surgeon. So if we look at this as a problem and try to develop a AI model for this, how do we go about it? So the surgical process will have to be analyzed for that. So what constitutes the surgical process is these 4 independent sets of activities and activities which a surgeon has to perform. So the first is tumor visualization. So during the process of surgery, I've shown you the first step of surgery where I've just started seeing the tumor. So that is tumor visualization. Tumor visualization is through the operative microscope. You need to position the microscope to see various parts of the tumor at various points of the surgery. Then there is the actual removal of the tumor. So removal of the tumor can be through multiple things. It can be through instruments such as suction, bipolar forceps, QSA, So, but all of them involve the concept that tumor or the volume of tissue which is present has to be taken out from the patient. Now, it is very simple that these two are very linear processes. You remove tumor and you see next part of the tumor. Where is the complication? What is the problem? The problem is in blood loss. So most tumors which are malignant have very high blood loss, and the surgeon during the process of surgery has to keep a track of blood loss. And there is obviously a finite amount of blood which a patient can suffer, and so it is important to track the blood loss. Now, is it sufficient that we do only these three things and be happy? No. The risk of neurological injury is there at every single step of the procedure, and so it has to be monitored. So if we are to think of an AI model, which we intend to use for operative purposes, the AI model should have cognizance of these factors. So it should have methods by which it understands what tumor visualization is. Then there should be something to remove tumor, blood loss, and be aware of neurological injury. Now, when we design models, like in the first example, we cannot model the entire scenario. We cannot use a model which can be built on an operating table. So what we instead use is mathematical models for developing these constraints. So the first step would be to select an appropriate method. So is there an appropriate mathematical method which can be used to model these things? Next step is input it into one of these learning paradigms which I showed you earlier. Earlier, I had shown you something called as perceptron. More conventional techniques include CNNs, which are convoluted neural networks, LSTMs, which is a long-term, short-term memory, generalized adversarial network. So there are very sophisticated networks which have very different purposes, and these can be used as the methods by which the training can be done. Now, it is very important while designing the problem that the entire process be representative of whatever we are trying to model. And we should also remember that there is a finite computing power. We cannot model the entire. Say, for example, would you like to model air temperature within the operating room? No, because it doesn't actually affect too much. Meaning, you do have bacterial counts, but you do not use it in the current model for a tumor resection surgery. So the first step is in developing something called states. See, surgery is a continuous process. We cannot model a continuous process in that fashion. We need to define states. So how to define a state is, we need to say that, yes, a single part of the tumor is visualized. At that same state, there is a particular amount of the tumor which is removed, which also gives an indication that there is some amount of tumor remaining. And what about the blood loss which has happened till the present time? And what is the risk of injury which is happening? So that constitutes, all these factors can be labeled as something called as a state. Now, when we have a state and multiple states, we need to transfer from one state to another. That is the progression of surgery. So that is defined by actions. So what actions can a surgeon perform or contemplate? So one is remove tumor, obviously, remove blood, which is within the operating field. Reposition the microscope, because visualization has to change from one part of the tumor to another part. This is a very specific requirement for neurosurgery and even in laparoscopic surgery. And at each step, you have to evaluate the risk. Say, what is the risk accumulated till now and what is going to be the subsequent risk? Cost. A simple obvious cost is blood loss. But there are also other hidden costs. So there is the risk of handling tissue. So like what are they? Say you handle normal tissue, there is a risk of injury. There is a risk of injury of handling abnormal tissue also without your knowledge. I think morning there was a very elegant video, laparoscopic video, in which something which was not in the operating field got injured. There is a risk of residual disease. Say if I stop surgery at this time, what is the risk of residual disease coming back to the patient? And obviously the risk of neurological injury. Now, I took you through these particular steps because of a particular reason. Now, I'll go into the next step. So once we have defined the states, we define states as being constituent of these parameters. And there are actions which are defined between each state to the next state. So a surgical process is split up into individual states. So each individual state transitions from one state to another state by a particular action which is performed and by a certain risk which is accumulated. Now, the change between two actions and two risk parameters can be defined as the cost. Now, please note that you can make these states as small as possible, the distance between two states. Now, the distance between two states is a mathematical concept, and we can make that as small as possible. The definition is important because as we make this definition, we are making the problem differentiable. Differentiable is by the use of differential equations. And all of the conventional contemporary neural network architectures are based upon the simple concept that a problem needs to be made differentiable, by which you can use differential equations in some fashion or the other to model the problem. We'll extend the logic. Now, each state cannot, surgery is a stochastic event. Stochastic, I mean that you cannot actually predict what is going to happen in the next step. So that is where the risk of surgery lies. Now, how do you model stochastic events is through trees like this, by which you define various states which can happen from one particular state to another, attribute probabilities for each of these particular states. And then you can calculate cost between any two different states. Now, again, from the first example to the second example, what I've done is I've transitioned from the actual operating field, gone through a mathematical process, and developed a model which will which can replicate the process. Now, to give a more visual feeling, say what I showed you is purely mathematical. Can that have some basis to the direct operating field? So let us say that the bipolar forceps is starting at S1, which is at one part of the tumor. The very act of moving the instrument from one place to S2 or to S3 or to a given point Sn on the surface of the tumor is an indicator of the state. Now, each time that movement happens, there is something which is happening to the tumor. There is some blood loss. There is some risk which is occurring. And so that is actually the cost which is accumulated, which is represented by the other vector. Now, what I've transited is, again, from a pure mathematical scale, I've again come back to the original network concept. So there, in the first example, I showed you X1 and X2 being different entities. Similarly, we can use these parameters as inputs to various learning devices. The next step of the story is to build solid mathematical models. So we need to convey this to engineers. You cannot convey to an engineer that you want an abstract process like surgery model. But it is far more easier if you say that, yes, we have a state function which constitutes of the microscope position, the volume of the tumor, and the blood loss at point T. And we need to get a path which is the most efficient, which goes from S1 to Sn and through all points in between. And can we model blood loss through an equation? And this would be an example of that. The sum of all blood loss between any two states from 0 to time T, where T is the total extent, the final extent of the surgical process. And cost is another parameter which can be modeled like this in the form of equations. Now, what I have so far defined is actually a Markov decision process. Now, when we say Markov decision process for a computer software engineer, oh yes, okay. So this is something which we can use for reinforcement learning. So we have transited somewhere starting from an on-table problem, formulated the maths and the processes, and given it in a packaged fashion to a computer engineer who can understand that, yes, okay, so these are the parameters which need to be modeled. This is the output which you are trying to get, and this is the learning which is involved in the entire process. Now, the beauty of a Markov decision process is that it is useful for such processes, such as surgery, which actually are very abstract and are very difficult to model using conventional software techniques and other mathematical techniques. So here we can actually define something called as pi. Now, pi is actually a policy, and the optimal policy is a policy in which you take out the tumor in the fastest possible time, which is the S-min, the least amount of blood loss which is possible, with the least amount of cost, that is the risk to neurological damage. So what I've tried to show in this brief discussion is the possibilities which exist for physicians, doctors, surgeons, who can use their day-to-day problems, transit from the problem on the bedside or in the lab or in the operating theater, develop concrete methods by which we reach the engineers. It is not that the engineer gives a black box, you plug in your problem and you get an output from the other side. That approach leads to a lot of problems in the long run. So it is useful for the doctor himself or herself to participate in the problem building process, such that you know that when there is a problem later on in the model implementation, that you are aware of the issue and you can solve it in a better fashion. So the aneurysm model is a very simple model. As I told you, it takes only about 20 lines of code to implement the entire thing. And there is very minimal computational requirement. And parameters are minimal. If you looked at it, actual parameters are there's only a line, which is basically a vector, and a vector has 2 dimensions. And people who are familiar with the computer science side would obviously recognize that these are very straightforward input parameters to neural networks. But if you look at the implementation, it's very difficult, because not only you have to feed the line into a robot, but you also will have to feed the line in such a fashion that it does the dissection and other things, which is a very different ballgame altogether. So it is not, what I want to convey here is it's not possible to solve the entire problem. What an attempt is being made is to solve part of the problem and show that it is feasible, it is doable. And then we proceed on to the next more and more complex problems. If you look at the glioma model, which is the brain tumor model, we saw that the parameters were too much. There were so many parameters which need to be learned, which need to be trained, which need to be kept track of. So there are multiple parameters, and these also with contemporary techniques can be implemented. You put it into a convolutional neural network, you would get reasonable amounts of accuracy in toolpaths. However, incidentally, as opposed to the aneurysm model, practical implementation is relatively easy. So how is it easy? I'll show you subsequently. So what I would like to convey, or convey a message, is that the definition of the problem is important. The problem definition has to come from the doctor. AI is not just about using a particular technique. You just don't have a problem, put it into a black box and get the result. Most problems in AI which are successful are basically image problems. So they have been very successful with taking an image, extracting information out of the image. But we as doctors should remember that all of our patient problems are not imaging problems, and they need different kinds of treatments, which is what I've tried to highlight. So there are very rich problems and very abstract problems. Say, for example, surgical decision making. They're very hard to conceptualize otherwise. But AI gives us an opportunity of implementing or finding solutions to such complex problems, as can be shown here. So the next thing is how to implement. You may have an idea, but you need very rich software background and very large funding to actually implement these things, which of course I think the administrators in the institute will take care of. So having said that, this is part of my PhD. So what exactly is the other parts which I'm looking at? So what is surgical style? So how does one surgeon differ from another surgeon by the way of doing things? What is surgical skill? How do you quantify surgeon skill based on his or her work done in an OR, not on from outside the operating field? What is surgical risk?
Professor Vikas?
Yeah.
Out of time.
Yes, I'm finishing. So we plan to implement it through two different robotic systems which we have developed. There are two videos. I think I'll skip the videos and conclude the talk. Thank you. So these are the publications which we have in our area. Thank you.
Thank you, Dr. Vikas. Nice presentations due to shortage of time. So your presentation is nicely described by what is the pre-surgical decisions in combination with the mathematical calculation of a model. How will you take decisions with a mathematical model? You will nicely describe the major surgeries in, as a neurosurgeon. You will take decisions by aneurysm, glioma, how we can tackle and pre-decisions. Can we take questions with our neurosurgeon, Dr. Anil is here. Dr. Dynamic Surgeon, Dr. Anil, can you, any questions? No. So at the end of, we'll take surgery. Thank you.
Thank you so much, and
thank you.
Great to meet you online, Anil.
Thank you, sir.
Thank you.
I'd like to request Professor Alok Agrawal. I'd like to request Professor Alok Agrawal, sir, Organizing Secretary of this CME, to present a memento to all the chairpersons. Thank you, sir. For the next session, I would like to request Dr. Santosh Rao, sir, Dr. Bikram, sir, and Dr. Manisha, ma'am, to please chair the session.
As Dr. Bikram had to go on an emergency surgery, may I request Dr. Momita to come and chair the session? Dr. Momita from Plastic Surgery.
Good afternoon, everyone. So we are hereby starting the session number 5. And the first talk, we'll just straight away go to the sessions because we are running short of time, half an hour in delay. The first talk is on artificial intelligence in healthcare from the person himself from Google, who was they are the masters of artificial intelligence. Dr. Karthik Taneja is the director and head of channel from Google. Dr. Karthik, the dais is yours, please. Dr. Karthik, I think you need to unmute yourself, please.
Yeah, sorry. Can you hear me now?
Yeah, we can.
Great, great. Thank you. Apologies for that. Good afternoon, everybody. Thanks for inviting me, and looking forward to this discussion. How much time do I have, Doc Sab?
We have 30 minutes for your talk, sir.
Okay, great. Thank you. So let me just go ahead and share my screen, and I have a presentation which I just want to share with you. Can you guys see my screen?
Yes, very much.
Yes. Okay, good. Well, good afternoon, everybody, all distinguished doctors, faculty members, organizers, and a very, very distinguished audience. It's a real pleasure to be here with you today afternoon. So thank you for inviting me. What I wanted to do today was spend a little time and help you understand and look at AI and its practical implications in healthcare and what is really happening in this field. I have a lot of examples which I wanted to share with you. This will not be a typical technical presentation, which I'm sure you all have seen since the morning, but it's going to just share some very typical examples and some of the things that are happening at a global scale, and how companies like Google think about artificial intelligence and what are they doing about it, because this is a very new field for everybody, including some of these large tech companies. So, without much ado, let's get started. So the goal of this session is I want to speak to you about 5 broad issues and trends, and fuel some new ideation and some new thinking on that, and hopefully this session will help you just do just that, and would love to get your views and your ideas and your suggestions after this session. So here is the agenda. Like I said, I want to speak to you a little bit about AI in healthcare, some of the global trends that we are seeing, and some of the examples that I want to share. I also want to talk about some challenges and opportunities that we see in AI, and how we in India, specifically the leading health community, can look at it and look at finding some solutions and the path forward going through this very exciting times in technology advancements in healthcare. So here is an example. Here's a quote from Charles Dickens. Is one of the most well-known authors globally. It basically says it was the best of times and it was the worst of times, and we are living through a major challenge, and perhaps the biggest challenge of our lifetime. And that's COVID. And we have spoken a lot about it. There have been a lot of discussions, but broadly, there are four broad challenges which COVID has brought forth. The first is it's a public health challenge. We know that. The second is it's an economic challenge. Economies across the world have been affected in varying degrees, and India is no exception. It's a humanitarian crisis as well, because what has happened is that the people who are on the lowest economic strata of society have also led to a major crisis in terms of their average incomes, their earning ability, and so on and so forth. And fourthly, it's a technological challenge. And why I say technology, because during the last 18 months, one thing that we have all come to rely on heavily is technology. Now, think about a conference like this. It would have been unthinkable about 18 months back that we could have so many panelists and so many speakers and so many attendees online. So technology has actually helped us get through this pandemic, and is helping us get through this pandemic even more. And going forward, the tailwinds on the technology adoption are going to accelerate, and are going to accelerate at a very fast pace across industries and across different consumer segments. And healthcare is going to be no exception on that. And I think if you have to take one biggest takeaway from this conference, is that technology is here to stay. Artificial intelligence will increase in an accelerated manner, and it will only help your work become more and more easier. And this is what I want to kind of share with you. Even though we are in a crisis, Sir Winston Churchill says that do not waste a perfectly good crisis. And we have, as we come out of this crisis of COVID, and as we come out of and look at building a better, faster, and an improved world, I think this is a great time to use technologies like artificial intelligence, machine learning, deep data science, deep data analytics, and predictability to drive better outcomes for all of us, and whether that be in healthcare or related areas as well. So let's look at some of the trends in healthcare, and some of the things that have been happening. And what I will do is I will share some examples, and then I have some videos which I want to share. Hopefully the videos will play. If not, I'll just talk through them, and would love to get your attention on some of those examples that I would love to show. So, so AI is not new. We use it every day. These are just some of the products that we use from Google every day. But take for example, search. We have predictive search. We have maps which we use. We have Gmail which we use. We use smart learning on smart reply on that. You have Chrome which you use. You have photos you use smart image recognition, etc. You have the assistant which you use on a regular basis, and the translate product as well. And this is just one example of one company which is driving machine learning into all its products and artificial intelligence. And more and more such products from every company on the planet is coming out. I think the most important thing for us to remember and think about is how do we use this technology to make the best impact for medical science in India. And I have some thoughts and ideas which I will speak to you at the end of the presentation, and hopefully that will drive some new ideation and some new thinking for all of you. So, so what has been happening during COVID? And here are like 4 or 5 examples which I want to share. AI has actually helped in management of COVID in a big way. The first example is Blue Dot. Blue Dot is a company based in Canada. In Florida, they delivered a very early warning sign before WHO actually called this virus out, and they gave very early warning signs to scientific community about this pandemic which break out. Right, so that's number one. Number two is there's a this thing called COVID.net, which is basically a deep learning module, and it's designed to detect COVID-19 positive cases and also accelerate the treatment for those who need it the most. So that's, I think, a really important thing. Then Google's DeepMind is a company based in the UK, and Google acquired it. But basically, they are helping scientists study various features of the COVID-2 virus and the protein structure of the virus as well through, again, deep computational algorithms and deep machine learning algorithms as well. Right. So, and that is obviously helping us, look at the various strains of the virus, and looking at how to mitigate and manage those outbreaks, etc., and different things. Then, how are we managing the COVID outbreak? So, there's an AI-based computer vision camera. It is deployed in China, and it's actually basically, you wear it on a helmet, and you kind of look at crowds and look at the temperature, and immediately you may spot somebody who has a higher temperature, etc. And I'll show the video of that in the next slide. Then there's something known as FluSense, which is a contactless surveillance platform. It is basically used to forecast seasonal flu and other respiratory outbreaks, and also look at such as COVID, etc. So this platform is also there, and that's using deep analytics and machine learning to do that. Then you have autonomous service robots called humanoid robots or Cloud Ginger, and they are being used in hospitals in China as well. And then they're using them to assist healthcare workers, especially during quarantine, or where healthcare workers are limited in supply, or they're not able to go and look at the patients, etc. And then a lot of these track and trace devices have come, which are actually helping manage COVID better. So, these are just some examples that we are seeing from a COVID management perspective of what is happening around the world on how machine learning and AI is being used. And I want to share some examples with you. So this is the example, play the video. I hope you can see it. Just a second, just loading. Can you hear the video?
Yes.
So this is basically a helmet where you can actually look at crowds. A surveillance officer can wear it and look at the temperatures of different people in the vicinity, and that data is kind of managed and uploaded on a central database. And then based on that, you can figure out where all is the risk of a COVID outbreak, and start looking at very localized containment zones or management of COVID. Right. So this is one example. Then here is an example from Liechtenstein, which is a small place in Europe. So this is a bracelet which gives real-time information about the symptoms of a patient, and they've given this very simple, cost-effective bracelets to each and every population, to each and every person in the population. Now, of course, it is easy because the population is small, but again, a very innovative solution to see if there's a second wave, third wave coming up at a real-time basis. And this is an example which I want to share, is from Belgium, of how social distancing is being maintained using these smart technologies. So they are giving devices in their factory and in their port for people just to maintain social distancing. So the devices are programmed to maintain a 6 feet distance. So if you come in close contact with another person, the device will automatically beep or vibrate to give you that alert. So again, a very innovative solution of how COVID is being managed, because you cannot close down the port, you cannot close down essential services. So how to make sure that people are looking at staying away from each other and maintaining the COVID protocols like social distancing, etc. So the next point is, what is happening in public health? And again, a public health, because COVID is a public health issue, there are many other such diseases where AI can be used and is being used. And I'm going to share an example over there to actually, have use data in predictive health, disease detection, mitigation, and also eventually elimination. There is an example of controlling malaria and dengue. It's called Project Debug, and this is something that the Google scientists are working on, and I'll share that with you. And then also look at how AI and ML is going to help us in the vaccination drive. Now, especially in India, we have a population of 1.4 billion, and if the whole country has to be vaccinated twice, we need to have a very scientific and a data driven model where we can get the entire country vaccinated. Otherwise, we will never be able to achieve this task properly. So I think there's a very, very important case of building data driven predictive analytical models to drive this vaccination across the entire population. And then another example is, how do we healthcare professionals work closely with disaster management authorities to predict national disasters and provide early warning signs to, or early warnings to healthcare systems to manage and monitor the load better? Things like cyclones, things like floods, things like heat waves. And every time this happens, every time there's a flood and the healthcare systems are not prepared, and it does not have to be this way, because today the weather science, today the science allows us to have very predictive, accurate models for us to provide accurate data of where these outbreaks or where these disasters might happen. And this is something that working very closely with another example I want to share was working very closely with traffic management and healthcare. So, so take the example of India. India has the highest traffic fatality and traffic accident rate in the world. I think it's about 4.5 lakh people are affected by this every year. Now, there is definitely a very important case of figuring this thing out through deep data predictive analytics and provide that data to healthcare professionals so that they understand the kind of trauma that may come, or understand the areas where you have the maximum such cases. And that is a very, very critical part of improving the well-being and health of individuals in our country, because this is such a major problem, and this is preventable. The problem is that this is preventable, and we are not able to prevent it, and this data does not seem to be going down over the years. So AI and machine learning will be a very, very effective tool if we can work closely with these authorities. So here is an example which I wanted to share with you for Project Debug. This is basically, again, an AI and machine learning tool, or machine learning tools are used to see how we can have malaria be controlled. So have a look at it, and it's a very interesting case study.
We are not able to hear anything. I hope there's no audio in this.
So basically, the video is saying that you have these mosquitoes which cause these Zika, chikungunya, and dengue, and there's not enough we are able to do as countries and as policymakers in healthcare to reduce this year after year. So what they're basically saying is that they're looking at developing these mosquitoes, the male mosquitoes, who can't breed and can't bite. And these good bugs will be able to stop the mosquitoes from biting. So over a period of time, when these mosquitoes are released, they will reproduce, and eventually you will have a population of non-female mosquitoes, and most of these are harmless, and they will not spread the disease. But I think the important thing to look at it. So what they're trying to say is, how they're looking at making some of these good mosquitoes or mosquitoes which don't have the danger. So they are this is a bug sorting algorithm. So these are bug raising robots, and these are bug raising machine learning algorithms, and they're going to use that to raise more and more better mosquitoes. And then eventually, once these good mosquitoes are spread across the world and across different areas, there is a great chance that diseases like malaria, dengue, chikungunya will reduce. So I think this is an audacious project, but if it comes through, and the early trials are very promising, I think this is something for a country like India is a very simple and effective method to look at it. Then let's keep moving. I wanted to share with you some other other examples from in preventive healthcare and conditions management. So there is a platform called the Baseline Evidence Generation Platform, which is basically collecting data from millions and millions of people through smart devices in effectively managing outbreak of diseases and proper treatment protocols. So this is again a major data management platform that is doing. Then there's something else known as OnDue, which is basically a condition management app. It looks at managing type 2 diabetes, which data is kind of flown in from the body and other systems, and obviously also looks at some of the other chronic conditions as well. Smart contact lenses, probably you must have heard about it, but basically it gives live information about the glucose level to this app. And it helps manage diabetes in a much better way. So you don't have to prick yourself all the time. Then there's a smart spoon by a company called Liftware, again in collaboration with Google, is basically helping manage cases of cerebral palsy, medical tumors, medical tremors. Difficult for people to use their hands, etc. Then you have connected care systems for BAMI. There's something which has come up by Lumi. And then also look at improved screening, monitoring, and management of patient with on AFB. Basically helping them so that they never have a stroke, because these are the people who are at risk of having a stroke and clots. So live monitoring of those as well. And then also developing solutions people with sleep apnea. And then the study watch, which I said feeds into the Baseline Evidence Generation Platform, which basically provides you can volunteer for it, and it gives real time information from different populations, and how that kind of impacts the overall wellness and development of health protocols and preventive health medicine as well. So this is the in terms of what is happening on. And so again, some examples, there's millions of other examples. These are some examples which I could think through and present it here for you. I want to again share a couple of videos with you. One is this smart diapers, which is a really interesting concept. And basically it gives real-time information about your baby and whether the baby has wet or not wet, and you can monitor it using a sensor and a camera, and actually spend some time uh, uh, and monitor the baby a lot more better. So this is a smart tracking device, and then you have an app which directly transmits to the app through the camera. So you also uh, you can leave the baby in the crib, go to a different room, keep an eye on the baby, travel with the baby. And again, these are very simple applications of machine learning and AI, but it's a huge benefit for young parents to manage the babies, etc. So again, a very very interesting application. So giving another example is Liftware. So this is a company which basically manages patients with tremors, because they have a huge problem in doing simple tasks like brushing your teeth or combing your hair because of the challenges with their condition. But here is a technology that can uh, help them manage it. So here is a technology that is developed basically in association with these patients. And this basically detects the tremors on your hands and adjusts the position of the spoon. There it is, go like that. So it greatly improves the quality of life for these patients. And you can easily charge it and easily manage. And this data is again fed through an app to make better decisions. So sorry. Yeah. So let me come to some of the challenges of AI and what is a big challenge that is driving and will be probably a problem, and we need to think through this. So a lot of the AI and machine learning being is dependent on deep data and getting a lot of information on data, etc. But also with the advent of COVID, data surveillance has become the new normal. And we as professionals and the policy think tank and the government and social scientists need to come together to figure out what is ethical and what is not. So it's basically an ethical and moral issue. And if you look at data, the questions to answer over here is: who collects and uses and controls the data? Do the healthcare professionals have the access to data? Does the government have access to data? Can the data be used by crime detection? How much of the data needs to be shared, etc. The second is machines versus humans. So how much access of data needs to be with the machines, and how much access has to be with the humans? Now, if it is only algorithmic, then there are very high chances that data is secure. But who are the humans who need to have access to your healthcare data, and what do they do with it? Can we have interchangeability of data? So I spoke about, can the data that you develop, can it be moved from one department to another? So from healthcare to crime detection, for example. But that's again a very ethical and a moral question that we need to answer as policymakers and healthcare professionals. And then how much data are we collecting? Do we collect data just for patients? Do we collect data for communities? Do we collect data for citizens at large? And what kind of data are we collecting, and what do we do with that data? So I think there are fantastic opportunities over here, and since we are still in very early stages of this technology and this development, the policymakers in India, the government, the social scientists, the economists, the philosophers should come together to make out the policies and laws of how this data will be used. It's a very very pertinent question before it becomes a big elephant and goes out of hand. and somebody misuses this data, we need to be really, really ahead of this. And all the eminent scientists sitting over there in an institute like AIIMS can definitely take this up as a very important task and move ahead on this. We need to set some principles for AI in healthcare, specifically in India. And currently, it is just a science which is evolving like an amoeba without clear direction and how the principles will be adopted. And then look at a really important thing again I mentioned about privacy was to health data maintenance and protection. We will at some point have computer systems to manage and collect data of all our citizens and patients, and we need to have strong privacy and strong systems to manage and take care of that data. And finally, it's important to define the principles and practices of AI in healthcare in India. I think this to me is the most important thing as this science evolves, and I think we should take this up on an urgent basis and look at what are those principles which are accepted by the health community, by the social scientists, by the government and the policymakers, and even the legal system. But here are some principles, and these are basically based on some of the principles which Google has set. But this can give some guidance and directions. So if you look at some of the principles on the left, it should be, whatever technology and AI systems we develop have to be socially beneficial for our people. It should avoid creating biases. So what I mean by biases is if you have a certain demographic and certain data that you're collecting, if you only collect that kind of data, the machine will only learn that kind of response. So if you're collecting data only from big cities like Delhi, Bombay, Raipur, etc., you will only have that kind of response. If you're collecting only from certain demographic, you will have only that kind of systems being developed. So you have to have a very unbiased data from all demographics, from all backgrounds, from all communities to really get a good picture of the systems that need to be developed. Obviously, the systems need to be built and be tested for safety, which is really, really important. And whatever we develop has to be accountable to the people of India. You cannot just develop and build something without accountability. Privacy is very important. I've spoken a lot about it in the previous slide. But making the systems are designed in such a way that privacy is the core and the fundamental aspect of that. And then uphold the highest standards of scientific excellence. I think we have some of the best minds over there to do that. And then some of the practices over there is basically use a human-centered approach. Look at identifying multiple metrics, not just one metrics, to access training and monitoring. And then whenever possible, look at and examine your raw data, because again that is really, really important. And sometimes what happens, we miss the we miss the wood for the trees, and so it's important to look at the raw data as well. Understand the limitations of your data sets and models, because sometimes you can do that, and then test. I think that's a really, really important thing. And then finally, continue to monitor and update your systems which you develop. So in my opinion, these are just starting slots, but if you kind of continue to move on this, you will be able to build a really good principle and practices for AI in healthcare. And then
Dr. Taneja, can you hear me, please?
Yes.
I'm sorry to interrupt you in between. We are, I think your time's up. We are running short of time.
Yeah. I'm through. And this is the last slide.
Thank you.
So the greatest. So here's I want to end with a quote by saying the greatest danger of artificial intelligence is that people conclude too early that they understand it. And we are, like we have learned today, we are in the process of actually learning this science and this and this whole process. And we should not conclude that we understand everything. We will build as we go along, but adopt the principles that we wanted to do that. So with that, I thank everybody for giving me the chance and the opportunity to speak to you. Hope it was useful. And if you need any further understanding of this, I'm available for any questions, etc. Please reach out to me on LinkedIn. Thank you very much.
Thank you, Dr. Taneja. Any questions from the audience? Sure. Dr. Taneja, it was a wonderful talk. In fact, there was in the talk, we went us to the minor details like, monitoring, including the diaper, or it might be monitoring the patients with sleep apnea. It was quite interesting, and it was a nice, informative lecture. Thanks a lot, and thanks a lot for staying with us. Thank you, Dr. Taneja. Madam, can you invite the next speaker?
I would like to invite our next speaker, Dr. Ashish Kumar Singh. He is director of Anup Hospital, Patna. He is master in robotics. His topic is robotics in orthopedics and joint replacement. Dr. Ashish Kumar Singh. Sir, over to you, sir.
Yes, sir. Yes, sir. Is my voice clear? Is my voice clear?
It's audible.
Am I? Yes, yes. Okay, I'll just start.
So you have to unmute. We are not audible.
A second.
Sir, unmute yourself.
So okay. Good afternoon, everybody.
Please.
Yeah, I'm very thankful to each and every one of you for organizing this CME on artificial intelligence in healthcare.
You are not audible.
Okay. Yeah. Am I audible?
It looks like you're logged in from 2 devices. That's why we are not able to listen.
Now? Am I audible now? Hello?
Sir, you are not audible.
Hello?
Now audible.
Yeah, am I audible?
Now audible, sir. It's clear.
Okay. Anyway, sorry for this. So I'm very thankful to everyone for giving me an opportunity to talk on robotics in arthroplasty. So important thing is that we have been discussing more on artificial intelligence, and the robotic is the next step. So what we have discussed over the past couple of hours is that robots and artificial intelligence, it aids in accuracy, it has confidence and reproducibility, and it has flexibility.
Sir, your
Yes,
voice
sir.
is not clear.
Give me 1 second. 1 second. Okay, allow me to join on this with seller dollar. Unmute, and I'll be clear. Okay. Okay, is my voice clear now?
Sir,
Yes.
your voice is cracking.
Oh, it will be there, sir. Okay. So, anyways, is it now clear? Yes.
Sir, better.
Yes.
Continue.
Okay. So the total joint replacement, a simple answer. The robot is the next level. Now, when we talk of the robot, the most important thing is how is it developed? And since 1950s, 1990s, 2000 and 2000 continuation 21, we have had an evolution of planning and execution. Initially, we had a static plan, then we had navigated execution, then we had navigated freehand tools, and ultimately, in this present era, we have robotic arm which assists us in surgery. Basically, how do we understand technology? This is important. The most important thing which we need to understand in orthopedics is the chaos. Is the body which is computer-assisted orthopedic surgery, and we use computers and robotic technology to assist in providing musculoskeletal care. As it has been reiterated that computers augment orthopedic surgery, it aids in geometric precision, reproducibility, perfect memory, and a lack of fatigue. We have to understand that computer-assisted surgery is basically not a robot. We have a simulation of human brains and the technology. It does not require dedicated technicians, and it does not replace the eye of the surgeon. Now, which system are we working? It's important. You cannot imagine doing a surgery when you're sitting in a room and the machines are doing the surgery. It is only possible in big drilling or milling mills and without intervention of any person sitting on the computer. But when we talk of automated robots in orthopedics, it is a semi-active form that the robots are controlled by us and we plan and helps in execution. And passive, that we are doing it, but it is helping it. Now, the second important thing which we need to understand is what are the modalities which we are going to feed the computer. Like we can say that a computer is an electronic data processing machine which processes data under control of predefined instructions. So how we are going to give instructions? Are we going to make algorithms? So no, here we use modalities. It can be X-rays, it can be MRI, it can be CT, or it can be image feed. That is navigation surgery. Now, computer navigations and robotics are actually rigid bodies, and it helps the surgeon to precisely align and be there where we want to be without any much problems, and it helps in perfect execution of the plan. Now, if you have a look at this figure, you can see that which two lines form a 10 degree. You can say A, B, C, or you cannot say that which lines are absolutely parallel. So in the next, you can see the figure A was 10 degrees, whereas E and F was very close. So here comes the role of the robot or computers or artificial intelligence. Now, the first computer-assisted surgery was done in 1997 in France by Fred Picard. Fortunately, I worked with him for with my fellowship for 6 months with him. And now, yes, it's the time for a long coffee break. Yes, I think so, yes, because the robotic surgeries are here and we have been doing orthopedic arthroplasty with the help of the robot. But what are the parts of the robot? You have so many gadgets here, as you can see. So, as I discussed earlier, it is an enforced, controlled robot, and there are various market other companies. Mako, Navio, Rosa falls in this category, and many more to come. These are some pictures which you can see. This is the new kid on the block, Rosa, which has also come up. And RoboDoc is also coming, automated handheld robots. So, as a part of understanding, for any system to work, we need to give them data, and that we call as registration. And then a 3D model is captured. Then we plan, and then the bone is prepared with the help of the robot. Now, there are two types of robotic guidance. One is we feed in CT scans, and in one, we feed in X-rays. In both these modalities, we are feeding something so that the computer is getting the data. And then we have a pre-op planning, and then intraoperatively, we align and plan and execute. So again, another thing is image-free robotics, that is navigation, is also there. Advanced navigation, that is, we don't feed any data. So basically, the input might be in the form of CT, MRI, or image feed. Now, whatever we do, we have enhanced planning, we have dynamic joint balancing, and we have robotic arm-assisted bone preparation. So let's talk about one system. Let's talk about Mako robotic arm. We have so many gadgets and screen, but basically it gives us visual feedback, tactile feedback, and audible feedback. So like we were discussing in the last lecture, the artificial intelligence guides us. Yes, this is the basic pattern and there we have to go. So in the same way, when we are going wrong, the computer helps us in getting it right. It stops if we don't listen to the robot. Now, it also has accused stop technology. Like it will stop. If you're going out of the haptic boundary, it will stop. It gives you insightful data and analytics, and you know what are your next 4 to 5 steps before you are even in the first step. So how do we go about it? Now, as we have been telling that we need the computer to give data. So in the case of Mako, we give X-ray CT scans. The CT scans then is segmented. And once it is segmented, we have a 3D model of the knee and the plan on a special software, what would be the actual alignment balancing for a particular patient. And it aids in intraoperative planning, and the robotic arm then helps in the bone preparation, and we'll take you there. So this is the pre-op planning which we get before the surgery, a day or two prior to the surgery. Now we plan beforehand, so the surgery starts before we enter the theater. And when in the theater, we have all these communication systems that we call trackers or arrays or visa disk. Through visa disk, the computer generates the 3D model, and then the 3D model is made sure that it is matching the CT model, and then the robotic arm comes in action. So we do the registration. So what do you mean by registration? We register the bone, and this data is then verified by the CT. Are we in the range of 0.05 accuracy? And then we go further. Now, once we go further, this happens, this is the registration phase. We have a CT scan model on the screen, and we are verifying the points which the computer is asking us to do so. Once we do this, then we are making sure that it is in the range of 0.05 millimeter value. Now, once we have this data, we can do dynamic planning on the table that yes, this is the actual scenario and this is what we need to do. For example, in this case, you can see that there is some tightness on the inner aspect of the knee, but we are able to see on the screen that yes, there is some tightness. It is showing 14 on the left front corner and 16, so 2 millimeter tightness, but we then take the cuts and we exactly know how much cuts it is required. And then finally, if you see, we execute with the robotic arm. So we have knee retractor, we are not using any jigs, and we are seeing the computer and making sure, yes, we are cutting it there, and there is no chance of getting things wrong. There is no chance of getting any soft tissue damage, and precision is almost 100%. Now, the most important thing is that these are costly instruments. We need to understand a lot of socioeconomic problems are there to take this. But at the end of the day, you plan it pre-operatively, and the same knee, as we planned, we did the cuts, executed the cuts, and we are absolutely in the range what we desired initially before the surgery. But the whole question is,
So are you there? Dr. Ashish, we can't hear you. I think there's some communication issues.
Dr. Assis? Sir, you are there? We are not able to hear you.
Sir, are you there? Can you unmute yourself, sir?
So are you able to connect?
So the question is, why robotics? The most important thing here is that the surgeon can make better surgical decisions. It is consistent and reproducible, and it has optimal implant positional installation, sizing, ligament balancing, enhancing the healthcare team outcomes. It also helps in enhancing healthcare team outcomes because it is characterized by decreased post-operative pain and requirement of analgesia. If you look at the various hospital data, the hospital discharge and functional recovery is very fast. Post-op day 2, the patients are going from my center. Accuracy is more, and we are getting a CT scan post-op to verify the accuracy. The soft tissue protection is very much. And of course, if we have everything in the right place, the knee revision indicators are going to go down. The important thing is that what do you expect if you want to have a surgery? The pain scores are definitely less when we are talking about robotics in joint replacement. I don't know why, but the pain scores are definitely less. Now, as told by Mr. Taneja, that technology adoption takes time. Yes, few are early adopters, some are late adopters, and some are laggards. But ultimately, everybody has to adopt, and most of the major centers have adopted in the major centers like Mayo Clinic, HHS, and everywhere. And the future is definitely going to be robotic, artificial intelligence, and things will progress every day. Now, there is a good point to understand that navigation and robotic, there is a difference. Navigation does not aid in the conduction of the surgery, but in the robot will help in execution of the surgery. Now, before I end, whatever be the technology, you should be able to choose lesser, less pain, less recovery time, and less blood loss. So why are then we still using traditional conventional techniques despite so much evidence? If you want to be if you are a patient, what would you choose? A 60 to 70% accuracy or more than 99% accuracy? And importantly, the most important thing is change is the law of nature, and it is already happening in some procedures. Telesurgery. Progress is inevitable and technology is here to stay. Only the form will change and become smaller with time. And nature's law, those who embrace the change will survive, those who don't will perish and retire. Any questions? Thank you.
Thank you, sir. Thank you for this wonderful talk. Many of us.
Sorry for the light, something went wrong.
What, sir?
I'm indeed very sorry, something went wrong from this side.
Oh, sir. Thank you, sir. Thank you.
Thank you.
Now I invite our next speaker, Dr. Rupa Mehta, Madam. She is an additional professor in the Department of ENT and Hair and Neck Surgery and a dynamic surgeon and educator. She will be delivering a talk on
tracing the evolution of robotics in medicine to its present applications. Ma'am, the task is all yours.
And a very good afternoon. The topic of my presentation is robotics in medicine, from science fiction to reality, and tracing the evolution of robotics from its initiation to its present scenario. Now, there's a very interesting article, The Hospital of Tomorrow in 10 Points. So it states many things, that the hospitals will be small, there'll be more super specialization, better care, pre, post-operative, end-of-life care, etc. But it states very nicely that robots will be more present and visible. And in all areas, all healthcare areas, right from nursing to rehabilitation to planning to surgery. But as we all understand, surgery is traditionally a hands-on affair. What we have been told is, like you palpate the tissue, you palpate the mass, and you decide your surgical strategy on the basis of that. So, but as we have been seeing since the morning, technology has revolutionized the face of surgery. We have laparoscopy, endoscopy, okay, and now robotics. But we have to maintain a very fine balance, because not everything can be subjected to instrumental rationality, which is, as Max Weber explained, a source of modern disillusionment. So we have to be very rational in deciding, neither be overly enthusiastic about the new technology and adopt it without understanding, and neither be overly, or excessive fear for the new technology. Both are bad. Alexander Pope has, aptly said, "Be not the first by whom the new are tried, nor yet the last to lay the old aside." So with that in mind, we have to understand that, like even right from the old Hindu Ayurveda text, it is said that surgeon's hand is the most important instrument. And Frerin, in his paper on prostatectomy, wrote that after the endoscopic and laparoscopic era, eye has been transferred to the tip of the laparoscopic instrument. So the haptic feedback, which they say, by palpating the tissue, is very, very important for carrying out the surgery. Now, robots, as we all know, have been used in industry from 1958. And they do all those repetitive hazardous tasks, and they are being used in, for manufacture of automobiles, for manufacturers of computers, for exploring the deep sea, working in hazardous environment. But their adoption in the medical field has been quite late, but it has come with the force. So from 1985, the robots started being used in medical field, and robotic telesurgical machines have performed transcontinental cholecystectomy, and there are other voice-activated robots and other robots which have been used. So if you draw the parallel between industrial robots and medical robots, you find that they almost had the same course before they were accepted publicly. Now, surgical robotics, as we all know, is an exciting and evolving field, and it seems to be the cutting-edge technology and the best technology, as said. But still, we have to remember that currently the robot is completely dependent on human control. The Da Vinci robot, which was told in the previous talks also, is the master-slave manipulator. So if you see the graph, from the freehand surgery to minimally invasive surgery, robotic-assisted surgery, and surgery with full automation will take, I think, decades, because that is has a lot of issues, which were told by Dr. Mahendra Bhandari sir also. So if we trace the history, the first surgical robot was in British Columbia University. It was in which they did hip arthroplasty, and then the Puma model was there, which was used for neurosurgical biopsy. But before that also, Leonardo da Vinci in 1495 made a model of a robot, which is still on display in Berlin Museum. So we have come a long way from 1495 to the present humongous machines, robotic machines. So this is just the timeline. Puma 560 needle was used for placing a needle for brain biopsy. Probot, Robodoc, Da Vinci robot, and then Da Vinci robot, multiple, like generations X, XI, S, SI, etc. So this is the Puma robot, which was used for taking brain biopsy. Now, as we all have been seeing, artificial intelligence or computer-aided surgery has many components, out of which robotics is just one of them. And the autonomy, the active, semi-active, and passive robots we've already seen in the previous presentations. So just to simplify, a surgical robot is a self-powered, computer-controlled device that can be programmed to aid in the positioning and manipulation of surgical instruments, enabling the surgeon to carry out more complex tasks. Master-slave manipulators. Now it has three parts we'll see. A surgeon's master console, where the surgeon sits and gets a three-dimensional view. This is different from the laparoscopic view. Laparoscopy or endoscopy will give you two-dimensional view. Here you get the three-dimensional view, first important thing. Second is immersive. The surgeon, when he sits in the console and sees, it appears to him as if he's doing the surgery. So it is tele-immersive and three-dimensional view. Then the master manipulators are there, joysticks are there, through which you can carry out the procedures which are translated to the robotic arms. And they do motion scaling and tremor filtering. So that is why the movements, robotic movements are precise. And a control panel to adjust other things. Then patient side, slave robotic manipulators are robotic arms that manipulate the surgical instruments and camera through laparoscopic ports. And as we said, the robot is tele-immersive. Haptic feedback is not there. It is tele-operative. You can operate from a remote site. Tele-presence, tele-mentoring. You can mentor the younger surgeons. The senior surgeon or the faculty member can mentor the younger surgeons remotely. Telestration, you can draw diagrams and show. So Isaac Asimov was a science fiction writer who popularized. Initially, the robot term was introduced by Karel Čapek in his play, and it meant forced labor. So the story was that first they introduced robots to help mankind, and then the robots rebel and they destroy the mankind. Then after that was how the robot term was introduced. But Isaac Asimov popularized the concept of robots in his science fiction books, and he conceived 3 laws to govern their behavior. First was a robot may not injure a human being. Second is a robot must obey orders given to it by humans. And third, it must protect its own existence as long as this does not conflict with first or second law. So same as Agarwal sir also mentioned in the morning, do no harm, prevent harm, and do good. So that is what is also reflected in this. So as we have all been seeing since the morning deliberations, that robotics have been used, artificial intelligence have been used in multiple healthcare sectors, right from pharmaceutics, clinical laboratory techniques, imaging, nursing and rehabilitative care. We have lectures lined up for you from physical medicine rehabilitation departments, urology, radical prostatectomy, partial nephrectomy, cystectomy, reconstructive procedures, adrenalectomy, etc. done. Gynecology, madam elaborated in detail. Then general surgery, colorectal surgery, endocrine surgery, bariatric surgery, cardiothoracic surgery, head and neck surgery, mostly used in oropharyngeal lesions because it is very difficult to reach there and you require huge incisions to be able to access that lesion. So mostly used in carcinoma, oropharynx, sleep surgery, and transaxillary thyroidectomies, then transoral robotic surgery is commonly used. So as we all know, robotic surgery, the advantages. It is ergonomic positioning for the surgeon. A surgeon who carries, out surgery for 6 to 8 hours, every one of us who have been operating will know that it causes a huge amount of, we don't realize during the surgery, but later you have back stiffness, you have joint pain, neck pain, etc. So it provides a very ergonomic position for the surgeon, sits comfortably in his chair and operates. 3D vision, in contrast to the endoscopic or laparoscopic surgery, which provides us a 2-dimensional vision, this provides us 3-dimensional vision, which is very important. Then filtered tremors, improved dexterity, 7 degrees of freedom are there. Less fatigue, the robot can carry out the same task repetitively over a period of time without getting fatigued, without getting bored, and allows performing complex tasks. Disadvantages, however, are lack of tactile feedback, can't change operating table position once arms are docked to the patient. Setting up time it requires a lot of time to set up, to make the setup. It requires a huge OT because the robotic system at present is very large, so it requires a huge OT to install and to do setup time. Then cost involved is very, very huge. That is one of the major drawbacks in making it less popular in the sense like less available. Then capital cost and the disposable cost, both. Maintenance is equally difficult. Disposable cost is also very high. But we all know it leads to smaller scars. If you have a sternotomy, huge scar, and in place of that you're having 2-3 small scars, so that definitely leads to shorter hospitalization time, less morbidity, lower risk of adverse effects, faster overall recovery time, less pain. Patient is happy because now the concept has changed. Initially, the doctor used to decide everything, the surgeon used to decide everything. Now it is more patient-centered. Patient has a lot of participation making choices. So less blood loss, quick return to normal activity. So in recent years, robotic surgery has become the most preferred method for many types of procedures. But we should understand, at the same time, someone has written, very fashionable. Robotics is a very fashionable stance. Do your prostate long distance, but if you want to save a life, trust a surgeon with a knife. So we have to keep the balance both ways. We have to understand that it is not a Me Too technology which can be used anywhere and everywhere. And despite the number of publications rising, every month you get a lot of publications, but still there's very less level 1 and 2 evidence to support its efficacy, like in all the areas. Now, apart from these, you require specialized instruments to be used. They are again costly, disposable, so that make the overall cost large. And this is the picture showing the degrees of freedom so that you can access all areas. So before we, decide that, yeah, it is a very good form of surgery or it should be adopted and should be done or such and such procedure should be done, there are with robots, there are certain points note. Are we doing this just because it could be done or it really has an advantage over the existing procedures? That needs to be clearly defined. Second, is it really advantageous to our patients? What are the costs involved? Because at present we realize, it is not covered by government, most of the patients, and our patients cannot afford such higher payments for the surgery. So that has to be understood. Can we afford it on a general scale? What are the professional and social implications? How may it change the education and structure of our profession? Having said this here, it will be also a big help for making for simulation and all. That will help in training definitely. But still, it will affect if we adopt it, then we have to make certain changes in our education and structure. Then what can robotic surgery offer that other simpler and less expensive techniques cannot? We have to define the specific disease procedure, the specific indications where it has the potential of optimizing results better than the other modalities. Should it be used for only niche areas or as one method for all surgeries? These all things have to be very clear before we go ahead with the saying that this is robotic surgery is the best for, modality for this particular disease. I have time, yeah. So to conclude, a robot is only as good as its operator. Future of robotics in surgery is limited only by imagination. No one knew that robotics will be, it was just a science fiction, it started as a science fiction concept in a play, then in certain books by Isaac Asimov, and now it has been used. So no one would have even imagined during that time. So even now we cannot imagine what all uses it can be put. At present we have huge robots like Da Vinci and all, but now the things are moving towards smaller nano robots, and there are multiple small robots, capsule robots, and which can be put in the and go into the specific area, which can be introduced inside the body and go into specific areas. There is leproendoscopic single port surgery, natural orifice transluminal endoscopic surgery, etc. So time will only tell whether there'll be a time where there'll be a robot in every operating room. The sole consideration of surgery is benefit of surgery in all disease processes, to all patients and in all places. It remains to be seen, however, if history will look on the development of robotic surgery as a profound paradigm shift or as a bump in the road on the way to something even more important. So thanks for patient hearing. Before I conclude, I would like to quote Martin Luther King Jr. Of all forms of inequality, discrimination and injustice in healthcare is the most shocking and inhuman. So we have to understand this, and this is both pros and cons. Once, if it is widely adopted, it will help in delivering tele surgery and tele medicine, so that would be even better. It will reduce inequality, but at present, because of its high cost, it is aggravating the inequality in healthcare. And no technology is good or bad, as ex-Intel President Andrew Stephen Grove said. Technology occurs. It is not good. It is not bad. The steel is good or bad. So everything has its pros and cons. We have to be skeptical and rational in utilizing it. My special thanks to Professor Dr. Nitin Nagarkar sir, Director sir, and Professor Dr. Alok C. Agarwal sir and team for conducting this very nice event. Thank you so much.
Thank you, ma'am, for taking us through this amazing journey of the evolution of the robotic surgery. Now I call upon Manisha madam to present a memento to ma'am.
My pleasure to give this token of appreciation, this hardworking lady, wonderful in person.
Thank you. I'd like to request Professor Alok Agarwal sir to kindly present memento to our chairpersons.
So Dr. Manisha Sin has brought the concept of hard-working women, hard-working men, and the whole team is hard-working, and it is ready now to get the mementos. So for the next session, may I call Dr. Sarita Ramchandani, Professor Dr. Amit Chauhan, and Dr. Prakash Gupta, Civil Surgeon from District Raipur. As our first speaker, Professor Dr. Sanjay Vadhva from AIIMS Raipur has had some death in the family. He is not able to speak today. His Chachaji expired today only, and we have our whole condolences for him. So there will be only two speakers in this session, Dr. Anil Sharma and Dr. Vandita Singh. Thank you.
Dr. Gupta, Civil Surgeon Raipur, Orthopaedic Surgeon.
Good evening, all. My congratulations to Alok sir and whole team for organizing this wonderful conference. I will be speaking on the scope of artificial intelligence in neurosurgery. So what we call artificial intelligence has already begun to permeate in our home, our work environment, right from consumer services to navigating our travel routes. And artificial intelligence, I would like to, it's not artificial, it's natural extension and byproduct of human intelligence. So in artificial intelligence, A should denote assisting, amplifying, and augmenting of human intelligence. Neurosurgery has always been being the most complex discipline in medicine. Neurosurgery has always been relying on cutting-edge technology. And neuroscience always embrace cutting-edge technology and technological advancement. So question is not, it's not about artificial intelligence if, it's about how. And matter is now to start. So these are various subdomain of artificial intelligence. Artificial intelligence is a technique which enables machine to mimic human behavior. Machine learning is important subset of artificial intelligence, which is nothing but computer science, which use statistical methods to enable machine to improve with experience. And another subset is deep learning, which is again subset of machine learning, which makes the computation of multi-layer neural networks feasible. So this is roadmap and schematic representation of domain and subdomain of artificial intelligence, right from clinical data representation to natural language processing and utilizing artificial intelligence as a tool, machine learning, and then clinical diagnosis and clinical judgment. So these are just schematic representation and various subdomain. So data is the most important tool for artificial intelligence, with which only we can make algorithm, we can behavioral watch, by behavioral watch we can track our history. So it's not about man versus machine. Artificial intelligence can never replace an empathetic physician.
It's man plus machine. It's a symbiotic relationship, and both should complement each other by making human abilities. So one size does not fit all. So approaches towards personalized medicine. So where artificial intelligence is being used in medicine, it has been discussed earlier. Like in radiology, we have seen robotic surgery, histopathology, endoscopy, and cardiac monitoring, among others. So this is just a schematic representation how raw data is converted into algorithm and clinical judgment and applications. So application of artificial intelligence in neurosurgery. So artificial intelligence, by utilizing artificial neural network, we can prognosticate, we can predict outcome following head injury. We can predict trends of intracranial pressure. It has been utilized in decision making. By making automation, we can use in preoperative planning and outcome prediction. By using various algorithm, we can automatically segment tumors. We can localize epileptogenic focus. We can calculate vasospasm risk following subarachnoid hemorrhage after aneurysmal rupture. We can predict tissue damage and treatment effect from stroke and select optimal candidate for pediatric epilepsy surgery. By automation and by algorithm, we can also predict survival in neuro-oncology and trauma cases. So it has been utilized in surgical adjuncts. As we know, before late 20th century, there were not many tools available to intraoperatively visualize brain. And later, ultrasound, computed tomography, and magnetic resonance image came into picture. And now we have image guidance, navigation, stereotaxy. So hardly you will find a neurosurgeon, though these are not related to actual performance of surgery, but hardly you will find a neurosurgeon who is not deploying and employing these surgical adjuncts. So these adjuncts may also benefit from automation and introduction of operating microscope, which is capable of semi-automated positioning, which is a very useful artificial intelligence tool. It may benefit image guidance adjuncts utilizing either preoperative or intraoperatively acquired imaging data to aid in operative trajectory planning. And other potential use of automation and include that alert surgeon when critical structures such as blood vessel or eloquent areas are being operated upon. It can be utilized to maximize the accuracy of intervention while minimizing potential for collateral neurovascular damage and post-operative deficits by avoiding damage to critical neurovascular structures. So surgical robots, as it has been discussed, there are certain key advantages of surgical robots, including from dexterity and tremors and all. So NeuroMate was the first FDA-approved surgical robot, which was developed by University of California. Later, telesurgical robot, which works on master slave principle, NeuroArm, it came into picture. And it was developed by University of Calgary, and it has been utilized over thousands of procedures, including stereotactic biopsies, hematoma evacuation, and electrode placement has been done. And ROJA is a surgical control system, which had been utilized and in electrode placement and stereotactic biopsies. And there are various spinal robots available nowadays, which can help in preoperative planning and guide operative trajectories for pedicle screw placement. Adjuncts also available for endoscope, as compared to conventional holder, robotic scope can be used to hold, which will free surgeon's hand. And more importantly, it will mark out safety area, which will stop and prevent surgeon from accidentally injuring critical neurovascular structures, which is particularly beneficial when we are operating in neurosurgery from narrow corridor. Neurotrauma, we can predict recurrence of chronic subdural hematoma by using various algorithms and prediction of craniocervical injuries. In spine surgery, there are various robots available where we can plan trajectory, we can put pedicle screws, and virtual reality surgeries can be performed. in functional neurosurgery, 1 year outcome after deep brain stimulation in Parkinson's disease, 86% of motor improvement and 100% of tremor outcome and 93% of speech outcome has been published in literature. So robotic guided electrodes are being placed in deep brain stimulation. In functional neurosurgery, outcome of epilepsy surgery has been defined, and by using a scalp electroencephalogram, automatic detection of seizure, that also can be done. In neuro-oncology, algorithm has been used for functional localization of displaced regions, for tumor classification and grading on imaging, which is more than 90% correct, which is far better than any experienced senior neuroradiologist can do. And it can prognosticate of malignant gliomas. All algorithms are available for that. And neuro-rehabilitation, by using brain-computer interface for severely disabled patient, they can hear and they can see with one brain. This is very useful for people who are severely disabled and suffering from motor diseases. So these are advantages and disadvantages of various decision-making and treatment and diagnostic and operative adjuncts. And diagnostic advantages, faster interpretation and potentially more sensitive and specific than humans. And it can analyze minute trends. In decision-making, it's more accurate decisions. It's quantitative rather than gut feeling decisions, and multi-stream information. And non-interventional treatment, it enables precise medications and automatic warning of interaction and doing errors. And operative adjuncts, it provides more precise guidance and more complete pathology removal and more precise anatomical and pathological visualization. Robotics is already in place, and for spine, robotics is already being used extensively. It leads to faster performance and fewer surgical error and fewer complications. So these are machine learning model versus clinicians. Machine learning model utilize various subdomains like artificial neural network, support vector machines, decision tree, fuzzy C-means, deep learning, linear regression, and clinicians are multidisciplinary involvement. So it has been found that artificial intelligence actually outperformed clinicians in diagnosis of posterior fossa tumors in children by classification of tumors into and grading by using various algorithms, and differentiate low and high grade gliomas, detection of surgical site infection, and classification of epilepsy, and prediction of CT abnormalities, and predicting outcome in pediatric traumatic brain injury, and lesion detection in undefined patient, and glioma survival prediction. So much has been talked about advantages and hype of artificial intelligence, but literature is very scarce about potential risk of increasing automation. One is non-surgical error. Individual medical mishap will lead to damage to only 1%. It will cause error to only 1%. But error in automation, error in algorithms can cause widespread error. Surgical error, that is another question. Physician de-skilling. This is one important aspect which we usually forget to discuss. Physician de-skilling is very important. And when technology is deficient or not functioning, physicians are rendered ineffective. And it may negatively affect their clinical judgment. Unproven efficacy, literature is still in a nascent stage, is still evolving. Contextualization is another important aspect because it may not take multiple aspects into picture. Data overfitting. So, however, artificial intelligence can never outperform clinician in empathy and the human touch. So, in nutshell, artificial intelligence, like every coin has two sides, good and evil. So, artificial intelligence, time only will tell whether it will be a bane or it will be a boon. And it can never replace an empathizing clinician. And more important thing is, It's here to stay. We have to embrace the technology. Thank you.
Hello. So thanks, Dr. Sharma, for your enlightening talk on AI used in neurosurgery. But I still say to start with computers, with robotic surgery, and then this use of AI. Humans have to plan, and they have to plan complex data algorithms, and where the AI will be used to control the machines with human brain. Thank you very much.
Very well presented by you, Dr. Anil Sharma. As well, aptly said by you, artificial intelligence is nothing like a man versus machine. It has to be like man with machine. So we have to learn the technology and incorporate it in our day-to-day practice. Thanks for your presentation. I would ask Amit Chauhan sir to present a memento to Anil Sharma sir. Now I would like to invite Dr. Vandita Singh, Associate Professor, Department of Pathology, AIIMS, to deliberate her talk on artificial intelligence in pathology. Over to you, ma'am.
Very good afternoon to all my honorable colleagues, seniors, and all the participants. And I thank the organizers for giving me an opportunity to speak on, to give a brief introduction to artificial intelligence in pathology. As everybody knows, pathology is a very visual branch, and there's a lot of image analysis and pattern analysis that we usually do. So the learning objectives for my talk would be to introduce the concept of artificial intelligence in pathology and its current status, to know its applications and effect on workflow efficiency in a pathology lab, to understand the factors that influence its adoption or acceptability, what are the regulatory processes that govern it, and how does the government of India support us, and what is the research being done in India. So the current routine applications of AI in pathology laboratories is that AI is nothing new to pathology. It has been used for the last 20 years in different forms. For example, as automated tissue processing, staining, generation of synoptic reports on laboratory information systems. However, in the last 10 years, what has changed is the advent of digitalized whole slide image technology, which has increased the use of digital pathology, which is now becoming more commonplace. There are a lot of options for whole slide scanners in the market, and they are all very good. So what is this image analysis? We are all used to Google Images, and you can take a picture on your mobile and upload it on Google Images, and Google comes up with some introduction about some information about the image. So can we do that in pathology? Take a microscopic image, put it on Google Images, and come up with a diagnosis? Possibly. Is this the future of pathology diagnosis? Maybe. But how and why? Pathology is a very pattern-based approach to diagnosis, especially in histopathology and cytology. What is this pattern-based approach? For example, on Amazon, you select a kurta and it gives you a prompt for all the similar-looking kurtas that are available in the market. So we can do it in histopathological images as well. You have a pattern, and the system or the software or the PATH AI system will come up with all the differentials which look like that, have a similar pattern. But it may be a little more complicated because the slides have not read the books and the slides do not know about convolutional neural networks. So the software can identify a cell, but it still needs input of a pathologist for classification and a proper algorithm to be really useful. For example, suppose for those who are not pathologists, to make it easy for them, You can have a image, pathology image, which is broken down into 6 grids. And so what the digital slide scanner would do is simply to create an image or a collage. What a pathology AI system would do is to break up each of these grid into categories to classify them as cat versus non-cat in this collage, for example. And for that, so you need a whole slide scanner and you need a path AI system which tells you which part of the grids are cat and which parts of the grid are not cat. However, this objective cannot be set by the computer, and it is still the human's job to identify what parameters define what areas of the grid. So this combination of a slide scanned image with an intelligent path AI system is what is called as computational pathology. Computational pathology is image-based diagnostic, prognostic, and predictive algorithms which incorporate not only the histopathological image, but also its clinical data, genomics, and proteomics, and come up with a most informed diagnosis. And how do they do that? By using different AI algorithms. For image analysis, the algorithm which is commonly used is a convolutional neural network, or CNN. What is this convolutional neural network? Like I said initially, you take up a whole slide image, you break it down into a lot of grids, and each grid will have its own data generated depending on the parameters being measured. And then they will be intelligently computed with the help of an intelligent pathologist to come up with a classification and also an uncertainty measure. But as you can see from this picture, you do require a pathologist right from the start to the end. So how does this AI really help if you still need a pathologist? It automates the whole process, making the screening time shorter and improves the turnaround time for the entire diagnosis to come up, and therefore it is useful. So the 3 important components for an AI pathology report would be a slide scanner, followed by an intelligent path AI system, and then good amount of information in the form of data, clinical details, ancillary test results, prognostic data, and predictive data. So the AI system is only as intelligent as a pathologist and only as good as the data which has been fed into it. So how is a traditional image analysis, which is usually done in a slide scanner, different from an intelligent, deep learning powered computational pathology? In traditional image analysis, the tasks are, in a traditional image analysis, for example, a breast carcinoma. What the system would do is basically make it easy to count the number of cells, count the number of mitosis, score the intensity stain. But what an intelligent system would do is to collate this data with patient's metadata in the form of clinical history or treatment response, and then come up with information which is useful. So the advantages of this intelligent system is that it helps in improving concordance between pathologists. As we know, pathology in a lot of aspects is subjective, so inter-observer variation can be minimized. It helps improving our screening times and therefore improving our turnaround times, so that the pathologist is freer to focus on challenging areas and foci which look different. This can also help us in allocation of resources better and therefore improving cost-effectiveness. So what are the examples of uses of computational pathology? So no organ system is immune to this. Right from gliomas to the prostate, there has been research on this everywhere. But the 2 important areas are predicting cancer outcomes from histology and genomics. That is, I give you a diagnosis of glioma grade 3, and the computer associates that with genomic data, which comes from another lab, and predicts survival for a particular group of patients. Similarly, in the prostate, the Gleason's grading for prostate cancer can be completely automated. However, the system still needs a pathologist, so a pathologist-centric pathology AI system is the way to go ahead. But this system is not without its limitations. As you can see, the same breast carcinoma can look different on 2 different slides. The same squamous cell carcinoma can look different depending on its grades. So there are these inherent limitations which can be overcome as long as the input data increases and there is more validation of the system, which needs to be supervised by an intelligent pathologist. Of course, it's better said than done. For example, as you can see in this image, Google always comes up with this CAPTCHA to identify the buses, which is easy in this one. However, here it says identify the cars in this collage, and there's only one which shows a car. So So the software can always have a glitch because the tumors are not robots, neither are we. And therefore, the system needs constant input and feedback to update it and keep on improving its training modules. So the applications for AI in pathology can be in research. They can also be in routine pathology clinical practice, and they are governed by regulatory issues and have their own challenges and opportunities. So the major applications are in the area of improving workflow and diagnostic applications, also in prognostic and predictive applications, integration of data with radiology and genomics, and educational applications. How does it improve workflow? It decreases the screening time, it improves the quality, prioritizes the workflow to focus areas, and makes the pathology service more efficient, cost effective, time saving, and increases accuracy. So the future objectives for AI in pathology are therefore that you integrate all of these 4 different applications and come up with new classification tumors for pathology images, combining pathology diagnosis with prognostic data and massive, radiology images, etc. This might improve efficiency of a pathologist workflow, and it can help in training training the pathologist as well as improving reporting system for the pathologists. So how do we apply AI in pathology? Can it be in silo in a pathology laboratory? No. We need a multidisciplinary approach in which all stakeholders, including the patient as well as the clinicians, are involved. And the clinical utility of these imaging software needs to be looked at. So we are not just looking at analytical performance of image analysis, but its real utility at the bedside. Algorithms for each organ system have to be defined, and this has to be led or delineated by pathologists. And you need to validate the data on large cohorts, which in pathology, most of the cohorts are retrospective. So when we have all of this together, only then you can apply it properly in clinical practice. So what are the regulatory issues? Abroad, because this has been in the making for several years, College of American Pathologists, FDA and EMA look at evaluating the performance of image-based AI algorithms, and they insist on applying the right level of evidence for the appropriate context. The context can only be given by a pathologist. All of these AI diagnostic tools have to be validated in the laboratory before they are set out in the market. Right now, they are only on research basis. And all legal considerations favor assisted or augmented artificial intelligence versus automated use. That is, they insist that a human factor still be there in using this AI technology. In India, regulation is in the pipeline and hopefully will come soon. The government of India supports all endeavors incorporating AI in the health sector, and the private sector has lapped up these options. So a lot of private labs already have collaborations with Google and Microsoft and are using this technology. As far as research on AI in pathology goes in India, only the major institutes like PGI or RNR at Delhi have used this, who have whole slide scanners and path AI systems and the capacity and facility for cloud computing, who are doing this. The limitation basically is the cost of whole slide scanners, path AI systems, and the amount of cloud storage that is needed. There is always resistance and suspicion of new technology, and therefore new local training modules need to be started, and the data that is taken from different regions needs to be validated in order to really accept it. So the challenges and opportunities are that acceptability of AI in pathology is slower than expected, comparing it with radiology, where it is a norm nowadays. That is because of the black box nature of AI itself. Because nobody really understands the algorithms of CNN and how they work. So also the value added by development of these algorithms needs to be balanced with the cost and disruption in a pathology workflow, and it should be applied in areas of most need. Also, different versions of laboratory information systems and HIS exist, and they are not compatible with each other because of proprietary issues which needs to be taken care of. And we always need high-class IT infrastructure, large amount of data storage costs, which has to be provided. So to conclude, computational pathology usage is absolutely going to increase in the coming days because of the need for evidence-based precision medicine. Artificial intelligence does improve and streamline the life cycle in pathology labs and gives rise to more accurate diagnoses. Acknowledging its limitations and challenges is important so that we can improve the system. And the concept of augmented intelligence should be adapted versus just artificial intelligence with human input in the form of pathologists, clinicians, and patients. We must guard against the human resource toll of AI. That is, people do become de-skilled. If the screening is done by the machine, the pathologist will probably lose the ability to screen a slide well. But we must reassure the users who are skeptical that AI can complement human resources but will never be able to replace it. I thank the organizers for giving me this opportunity to speak on this topic. Thank you so much.
That was an excellent presentation, Dr. Vandita. I think in histopathology especially, it is an image-based diagnosis, as you told. And for the whole slide scanner and the artificial intelligence machine, whenever it is prepared, I think I remember the earlier talk by Dr. Bhode, sir, when sir told about one story that in US, the researchers, they come up with an artificial intelligence model where they try to differentiate the simple tank from camouflaged tanks, that is tanks hidden behind trees. And they checked it and they found that it is able to diagnose 100%, differentiate between the two. They presented it to the US Army. After checking, the Army rejected it. They told it is not able to diagnose. So after analyzing, they found that actually the artificial intelligence machine is diagnosing the simple tank because it was taken in a bright light day. And the camouflage tank, it is identifying because it was taken in a dark light. So I think while preparing artificial intelligence machine in pathology, we also, or the researchers should also keep in mind the confounding factors. That is, whether the stain is very bright or there is slightly stained, what about the sections, thickness, all those things should be taken care of. Okay, thank you. Thank you very much.
I agree with you, sir. The whole concept with any software is garbage in, garbage out. If your data is not, if you have not defined the parameters, you won't get a good answer. And but the usefulness is that the more data you have, the system becomes better. So we should not be suspicious of the technology, but we must work with it to improve it.
Yeah. Okay. Thank you. Now I request Dr. Sarita Ramchandani to present memento to Dr. Vandita.
Thank you. I'd like to request Professor Alok Agrawal, sir, to kindly present memento to our chairpersons. Thank you. For the next session, I'd like to request Dr. Ekta Khandelwal ma'am, Dr. Harshal sir, and Dr. Amritava Ghosh sir to please chair the session.
Very good evening to all of you. To start with this session, the first talk of this session is by Professor Dr. Satyendra Fulchale sir. He is Professor and Head of the Department of FITI JNM Medical College, Raipur. Welcome you, sir. Sir will be sharing his experience of navigation in joint replacement in spine surgery. Thank you, sir.
Thank you, Dr. Harshal. Good afternoon, everyone. Respected seniors and dear colleagues. Respected Dr. Nagarkar sir, Director AIIMS, Dr. Dhaneria sir, Dean Medical College, AIIMS. First of all, I am thankful to organizing team of this grand successful CME in artificial intelligence in AIIMS, particularly to Dr. Professor Alok Agarwal, HOD Ortho, Dr. Bikramkar, Dr. Harshal, and the whole team of AIIMS, Raipur. It is a very informative and new gesture in medical science and in orthopedic. So to discuss and share my experience in computer-assisted orthopedic surgery chaos. That is the role of navigation in spine trauma and major traumas and joint replacement surgery. So to start, this is the photograph of our medical college and the hospital building. So spine injury are reported to occur in approximately 6% of all trauma patients. 65% occur due to the fall from the height, road traffic accident, and the thoracolumbar injury are the most common, around 90% of all the vertebral fractures. So what is a navigation? It is an information used to determine the precision and course of an object. If this is the pelvis bone object, it determines the course of it. And how it works? It utilizing the tracking system and programmed software to provide a map of the operative field. Two major modalities, CT-based navigation, computer-aided navigation, as discussed earlier with the Dr. Anup Singh from Patna regarding the navigation in and robotic surgery in total joint arthroplasty. The CT-based navigation, this method involves a pre-operative CT scan and registration step to relate 3D virtual modalities to actual modalities in the operation table. There are certain instruments or tools which help for the navigation. These are the reference array, T geometry, and these are the, we can say, spherical or opticals. It works on the principle of infrared camera, and this is a bony instrument, Sange screw, a few others, bone fixators, and these are the probe. The probe are having this optical spheres read by the infrared of the navigation system, and this is the painless femur array system with screw. So multiple tools and instruments are used for concising the, and out of this, the important is this is the infrared camera. This infrared reads over the spherical opticals and give the image in the screen. So silent picture of virtual fluoroscopy displays the predict the position of the surgical instruments and the implant relative to store the images. So this photograph showing the what we have inserted before, the Sange screw in this. So the silent feature, the image can be readily updated after fitting an optical tracking arrays to both C-arm and the patient. It allows the tracking to the bone and fats. So this is the first we have to take a CT scan of the spine of the patient, and then we have to download in the monitor of the navigation. That is the navigation in our setup in Medical College Raipur we have from the brain lab. And while doing the surgery, we have to pass a screw from this part of the spine. This part of the spine, we have to part a screw from this part of the spine that is named as a pedicle. So it is a very important, it should go in the center of the pedicle and it should not injure the nerve roots and the vessel. So the navigation's imaging gives the idea, direction to the surgeon that you are going in the right way. Like this photograph showing. And so again, continuing the silent feature, calibration, target and the software packages are used to wrap each X-rays images to render them optically correct. So we have to register them and see for the when we are doing a joint replacement surgery, it shows the model of the iliac bone and we have to wrap it. So continuing the silent feature, after storing the image, the real-time image of the surgical instrument can be overlaid on the storage images. So advantage of computer assisted orthopedic surgery is computer navigation joint replacement allow for the higher precision than what is possible using just a classical manual technique. Implants are aligned better and the reconstructed are lasting longer. Minimal invasive approaches are sparing soft tissue facilitation, faster recovery and shorter hospital stay. Combined together, computer assisted orthopedic surgery and minimal invasive surgery are making the patient and their surgeons happy. So these are the third literatures, review of literature from the review of literature for the role of the navigation in the skeletal trauma. J. Spielberger et al. Says that the computer tomography assessment of pedicle screw placement in lumbar and sacral spine. They published the literature in the Euro Spine Journal in 2018. Suresh Patil from India et al. Say pedicle screw placement with the O arm and the Seatal navigation in orthopedic, online publication in 2012. So there are the certain studies which advocate the navigation system for the pedicle screw placement. Before the navigation system, we have to put the pedicle screw under the image intensifier or in C-arm. That means, to simplify, it is a virtual X-ray which guide the surgeon to pass it. So this is there are certain studies, and this is the important study from the randomized clinical study to compare the accuracy of the navigated and non-navigated thoracic pedicle screw in deformity correction from the Ganga Hospital, Coimbatore. Dr. Raj Shekaran is a legend orthopedic surgeon from India. And they conclude that and the other study published in the Indian Journal of Orthopaedic, again from the Coimbatore Ganga Hospital by Dr. Ashish Jaiswal, Ajay P. Sethi and Dr. etc. They conclude that navigation is a useful adjuvant during stabilizing the challenging spinal trauma, rendering feasibility, accuracy and safety of pedicle screw placement in difficult situations. So there are internationally, worldwide, there are the various studies for the spine trauma. And so while putting a screw inside the pedicle, it should not go outside the pedicle. So there is a classification given by the Lurch and Wisner classification for the malplacement of the pedicle screw. Malplacement, that the screw should be placed in the central position. However, if it got malls, so they classify it as encroachment when the pedicle screw could not be visualized, minor penetration when the screw was less than 3 millimeter out of the pedicular boundaries, moderate penetration, the screw trajectory was 3 to 6 millimeter outside the pedicular boundaries, and the severe penetration, that the screw trajectory was more than 6 millimeter outside the pedicle boundaries. That means there is a chances of causing an injury to the nerve roots or the vessels. There are studies showing from accuracy from the pedicle screw, various studies. And this is the one of the photographs showing if the screw is of larger size, it may causes the injury to the aorta or the inferior vena cava. In this slide, this screw is, actually this screw should pass through the pedicle. It is going through the pedicle, but it is a larger size, it may causes the injury to the aorta or the inferior vena cava. So for that, it should not cause an injury to the important soft tissue and should remain in its position. There should be an accurate placement of the screw. And this is the showing that hairy classification, there should be a no breach. A grade 2 is a lateral breach. Grade 3 is a lateral or anterior breach to the TP screw. Or 4 is the medial or inferior breach. Or 5th is a breach that requires revision. That means revision means if the screw is placed in the mal position, then we have to remove the screw and put the second screw. That is the revision. So there are certain example of our cases we are operating. The case number 1 for spinal tumor causing the fracture of the D12 vertebra. The X-ray showing the fracture of the D12 vertebra. Here the D12 vertebra is compressed. And this is another lateral view. And this is the view when we take the CT scan of the same injured patient and download in the monitor of the brain lobe navigation system. It's coincide with the vertebra in the monitor, and it gives the idea we have to pass a guide to the surgeon that you have to pass the screw in this pedicle, right? Not outside the pedicle. So these are some of the images we are having in the monitor of the computer of the brain lab. And another various guidelines are there in this all photograph, and this is the spherical circular that should, when it is going in the center of the pedicle, it should be a bull's eye like, total circular. And if it is not total circular and that means going the idea that is not inside the pedicle. So the other operative photograph when we are after closing, doing the closure, this is a pedicle screw inside in the vertebral body, and this is the X-ray APU, and this is the operative photograph, and this what I've said is the array. This spherical is read by the infrared camera and gives the idea to the surgeon forming an image. And these are the CT scan pictures showing the screw is in pedicle. Another picture that the pedicle are going in the converge way. And these are the various photographs we have. And one of the photograph I have, this is the X-ray, AP lateral X-ray that's showing it. After passing through the pedicle, the fracture spine has been stabilized. And these are the 3D CT scan after doing the surgery. These are the 3D CT scan. And this is the clinical photograph of the patient. This is the incision mark. We started the early physiotherapy, early mobilization of the nearby joint, early physiotherapy, and the patient make the patient to walk with the parallel bar exercises. This is the second case of the spine fracture, AP and lateral view. This is a CT scan picture, MRI picture showing the compression of the spinal cord, and this is the 3D CT scan before navigation system and the operative photograph. And this, what I mean to say that the navigation gives the idea to the surgeon that you should be go central in between pedicle, not outside the pedicle. So it gives the idea, it's showing the surgeon that it should be a bull's eye, not irregular. This is a certain CT scan photograph showing the screw is well placed. And we are discussing the navigation system. These are the certain conventional method. Without using the navigation system, there is a chances that the screw may go outside the pedicle. It causes the injury to the nerve roots or the vessels. So this is again the same photograph is showing the bullseye, the AP and lateral view. The AP and lateral view again the 3D CT scan. This photograph of the second patient, we have started the early mobilization of the joint and early weight bearing. So to conclude, computer navigation method exhibit the higher accuracy in pedicle screw placement and reduce the pedicle perforation as compared to the conventional method. Computer navigation method require less revision surgery with no radiation exposure to the patient, doctor and OT staff than the conventional method. Before that navigation system, there may be chances of the radiation hazard to the operating surgeon, his team, and all the OT staffs. Role of navigation in acetabular fracture. This is an X-ray of the pelvis showing a fracture of the dislocation of the hip joint and the fracture of the acetabulum. This is the operative steps. And this is one of the photograph that I am operating on the patient. This is me, and this is me, and this is my ex-professor, late Professor Dr. Dao sir. In the visible in this photograph, and this is again the navigation gives the idea that you are fixing a acetabular screw. While fixing the acetabulum, there may be chances one of the screw may go inside the hip joint. That means if the screw may go inside the hip joint, it causes the difficulty in reduction of the acetabulum. And so it is better to use the navigation system that this gives the direction and depth of the screw to the guide to the surgeon. And this photograph is after fixation by the double plate. We fix the acetabulum by the double plating. There's some photographs. This is again a photograph of navigation. Same. So screw navigation and acetabulum indicating the direction and depth of the screw in the bone. These are the X-ray photographs showing the double plating by the fixing the acetabular wall. So the take-home message, computer navigation method having a slightly more operating time than the conventional method, but it requires a learning curve for the computer navigation technique is high as compared to the conventional freehand technique. It required a need further more training to get more better result. Thanks.
Thank you very much, sir, for sharing your expertise and knowledge on navigation in joint replacement and spine surgery in a very concise and precise manner. The house is open for any question. Okay.
Thank you very much, sir, for your such a nice presentation. Now it's a time for a token of remembrance. Now may I request Dr. Amrita Ghosh to present token of appreciation to us, sir. So can we have you over here?
Coming up next, we have a very interesting topic, artificial intelligence in India. And to deliver the talk, I have the pleasure of welcoming Professor Sumit Gupta, who is head of Center for Digital Economy at IIM Raipur. Over to Professor Sumit Gupta.
Thank you, sir. I hope you are able to hear me and also see the presentation. I'm thankful to Professor Agrawal for inviting me for this presentation. In fact, after seeing the presentation from great experts at AIIMS, I'm feeling that I actually know nothing. And also, it's a difficult journey for me to put these next 15 minutes. So I will just share and what I was thinking, because although we can share a lot of things which are happening in India and so on, I thought that why not what we share our own research which we are doing on AI. So it's not actually, we are management researchers, so we don't actually do a lot of technical research. So my presentation will also be quite tuned to that. So one is that we consider AI as one of the disruptive technology, and whenever a disruptive technology comes, it causes a lot of fear among users. And that's that same thing. It's making one of the feelings we have is actually, although many things could have been done earlier very easily, now with the halo technology, like many of you have presented, it makes it more accurate, but then it also makes our life a little miserable, right? So businesses are fearful of losing out to competition, and as they must do something of AI. And that's what happens whenever a new technology comes in, that businesses try to, how do we stay in business, for example? And I was just talking to one of my friends who is in solar, and he was telling that AI, the work which they used to do, the design work, is now all taken off.
Sir, your voice is not very clear. Can you keep the mic a little bit close?
Yeah, 1 second. So let me. Okay, I don't have the. Yeah, 1 second. So, are you able to hear me now?
Sir, it is better. Thank you so much.
Right, thank you. Okay. So one is that these businesses are fearful of losing out to competition, and therefore they must do something of AI. So we actually do a lot of research in business, and not so much into technical fields. And that's what I was sharing. So what do business do, and how do they formulate their business strategies? And one of the ways is that they form consortiums to identify a common path. And that's the same thing which is happening in blockchain. Nobody knows what is going to happen, but and everybody is fearful. And individuals, if you ask people how to use AI, they say AI, and it's sort of a buzzword. And for us, like teachers, we have to learn to teach it, right? So this makes somewhat fearful. So that's what we feel. And here is a Gartner's hype curve. I guess you all know. The technology actually generally takes this trajectory. And initially, there is a lot of hype about technology, and people feel that it can do a lot. And that is what has created fear when people talk about AI. Will it take our jobs? Will it take away our bread and butter? And or will it remove machines? Will we be rendered useless? Even, for example, online teaching and so on coming, people are feeling whether we'll be there in teaching profession, or whether teaching pro education will take a turn, or something like that. And we have examined this technology to some detail in terms of management issues. And although there is a lot of hype which is created, ultimately a decision can only be made by human. AI can support decision making, but it cannot take decisions. And for example, even in doctorate profession and so on, when you compare several images of any disease,
ultimately the doctor has to take a decision. Or we remember when you used to go for eye checkup earlier, some 10, 20 years back, and computerized machines came into the market. We would, of course, get our eye tested by computer, but we'll have faith in the doctor, not so much on computers. So it's a parallel game which is created. Now also, AI may give us some results and it will tell, okay, this is the disease and so on. But the faith is more in the doctor rather than in the AI. So it's there are trust issues, faith issues, and all those issues. So what we actually are looking at in our research is what are the issues in adoption of AI by companies, by individuals, by businesses, and what are some of the ethical concerns raised by AI. So we are trying to come up with a framework which companies can use in implementing AI in their organizations. Okay, and it will take some time as we go through it. Probably next 2-3 years, 4 years, we'll probably be coming out with a AI kind of framework. It's a compatibility framework by which companies can use for identifying at what level they are in their businesses and at what level in their AI adoption and what they need to do further. Okay, so here what we did, in our preliminary research, we examined some 20 organizations. We did these are diverse organizations all over the world. So there are IT services, 10 organizations, then computers to healthcare services to technology to telecommunications, then finance and health and insurance, transportation. So these all total 20 organizations. We interviewed people from these organizations, the top level, the management level, that implemented AI, and we asked them about their journey, AI implementation journey. And what we found out is that these companies, they are actually doing image processing and natural language processing capabilities of AI to automate their processes and decision making. Some decisions you can automate, you cannot automate everything. Ultimately, key decisions rest on the primary decision maker. So in that sense, you may remove some of the people from the organizations who are taking those routine decisions, but you may not be able to remove people who actually take decisions which require, which AI cannot automate. Which, I mean, we all know that AI has some level of depth, but it cannot actually take all the decisions. There are subtle decisions in life which in any businesses which AI cannot take. Then there is another challenge which many organizations face, and I'll come to that in a few minutes. The lack of data, poor data quality is the primary challenge. And I think in one of the presentations, one of the faculty member spoke about that if you have improper data, garbage in, garbage out, then naturally, whatever you will get from AI will be improper, incorrect. And that's what is happening with many AI bots. Amazon has its own chatbot. And when we go to the chatbot, we try to present that this is our problem, but then ultimately we want to talk to a person behind rather than the chatbot itself. Because chatbot is unable to solve the problem. Again, the same thing, garbage in, garbage out. The second is that the privacy laws, which are regulatory bottleneck, and there are a lot of legal implications which are coming because of using AI. What happens if an insurance company get hold of these images? Okay, and that's another field, because many times they may misuse it and probably increase the premium or reduce the premium according to their own processes. Okay, so this privacy, because of these privacy laws, the implementation actually is not completely there. Then we also found that organization use so this is just a business model which organizations use. So I'm going to skip it. So here are some facilitators, various trends. So I'm going to talk about these facilitators which are facilitating the use of adoption of AI. One is use of AI robots in the hostile environment and their use in decision making. For example, now you can use drones, and using drones you can go to hostile environments, take images, bring those images back, use AI to analyze them and support the decision making. Okay, then cloud and AI adoption, facilitate the adoption of AI because it gives you a lot of space for storing your images. Cloud is basically all about space, and it also facilitates wherever you are, seamless AI analysis. Okay, then the third facilitator, which we felt that organizational culture that rewards innovation, top management support, strategic roadmap, and the availability of right training data, which is actually a hindrance so far, because when you do not have training data, then how do you actually get the right analysis? It completely depends on the previous data. There are also some barriers: complexity of the data, unavailability, security, quality, complex algorithms. And very important is this black box algorithm. We don't know what is happening in AI. How is AI actually giving results? So they use this neural network classifier as well as the support vector machines. And it's very difficult to actually put it in terms of a equation what this algorithm is doing. And because it's not so easy, it's very easy to fool others. And I will come to that, what are its implications in a few minutes. So that's one of the barriers. Then the second type of barrier is the resistance to change, fear of failure, infrastructure issues, misalignment between business and technology. And let's say as a patient, I go to a doctor and say, okay, doctor, I have faith in the doctor, but I may not have faith in the machine, an AI machine, for example. Now, it will take time for that faith to come in. Okay, so doctors may trust, but then they have to do the analysis themselves. There are privacy and security laws, lack of regulatory bodies. In India, as the regulations are far behind, and that's in general rule. Regulations are at least 5 to 10 years behind the technology. And then there are complex regulatory approvals and policies. Now, what we see the trends, in terms of trends, what we see is it's in many of the organizations, they are just experimenting with different AI tools. And they have some narrowed down on some AI tools and technology to use. For example, I have heard about AI taking a photograph of the eye and telling whether there's a possibility of cataract or not. Possible, a very, very simple one. So you just take a picture from a mobile. Now, how accurate is that? That is a concern, right? Then, of course, you need to have a lot of eye-based previous eye data to be able to correctly detect those images. Then move from automating repeated manual process to intelligent automation. That is what is a big trend now. And initial focus was, of course, on collecting data. Now the focus is on extracting intelligence, improving efficiency and productivity and personalization using AI. So these are the important trends. Earlier, collect the data. Now, how do we improve? How do we extract intelligence from that? So I'm just going to, these are some of the implementations of AI which is happening across. One is in the initial state, it was rule-based robotic process automation, which was very common in industries. And RPA has been very common. Now it is going to intelligent process automations where you probably do not need to interact with the machine. It does automatically. And you might see this in the warehouses of Flipkart where they sort the goods to be to be transported to their customers, and it's an automated sorting. Then there is in terms of this initial state pharmacovigilance area, manually obtain and enter data for pharmacovigilance. Now use AI to interpret natural human language and semantics. So that is quite happening. Then there are next area is earlier there were rule-based chatbots. Now AI-based chatbots. AI actually tries to figure out what is the question a person has, and then it tries to bring out the solution itself. So some of these are more in finance and segmentation. Then there's one manual interpretation radiology reports, and it was now classification of radiology images using computer vision for faster treatment. And ultimately, whether you have UAI or not, it depends on how the processes are implemented in an organization. Then the last one is manufacturing sector maintenance, and it's now prescriptive maintenance using AI image-based quality control. So these are in different industries, not only in medical science, but also in other industries where they're using AI, trying to make it more, you can see from taking the data, trying to extract some intelligence from it, and automating the process, not based on rules, but based on AI. Okay. Now, the second area which we are trying to do research on is about ethics, and we want to know what are the ethical issues that arise. Because when we talk about governance, when you talk about businesses, ethics becomes very, very important, and as it does in medical science. So here we have done some research, and some of the research we have is this. I'm not so sure what happens in this human brain project, but then there is a existential risk. And let's say you come up with that human brain, then there is an existential risk whether we will exist or not. And I don't know, it seems that many scientists, they do not really worry about this, whether human beings exist or not, because they just want to go ahead with their technological advancement. Okay, so, but then that is a risk because ultimately human beings have to live. Otherwise, why do you create technology at all? Then there is this medical radiation sciences. This is the domain where ethical issues faced by clinicians. This black box bias inequity, this black box algorithm, and I'll talk about that in a few minutes. Then radiology, again, potential job loss. Do we really need radiologists now? We do. That's not going to remove. Gastroenterology, these are all in medical science. Actually, I took from medical science. We've done in other areas also. So potential harm, cost to patients, accountability, decision-making bias, and workforce impact. So these are some of the ethical issues. Then in cancer screening, epistemic risk that reflect value judgment. So if you take an image, now the same image can be interpreted by different doctors in different ways. And many times you find that the opinions differ. What opinion will AI take? It will take the opinion of the doc or the person who actually created it. And it's possible that the opinion of the person may differ. So is it necessary that AI will always be correct in its judgment? Right. So nuclear medicine, there's another issue related to fairness, justice, safety, reliability, data. So many data security, privacy, and confidentiality. In the medicine area, again, it's again part of other things. So it's patient privacy and security, change in the fiduciary relationship between the physician and the patient. Now, earlier, you see this fiduciary relationship between physician and patient was very different. It was not commercial. It was more of a reverential relationship. So what happens when a person has images, know all about you, and it's possible that some other things may happen, which happens with many of these insurance companies. Unethical manipulation algorithms. So these are some of the dark side which we are looking at. In healthcare, again, epistemic related to misguided, inconclusive, inscrutable evidence. You see the report, AI gives something different. Algorithms are manipulated. So on. So I'm going to talk about that. These are some of the concerns which are raised by AI. One is bias in AI could occur when the machine discriminates against certain groups of people. Here is an example of Timnit Gebru, who was actually AI researcher, AI ethics researcher at Google, and she was fired because the Google algorithm was biased towards whites. And it was simple because the data was of white people, so it will be biased towards white. But then she was fired. Right now, whether it's correct or not, that's an ethical issue. So that is the bias which machines discriminate. So depends on what data you feed. Then as more and more consumer data is being used by an AI algorithm, the consumer might be unaware of the extent to which their data is being used for secondary purposes. Once data has, doctors are not going to control the data. Data will be controlled by third parties. So what happens? How they use it? Do they misuse the data? It's all possible. And we cannot say that Google and Facebook and Twitter, they are not misusing the data. It's impossible. They will. Okay. So I hope you were able to see my screen earlier.
Yes, sir.
Then, yeah. So the black box AI algorithm caused lack of transparency issues for the users. How can the users trust the AI system? And this is a very important issue. How would I trust an algorithm? Because it's a black box.
Sorry, sir.
Pardon?
You are already ahead of time. Kindly to conclude it quickly.
Just 2 minutes, right? Yeah.
Thank you.
So, and then it could cause job replacement anxiety. So this I have already discussed. So then my question are these questions. Google unbiased in search results. When you search, is it really unbiased? No, it's not. It's not possible. They do no evil. Twitter really interested in free speech? They have their own. These are all black box algorithms. We don't know. They say that we want free speech, but they do not. Similarly, is Facebook really neutral, which they're clamoring about? So when the algorithms are not clear, then they are going to raise questions about ethical issues. So that is our research. Our research is to adoption and ethical concerns. And from there, we are coming. And that's what I wanted to share with all of you. Thank you very much.
Thank you, Professor Gupta. That was a very interesting how India is adopting AI in healthcare and the various issues associated with it. So now the session is open for discussion. If there are any questions.
Chat box, madam.
Okay.
You can put your question in a chat box as we are now. We have another speaker with us. The next topic is artificial intelligence in pharmacovigilance, which is a continuation in the morning topic as given by Professor S. B. Dhaneria. Now may I request Dr. Manju Agrawal, Assistant Professor, Pandit Jainam Medical College. We welcome you, madam. Dais is all yours.
Thank you. At the outset, I must thank the organizers for giving me an opportunity to speak on this platform. Thank you very much. Today, I'll be speaking on artificial intelligence in drug safety or pharmacovigilance. So as Albert Einstein has rightly said, the measure of intelligence is the ability to change. And all of us are here since morning ready to change. I'll be discussing under the following headings of the need of AI in pharmacovigilance, the present status, available AI applications, the advantages and benefits, and its limitations. Since in the morning, we all had a lecture by Dhaneria sir on AI in pharmacology, and he has touched upon this topic. I'll be going into details. We all know pharmacovigilance is the science and activity relating to detection, assessment, understanding, and prevention of adverse effects related to drugs and devices. Why is it important? Because in the last 10 years of the beginning of this century, 71 of the 222 drugs approved by the FDA were either withdrawn, required a black box warning, or warranted a safety announcement about new risks. So, we had loss of resources because of these withdrawals. The need is that the pharmacovigilance data is very large and depends on human intervention for managing it. The WHO Global Database of Individual Case Safety Reports is the largest database in the world with over 20 million reports submitted since 1968. So use of AI will contribute to optimizing the use of these medicinal products with safety. We can use AI in two different stages. In the preclinical and clinical trial phase, AI will reduce animal testing. It will help us to develop computational models which will provide reliable toxicity prediction, reduce the cost and time. In the post-marketing surveillance phase, the operations will become more effective and efficient. It will lead to increased insight and help detection of signals and their validation. And it will increase the value for stakeholders because drugs will come with more informed labels. There will be better coordination between the pharmacovigilance and the regulatory authorities. And we will have safety literacy. You can see in this diagram, in the preclinical stage, two-thirds drugs fail because of the toxicity. And along with it, there is constraints of cost and time and ethical issues. Once the drug reaches the clinical trial phase, 1/5 of the drugs fail. And once they reach the post-marketing phase, almost 1/10 of the drugs are withdrawn. So there is lot of loss of resources and manpower because of these things. And we can save all this by using AI in pharmacovigilance. At present, the data is publicly resourced, and in countries which are adopting the electronic health records, they provide the data. Then this data is provided to the ADR monitoring centers, which process the ADR reports. So here you see the present method. A case is reported in the form of email or paper. It is sent to the ADR monitoring center where the seriousness of the issue is identified. The data is completed, and then missing information and corrections, if any, are done. And then a quality review of the data is done and a signal is detected. If we use the AI, what will happen? Once you receive the information using AI, which is of multiple types like machine learning, deep learning, natural language process, this will be handled by these processes, and the UI exceptional handler which is used will review the corrections and lead to increased acceptance. Then extensible machine learning will export the data to the safety system, and we will have a correct, consistent, focused, and highly efficient ADR reports. So, what are the methods of AI in drug safety? In the preclinical and clinical trials, we have the machine learning, which employ interpretable models and are of low order of complexity, but they predict drug toxicity, inform the mechanism of action. They predict toxicity which is diverse in patients of different places, and they aid in trial design and drug development. In post-marketing surveillance, use of deep learning technology, which are non-linear models and orders of high order complexity, use convolutional neural networks and regression neural networks. They give us a complete real-world data which does a good comparative safety analysis, inform precision modeling for patients, and aid in clinical decision-making along with regulatory decisions. Different types of machine learning approaches are there. At present, we have an open source toxicity prediction tool based on the quantitative structure-activity relationship methodology and is used for diagnosing or understanding the lethal dose, LD50, as you all know, developmental toxicity, if any, and can even perform AIIMS mutagenicity tests. We have other existing softwares like TajTox, Proctor, Hazard Expert, which all predict drug toxicity in the clinical trial phase. Using deep learning approaches, we can extract adverse drug events relationship, learn all toxicity effects in one neural network, and the accuracy of this prediction is 86% with 82% sensitivity and 92% specificity. This has been tried for drug-induced liver injury model. The other type of drug toxicity models available are artificial neural networks, convolutional neural networks, autoencoders, generative adversarial networks, and long-term, short-term memory approaches. We have, recently they have developed a software known as DeepTox. This is for clinical trial. What they did, they took drugs from the FDA repository. Almost 1,000 drugs were taken and analyzed on this DeepTox software for their drug toxicity and other adverse effects. On analysis, it was found that it was having a very good report because it had exactly told which drugs would fail in the clinical trial and which drugs would be withdrawn from the market after phase 3 trials. So this is it is still in the research phase. It is still not used by FDA for approval of drugs, but we look forward that in near future, DeepTox will help us to shorten the clinical trials and allow prevent withdrawal of drugs from the market. Other AI processes are natural language process, semantic searching, and software entities. Now coming to the pharmacovigilance in the post-marketing surveillance phase, the spontaneous reporting of ADR is done by the World Health Organization Program for International Drug Safety Monitoring, along with Food and Drug Administration Adverse Event Reporting System, and the Pharmacovigilance Program of India, which is run by the Indian Pharmacopoeia Commission. Individual case safety reports, which are specific documents for recording information, are processed with the help of machine learning and natural language process, and this is fed into a software known as Vigiflow. Vigiflow is a web-based individual case safety report management system maintained by Uppsala Monitoring Center in Sweden. It is used by the National Pharmacovigilance Centers. Data is collected and shared to this Vigiflow. It is processed there, and then from here it is reported to WHO in the form of Vigibase. It is not mandatory for us to report ADRs in the Vigibase, which is a global database. We can do an e-reporting from our own institutes, which is a very simple two-step procedure. You can create a link on your OPD or the homepage of the institute where you can write e-reporting link and inform your stakeholders, that is patients and your healthcare professionals, and use it for e-reporting. Medical College Medical College Raipur already has, we don't have an e-reporting link, but we have the national helpline number where one can directly report ADRs. The Vigibase is a WHO global database used by the WHO, not by the national bases. And it is linked to medical and drug classification terminologies such as WHO ART, MEDRA, WHO ICD, and WHO drug. These terminologies help us to generalize the data for all the nations because these terminologies are unique for all the countries. So this enables structured data entry, retrieval and analysis at different levels of precision and aggregation, and leads to effective and accurate analysis. Whenever we report any ADR or side effect which is reported for the first time, we call it a signal. Whenever a signal is detected, it is reported to the WHO database with the help of VG rank. It is used to detect serious ADRs, newly marketed drug ADRs, specific drug ADRs, and specific patient population side effects. Once a signal is detected and confirmed, then it is communicated to all the national pharmacovigilance centers with the help of VG-LISE. Now you must be thinking, can we use all these softwares? No. Only the ADR monitoring centers are authorized to use these softwares, but the public can access the software with the help of VG Access. You can log into the vigiaccess.org and a page will open where you can accept the terms and conditions, write the drug for which you want to know the side effects, and it will let you know the details. Let us see this. This is a VG Access website. You can enter the trade name of the drug here. So I have entered the name chloroquine. You can see the distribution of the parameters, like they will tell you what are the type of side effects, ADR reactions, its geographical distribution, age group distribution, the patient sex distribution, and number of reports generated each year. So you go further and you can see that it has detailed the different types of side effects, like the blood and lymphatic system disorders. 461 ADR reports have been generated till date. So this will help you to know what are the side effects, and you can, if you feel that the ADR you have come across is not mentioned in the list, you can add there and inform it to your nearest ADR center, and it will be processed with the help of VigiFlow. So what are the advantages and disadvantages of AI in pharmacovigilance? The advantages are that it expedites the drug approval and reduces the withdrawal time. So the process becomes fast for new drug discovery and development. The cost for processing or drug development is reduced by 50%. The reporting is accurate. It can handle diverse data. It can increase the workforce productivity because entering the data and analyzing is a highly time-consuming work. So if our experts are free, they can do a highly value work during that period. It reduces the risk and increase the benefits from medicines to enhance patient care. And it will allow us to move from reactive to proactive pharmacovigilance. So what are the challenges and the future? For AI to work effectively, it requires huge amount of data, and there is no regulation in place that controls what data should and should not be accessible to AI. We have to deal with patients' health information and personal information, which may be misused at times, so we have to think about it. It requires organizational and cultural mindset to adopt AI, so are we ready for it? There is problem with AI that there is missing empathy, emotions, and human connections. So we must be ready for it. But the future lies with digitalization and AI analytics and patient-centered data collection for overall drug safety. So we have to accept AI, but we have to be careful also. Thank you.
Thank you, ma'am, for such elaboratively and beautifully highlighting the importance of pharmacovigilance.
Thank
It was
you.
really very nice talk. As you can put your question in a chat box. Now, may I request Dr. Har Sakale to kindly give a token of appreciation to Manju ma'am.
Thank you. I was given only 7 minutes by Alok, so I had to do it short. Very nice. Thank you.
So the next topic, the interesting topic on artificial intelligence in lab automation. And to deliver the lecture, we have Dr. Seema Shah, Assistant Professor, Department of Biochemistry, AIIMS Raipur.
A very good afternoon to all. After a day-long academic feast on role of artificial intelligence in healthcare, at the end of the day, I will sum up all the presentations, and my topic is artificial intelligence in laboratory automation. We all know that lab automation essentially means use of automatic analyzers with minimum involvement of manpower. It uses various steps like sample acquisition, sample transport, reagent handling, then sample preparation, analysis by the system, data handling, and process control. Already we have so many steps in clinical lab which are already AI powered. So to sum up, we have flagging of lab results. That means whenever a patient samples is analyzed by a automated AI powered system, when the test results are beyond a defined reference range for that particular test, then that result is flagged. This flagging is based on what we call nomogram or lab defined reference range, which is specific for age, sex, or physiological condition of the patient like pregnancy and lactation. That means whenever we enter the patient details in the AI-powered automated lab system, then that report generation software takes up the patient details and brings up the correct applicable reference level only. And if the patient value is beyond that reference range, then that is highlighted. This saves the clinician from remembering hundreds of reference ranges for the hundreds of tests which are coming up day to day because of new tests are being added to that test menu because of the more emphasis on the evidence-based medicine. Similarly, this system can also calculate risk of development of various diseases like MELD score for developing end-stage liver disease, Q risk calculation, EGFR, Framingham risk score, and they can predict development of impending disease even before the symptoms really occur. Along with this AI-powered extraction of the data by the patient values, it can come up with a newer algorithmic tool which would be more specific for a particular geographical area for the patients residing in those areas because of the ethnic and the genetic variability. Now, we must know that analysis of a patient sample starts much before the sample is reached in the lab, and it starts with the process of calibration. So, the AI-enabled system will guide the lab personnel what is the time to calibrate, and if calibration is not passed, which steps in the complex analytical pathway has gone wrong, though it has not yet reached up to the level of the autocorrection, but it do suggest what are the error that might have occurred. The second step in diagnosis of analysis of a patient sample is quality control. So each of the lab throughout the world must assure that whatever test reports we are reporting, we are generating, it must conforms to the defined quality levels, for which we use various QC samples, we analyze it, and we put it in various graphs called Levy-Jennings chart, and we have different combination of Westgard rules like 1, 2S, 2, 2S, 70, 10S. So a combination of different rules are used for each of the different tests, and depending on the type of rule that is violated, we come up with what may be the error in the analytical system, whether it is random error, whether it is a systematic error, whether it is affecting more than one parameter, and so on. This picture shows a scenario which is not very uncommon for at least in India, when a VIP convoy disturbs a normal routine traffic. However, AI-powered stat prioritization means that when we receive an urgent sample in our lab and assign it the level of stat and puts it in the machine, then the machine analyzes this sample with lowest turnaround time without any chaotic disturbance of the already running routine test procedure. So AI powered system knows when to stop and which sample to stop, but momentarily. Inventory management is at the center of a continued lab services for any clinical lab. We all have seen the unpredictable situation that we faced last year when suddenly the less common tests like IL-6, D-dimer, ferritin, the demand of those tests skyrocketed. But we were struggling to fight for the reagent supply because of the suspension of the international flight and industrial lockdown. So here the inventory management software tool can really come to help, and it can predict what type of growth or what type of how much demand would be increased by reading the trend elsewhere in the world. Moreover, it can also predict which test volume will increase for a particular lab depending on the search trend and growth that it analyzes from the previous years. So we have additional steps in a laboratory which are being developed, not much in use in India, but we have robotic sample acquisition, which is much more precise than a manual phlebotomy with regard to depth of prick, that amount of sample draw, as well as the pain score. We have robotic sample preparation like pre-sorting, aliquoting, decapping, sorting into the analyzer specific tray, and all these processes, when AI enabled, reduces the turnaround time of all the tests. Now, if we talk about sample adequacy, all the clinicians must have faced a situation at least once in their lifetime when on the second visit of a OPD patient, they receive a lab report which says, report not generated as sample inadequate. That's a very frustrating situation, but manual processes in the sample draw cannot solve it. If AI-enabled process is used, then the sample adequacy can be assured right at the moment of the sample acquisition itself, depending on what type of test has been requested for that particular patient. So we have one or two systems in the market. One is from Atelica from the Siemens, which has this come up with this auto verification AI-enabled auto verification mode, where the patient reports are auto verified if it falls within the defined reference range, and it also takes into consideration delta check of that patient. So auto verification in one way will decrease the turnaround time, because around 60 to 80% of the lab reports are normal. Moreover, it will increase the quality and it will increase the consistency by removing the interoperator variations. And we already have defined guideline for auto verification also from CLSI Auto 10A. Then this diagram shows clinicians rushing within the emergency ward, and we know that there are systems in place whenever a patient comes in the emergency ward, a message is sent through pager to the concerned clinician, and they can run to the patient for immediate management. If the same thing is linked to the automated lab testing process, and whenever a patient comes up with a critical value like blood glucose below 50 or potassium more than 6, which demands immediate attention, then that critical value can be paged to that clinician and immediate patient management can be done. Moreover, AI-assisted lab-generated system can also suggest what additional tests should be done for a particular patient depending on how the parameters are altered. This will save frequent visit of the patient to the lab, and it will also omit the chances of frequent prick. So the future of AI in lab automation is towards making of a robo-scientist. So to conclude, AI-powered laboratory automation will improve the quality, efficiency, and correctness of laboratory reported results and would be instrumental in patient management. However, we must know that man created AI and AI can never replace the men, expertise of the men. Thank you so much.
Thank you, ma'am. That was a very interesting and enlightening presentation. So, any questions, again, will be there in the chat box. So, thank you very much. And I would invite Ekta ma'am to present a memento to her.
Thank you. I'd like to request Professor Alok Agrawal sir to kindly present mementos to our chairperson. Thank you. One important announcement is that online Google post-test form and a feedback form has been sent to all the registered delegate. It is important for everyone to fill up to get the certificates.
So, dear friends, I hope you must have liked this CME. We started at morning 9 with 7 sessions into it, starting with the introduction to artificial intelligence, applications of artificial intelligence in the field of surgery, pharmacology, limitations in healthcare, role of it in anesthesia, medicine and public health, perinatal depression, need for artificial intelligence as a panel discussion, followed by its role in ENT, radiodiagnosis, OBS and gynae, followed by its role in healthcare, in medicine, role of robotics, role of robots in orthopedics, in neurosurgery, pathology, pharmacology, pharmacovigilance, role of navigation in spine surgery, status of artificial intelligence in India, and its role in laboratory automation. As you are still there, if you want to ask any questions, you can unmute yourself and ask the question now. We still have our faculty online to answer the questions. Professor Sumit is here with us. Professor Dr. Saroj Chodamani Gopal is there with us. Anupam Singh is there. Arpana is there. Ajay Khanna is there. Okay. So without wasting much time, we should go for the valedictory function. May I request Dr. Sarita Ramchandani to come on the dais. Professor Dr. Amit Chauhan, please come on the dais. Dr. Ekta Khandelwal, please come. Dr. Bikram Keshrikar, please come on the stage. Dr. Harshal Sakle, please come. Dr. Amritva Ghosh, Dr. Seema Shah. So, are there any more people from the committee present here, from the organizing committee? So, dear friends, it has been a hectic day. The whole committee has been working from morning to evening for the last 3 to 4 months, and working during pandemic has been very difficult. I'm thankful to the committee sitting here. I'm also thankful to Mr. Varun Pandey, Chandrabhan, and the IT team. I'm thankful to Avinash and his team for the computers. I'm thankful to Mr. Manoj Rastogi, our executive engineer, electricians Piyush, Devangan Sab, and others who have been working here and making this function a success. We have got with us Professor and Head Department of Orthopaedics with his whole team sitting here, Dr. Satyendra Puljale, sir. Sir, please come and have a seat. And then there is only one more faculty sitting in the hall, that is Dr. Momita and Dr. Manju Agrawal. You have to keep there because there are no chairs here. Does anyone want to speak something? Any of you want to speak anything about your experience of the training, of lacunae, of the good parts, so you can mention. If not, then there have been the Department of Orthopedic boys working from the morning, and I would like to definitely thank them for their work. May I request Dr. Ankit to come here and Amit Chauhan sir to present him with a registration bag. Although we had a registration of more than 625 people, but there were 110 people in this hall as a conference in hybrid mode. And even the engineers which are sitting with us must be knowing that they have also learnt a lot. May I request Dr. Sarita Ramchandani to give a bag to Rudh Pratap Das. May I request Dr. Ekta Khandelwal to present a bag to Dr. Anupam Inamdar. May I request Dr. Amritva Ghosh to present a bag to Dr. Shubham Sharma. May I request Dr. Vikram Keshrikar to present a bag to Dr. Shubham Bharadwaj. May I request Dr. Seema Shah Madam to present a bag to Dr. Pandya Rajan. May I request Dr. Harshal and Dr. Satyendra Puljale both combine to give a bag to Dr. Dikshant Saini. There are many more bags remaining with us and lot more boys also waiting here. But this is being just a token, and all of them will be getting their bags and mementos and multiple further trainings to come in future. Is Dr. Saroj Chodamani Gopal Madam still on the computers? Madam, are you still there? So if no one wants to say any more, with the permission of Madam Saroj Mani Gopal, President, National Academy of Medical Sciences, I close this CME. Thank you. Thanks all. फोटोग्राफ ले लेते हैं
पता तो चलता है
लो मास्क को भैया और ऊपर चल जाओ आप सबके फेस पे स्माइल होनी चाहिए